Okay, it's 9 o'clock in the morning. I think we should start on time, and I see Liwa is already standing by in Hong Kong. Let me open the session and welcome everyone to Singapore and to our fellow co-hosts in Hong Kong. Good morning as well in Hong Kong. So my name is Jack Tan, the chair of the Singapore Cardiac Society PCI chapter. And I just want to narrate a short story. This big symposium, I started organizing it in 2019 for 2020 event. And you guys know what happened. The big symposium was very successfully done in Hong Kong prior, and they wanted to rotate. And I was planning a big meeting, I would say, in 2020, and this was deferred. And we discussed many times and delayed to today. So this is really one meeting that I've been organizing since 2019 to have it in 2022. So thanks to everyone for coming today. My co-endorser will be Dr. Wen-Lieng, the president of the Taiwan Society of Cardiovascular Intervention, and Dr. Tam Liwa, the chair for the Hong Kong Public Hospital Cardiologists Association. And now I'll pass over to Dr. Lee for his opening remarks.
Well, good morning, my friends, either sitting here in the floor or on the line. I'm Dr. Wen-Lieng from Taiwan, and I'm the current president of Taiwan Society of Cardiovascular Intervention. I'm so grateful to Dr. Jack Tan for the invitation, and also let me have the honor to be one of the hosts. I'm so pleased thrilled today to see so many of you. I know some of you are my old friends, and some of you are my new friends here. I think over the past few years, you know, Taiwan doctors, colleagues are very good at interventional skills. However, we are lagging behind in the new devices like the mechanical support or the IVL. So over the past few years, we have more and more interactions with our friends from Hong Kong and in Singapore and in other countries to have sharing cases, experiences. I think this is one of the reasons that the big symposium will held here to bring us together to such activities. I think after today's meeting, I think most of us will learn new things and update our knowledge so we can provide updated service to our friends and create a win-win situation. So thank you again for coming here, and thank you, Dr. Tan, for holding such activity. Thank you.
Liwa, your remarks, please.
Okay, good morning. Thank you. Thank you, Jack. And Dr. Lee, thank you very much for having this very educational activities held again. So on behalf of Hong Kong Public Hospital Cardiologists Association, I also extend my warmest welcome to all of you, especially for the audience in the Singapore. They can attend the physical meeting. But in Hong Kong, most of our cardiologists still need to attend it through by a virtual platform. But we are very lucky that still have some colleagues arrived in the hotel in this physically meeting and in this hotel. So I hope that this will continue to be evolved, that we can have a more physical, contact, physical meeting, direct communication or sharing between us. So you can look at the program. Actually, this big symposium started many years ago in Hong Kong. So that time, the aim is to, sharing of international experience amongst colleagues in Southeast Asia. So that was a really very good and educational meeting in the past. So unfortunately, this years for the past few years, we can't organized it because of the COVID, but we are very glad that this meeting coming again. So we are really looking forward to a very educational meeting today. So welcome again. So I hope all of you will have a very enjoyable and educational meeting today. So thank you.
Thanks, Liwa. So I hear the consistent theme friendship and learning. So beautiful messages from Dr. Lee and Dr. Tam. It's a very small, cozy meeting, so I would like it that it's very chillax. Let's do it easy, and if there's any question, just raise your hand, approach a mic, and ask away. And let's keep it very, very interactive and light. So the first session is a STEMI/COVID session. I'm the moderator with Liwa in Hong Kong. And with me as a panelist, we have Dr. Chichareon from Taiwan, Dr. An from Vietnam, Dr. Fly from Thailand, Raymond Fang from Hong Kong, Dr. Kang from Korea, and Dr. Yuli from China. The first talk is, so let me just briefly state the objective for this morning's opening session. We want to briefly discuss the latest STEMI management treatment algorithm updates based on the recent clinical trials and studies. And of course, if you disagree with the guidelines, the trials, the results, please feel free to discuss those as well. We want to then also learn how STEMI intervention have changed or should have occurred in patients with COVID-19 infection. And I think in Asia, we are used to SARS, and now we are COVID-19. My infectious disease experts tell me that the next pandemic usually is about 7 years away. If you look at intervening from SARS to COVID-19, there was H1N1, H1N5, MERS, Ebola. So you predict that the next round is 7 years, which is pretty fast. So I think as interventional cardiologists, we need to really know how to deal with STEMI intervention in the COVID pandemic environment or any pandemic environment. So I think this learning, hopefully, it will be less stressful the next time we come towards another STEMI in the pandemic. So to start off the lecture, we'll have Patrick Lim, who is head of department at Khoo Teck Puat Hospital, to give us the latest clinical update in STEMI management in 2022. Patrick, please.
Hi, good morning. Thank you for the invitation. Thank you to BIOTRONIK. Good morning, colleagues and friends. So I've been tasked to talk about the latest update in STEMI management, which is quite broad. So I'm narrowing down to perhaps only the non-infarct related artery stenosis and what we do about them. No disclosures of note. So hopefully they'll flow quite nicely. Go through the trials from primary culprit complete. What types of lesion subsets are we talking about, and timing of when we treat them based on the trial. And after that, looking at the value of FFR, IFR versus angiogram only, and then hopefully that ends up with the recommendations and how the recommendations came about. So if I talk too fast, I just slow me down. So primary the word was preventative revascularization. So preventative, the lesion subset were anything more than 50% stenosis. It was PI initiated, UK, 5 sites, 465 patients. And the treating physician has to feel that the lesion could be treated equally with medical therapy versus PCI. So left mains osteoids were excluded. So non-culprit lesions were done during the index procedure at the same time. And the primary outcome, although is cardiac death, MI, and refractory angina. So I summarize the results. So 60 years old, males, well, no shock, blood pressure all good, and they met the primary outcome. Culprit, also PI initiated, UK, 7 sites, smaller numbers. So this time they changed the non-infarct related artery stenosis encouraged to be treated during index procedure but not mandated. Those that were not done during the same index procedure will normally do no reflow. So primary outcome again was MACE, but the MACE was defined as all-cause mortality, MI, heart failure, and repeat reverse. Again, primary outcome was met. Again, males, 60s, and they had modest amounts of infarction with a troponin of up to 1,000. And EF was 45%. So small infarcts, males. MACE met, all death, MI, heart failure, repeat reverse. So 2 trials, both small numbers, led to complete. So complete was 4,000 patients across 31 countries and 140 centers. So just not limited to the UK only. And it was done straight after the release, so 2013, 2017. This trial introduced the concept of FFR within for the moderate lesions. So 50 to 69% stenosis were interrogated by FFR wire, but the number was very small, less than 1%. So stage PCI was done either before discharge, or the latest one was up to 45 days. They achieved complete reverse in 90%. And the answer that this trial wanted to, the trial wanted to answer was whether there was hard endpoints of MI or death. So which is why the first primary outcome was composite of MI or CV death. Whilst for the second primary outcome was just in case they couldn't meet it, they added in the ischemia-driven revascularization. Unfortunately, both met. So the interesting bit for me was, what size of the lesion? Where are they? Circumflex included or not? Can we put in a 2-5 stent and circumflex doesn't make sense? So again, look at the syntax score. They're low. They're 4.6 to 5. So these are the non-infarct related artery stenosis, low syntax score, relatively large vessel, about 3 millimeter vessel size, and they were scattered everywhere. Circumflex, LVD, RCA. Again, so met the primary outcome, both CV death and MI, but also CV death, MI, and ischemia-driven reverse. So then the next goes to the next slide. So I think this hopefully answers the straightforward non-infarct related artery, low syntax score, relatively large vessel, more than 2.8 millimeters vessel. They would benefit from reverse to meet the primary endpoint of MI or death. So then summarized it, but should be okay. So does FFR help guide treatment for non-infarct related artery? Dynamic 3 primality, so 6 to 7 patients, 1:1 randomization between the FFR guided versus culprit only. Met the primary endpoint, which is all MACE defined as all-cause death, MI, ischemia-driven revascularization, but also driven by ischemia-driven revascularization. Compare acute, so 2:1, so 295 underwent FFR, got a revascularization for any stenosis more than 50%. Met the MACE. MACE this time is defined as you see the recurring theme. MACE kept changing across all the different trials. All-cause mortality, MI, reverse, and stroke. And they met the primary outcome, and again, driven by revascularization. So what was flower MI? So by the time flower MI came about, you already had infarct-related artery stenosis based on angiography that they did equivalent or better than just leaving it in medical therapy. And so the trial was done to assess whether FFR provided additional discriminatory value above and beyond just plain old angiography. So 1163 patients divided into 1:1 in either via angiographic guidance versus FFR guided. No significant difference between FFR guided versus angiographic guidance. So hopefully that, and then that go. Then how about if we do IFR? So that's a bit hard to recognize, but so IFR was done in so STEMI patients, 120 patients, 157 lesions. IFR done immediately, and also at a median of 16 days, so ranging from 5 to 32 days, the IFR was repeated again. So the top right box, so negative at post during the index procedure, and subsequently reassessed again, they remain negative. Bottom left box, positive after index procedure, and positive after interval period, and that was a 78% agreement. I'll leave it up to you to decide whether 78% agreement is a good enough number for you to decide or not, whether you should offer someone reverse. So that was IFR. So hopefully I answered FFR, IFR role in non-infarct related artery. What should we do in shock? So, well, just going to focus on the most recent and exclude the previous ones. So culprit shock. So 706 patients, I think all know about this trial, including the AMI shock, they have multivessel disease, they have the tissue hypoperfusion, pulmonary congestion, and then CTO attempts should be undertaken if you're randomized to multivessel PCI, but try not to be excessive. Contrast load less than 300 mils, although one case did exceed 300 mils. And the primary outcome was all-cause mortality plus need for renal replacement therapy. Again, trying to pick up the thing. So these are slightly older patients, they're 70s. They were also predominantly males again. They had 1/3 two-vessel disease, and the other 2/3 were three-vessel disease. They were in shock. 80% were intubated and 25% required mechanical support, though it wasn't clarified as to which type of mechanical support they were offered. And only 86% achieved T3 flow for various reasons. So we all know the left side, which is the outcome at 30 days. Primary outcome was met for both, which is that death and renal replacement therapy showed that culprit lesion revascularization perhaps was better than trying to do everything at the same time. But this trial was then followed up to 1 year and published a year later by the same group, and showed that although the number of deaths was still numerically higher within the multivessel PCI group, it's not lost its significance. Similarly to the renal replacement therapy. And then looking at how the curve stopped separating after the acute event, above and beyond the 1 month crossover 17% from the culprit lesion only PCI. What does it tell us? Not too sure. So post-hoc analysis. So looking at the groups that did the worst. So if you have left main LD disease and you underwent multivessel PCI, you do badly. If you do it acutely, which is the only thing that I can take away from this. But I mean, there's a lot more data, but perhaps that was the main thing that came out to myself. So that ties in very nicely to the guidelines and recommendations. So ACC guidelines was 2021. So all the trials have been published. So quite straightforward. If you are well, you should be offered stage PCI to reduce the risk of death and MI. So that's based on complete. If you have complex disease, which is not studied, so back to baseline, offer CABG because it's not studied. If you are stable hemodynamically, which then goes back to culprits and primary, could be done at the same time. And then harm will be STEMI complicated by the cardiogenic shock. Routine PCI should not be done. And then the caveat was that it led to higher risk of death and renal failure. So I guess this was taking from all the trials and the primary outcomes and then coming out with this recommendation. The ESC was slightly earlier, 2018. So the guidelines was a bit more ambiguous. So 2A, so routine revascularization before discharge. Bypass again was still offered for those with complex disease. And in C-shock, routine revascularization should not be recommended. And then come back to me, that was answered previously. I do have one or two more slides, but I'll stop for now. Was there any discussion or questions from anyone?
Thanks, Patrick. That was wonderful. Actually, it's quite a good review of quite a lot of trials. And in my mind, it answered the two main categories. One is when should you do the non-infarct related artery at the index event? When should you do? How should you do it with physiology guided or not? And the second big question is what to do for multivessel disease in the cardiogenic shock patient. So these are the two big categories translated into guidelines. Maybe I'll ask my remote panelists first from Hong Kong and Taiwan. In Taiwan, we have Dr. Chang, I believe, from Taiwan. Has all these guidelines trials influenced how non-infarct related artery is performed in Taiwan? Is it done during the index STEMI, inpatient, or stage as another admission? Dr. Chang?
Before the trial of Capri shock, I think very often, I mean, in Taiwan, many interventionists try to treat most lesions during the prime PCI procedure to expect complete revascularization and later translate into better outcome. But after the Capri shock, I think the way that we treat has changed. But I personally think that it's quite depends on the experience of the operator. If you have a short tie stenosis, for example, at RCA LAD, and you think you can treat it with a very simple procedure, I will still treat it. Of course, I think it's very hard to define what kind of experience should do what kind of lesion during prime PCI for non-carpal lesion. But I do think, yeah, we should judge the difficulty, the potential complexity or complication for those lesions. As I know, in Capri shock, they even treat CTO lesion during prime PCI. I think that's quite unreasonable. So if you treat those lesions, you may use a lot of contrast, which may later contribute to worse renal outcome. Yep. Thank you.
Thanks a lot. Dr. Kang, maybe I can get an opinion for you. Very interesting to me, what the results surprised me was the Flower MI trial, which shows that FFR guided didn't really change anything for AMI subset based on angiography. Do you think it's because it's the FFR rather than IFR or QFR? Or do you think that in the AMI subset, the non-culprit lesions are actually also vulnerable? What do you think of the Flower AMI trial?
Actually, I did not visually study for coronary region. So usually based on the angiography imaging, I did a PCI for AMI patient to a carpal or non-carpal region. So in the stable coronary stable coronary syndrome, so the FFR data, visual data showed a good result compared to image the coronary angiography. So I expect the visual results such as Flower AMI that show us the result. Actually, I don't know.
Yeah. So what you're doing seems to be backed up by the Flower AMI trial. Angiography alone seems to be okay. But in Korea, you do a lot of IVUS, right? So do you do IVUS in the acute AMI setting as well?
I think the half and half. Yes. So for usually for study. So some physicians prefer IVUS study carpal region and non-carpal region. So out of 50% do not do IVUS study for AMI. Yeah.
I think there's some value, but in terms of this region, our IVUS uptake is still very low. Dr. Yueli from China, to me, it makes a lot of sense that if you have non-culprit vessel, favor China 2 was just published. QFR seems to work quite well. Are you guys using a lot of QFR in the non-culprit vessel assessment rather than the invasive FFR in China?
So strictly speaking, the voice is not very clear, but in my opinion, in our clinical practice, for the primary PCI in most conditions, we only treat the culprit vessel. Certainly, this is depend on if the non-culprit artery contribute to the hemodynamic unstable. And for the patient with like cardiac shock, we often use hemodynamic support like ECMO and sometimes we both use ECMO and IBP. And as to the QFR, so certainly is very useful method could calculate the functional of the artery, but just like the flower MI study showed us, for the ACS patient, for the lesion we treated it or not, we should not only depend on the functional results. We should based on the imaging results. If the lesion is very unstable, we should pay more attention. Like if the lesion is TACFA or OCT sometimes may show us if the lesion with inflammation, etc. So I think for the ACIS patients, both the imaging and functional method is very important.
Thanks, Dr. This session, we practically gave a lot of time so that everyone can ask questions. If there's anything you disagree, you want to discuss your raise, please just approach the mic and ask away. Can I ask my local panelists here then in Thailand, when do you do your stage PCI? Do you do it in hospital, like what is recommended, or is still as a stage procedure?
Yeah, in my institute, I think it depend, and my practice is depend on the severity of the non-carpet lesion. For example, if the non-carpet lesion has a really severe, let's say, subtotal occlusion, and yeah, we do the stage procedure before patient was discharged. But in majority of the patient where the lesion is not so severe, maybe we bring back within 1 month. But in very few cases that we treat patient according to the PRAMI, because you know, the multi-vessel primary PCI, I mean, treat the non-carpet at the time of the primary PCI, have a benefit on the bed utilization. Let's say patient came in during the daytime, and then we have a limited source, and we evaluate that the non-carpet is not so complex, we treat at that time.
Thanks a lot. Liwa, is Raymond with you in Hong Kong? Is the topic of cardiogenic shock is actually the most tricky, I think, when you encounter in a primary STEMI environment. What is your, the guidelines say routine complete revascularization in cardiogenic shock shouldn't be done. So in your mind, Raymond, what is considered non-routine that is a circumstance that you guys are doing in Hong Kong for complete revascularization in cardiogenic shock?
Right. Well, I think I can't represent Hong Kong, but I just talk about myself. Okay. For me, I think for patient really came in with severe cardiogenic shock, then for me, I think most important thing is open up the culprit vessel as soon as possible. And a lot of time you need to, open the vessel and also put into the hemodynamic support device, and it takes a lot of time. So for me, depends on what's non-carpet lesion like. Most of the time, I don't think I would touch on the non-carpet if I think that's not the major problem causing the shock. But of course, like other speaker, I mean the panelists today, it depends of the situation. If I think if I think the other lesion is important, and then if the patient is shocked and he's stable, and probably I would just quickly do the non-carpet as well. But most of the time, I don't think I have the luxury to do all of them. Okay, so that's why I think I still support the guideline suggestion of just focus on the culprit vessel. Yeah.
Doan from Vietnam. I know mechanical circulatory support, we talk about it. It's actually quite an evidence-free zone. What type of support, when you should put in. In Vietnam, what do you do for a patient who comes in stage D, for example, like incorporate shock, intubated, inotropes, triple vessel disease? What do you do in Vietnam?
Actually, until now in Vietnam, we just only had the IBP and the ECMO only. So the patient, if the patient would admit just only the stage B or C, we do ABB first, and to open the population next. But actually, there's some the very severe patient or stage D or E, or we have and the title we have no choice, and we also do the same with so correlate with the ECMO. But based on the time, the patient, the time duration of shock, and also the coronary anatomy also affect the patient mortality. Until now, I think is the mortality is still high, but until now we have no choice, and with the ECMO and ABB.
We still have a mechanical circulatory support session coming up, so we can discuss a little bit more there. Yes, please, comments.
I have to comment at the first, the non-complete region, FFR guided non-complete region PCI. Our group, I'm Wen-Lieng from Samsung Medical Center. Our research group, SMART group, present ESC breaking session named Frame AMI trial. Frame AMI trial showed the FFR guided non-corporate PCI was associated with good clinical outcome, particularly all-cause death or recurrent myocardial infarction. Will publish in next issue of European Heart Journal, and contrast to the pro AMI, our finding suggests the non-corporate PCI, FFR guided non-corporate PCI will be improve clinical outcome. So this issue is ongoing debative issue. And second point, national CAS database from US, MCS under support of MCS, the multivessel PCI was associated with improved clinical outcome in the setting of cardiogenic shock. The other data, NCSI, National Cardiogenic Shock Initiative Group, Detroit group, improved impeller supported PCI, multivessel PCI, clinical outcome was similar to cardiopulmonary PCI group. In our data, Korea Multicenter Registry, Rescue Registry, multivessel PCI was associated with improved clinical outcome than cardiopulmonary PCI in a setting of patient underwent VA ECMO. So multivessel PCI versus cardiopulmonary PCI is an ongoing debatable issue.
No, okay, can I hold you there for, let me ask you a few questions. Thanks for chipping in and raising those points, especially in Korea. I know you guys, Samsung Medical Center, for example, is doing great studies. For the difference in what you presented in your study for physiology versus the Flower AMI trial, it shows no difference. Do you think it's a matter of the type of physiology study? Do you think it matters if it's IFR versus FFR? What in your study, was it FFR? FFR. Is there an advantage of FFR versus IFR? And do you need to do more index in AMI, for example, IMR and other indexes? You think, does it help in AMI setting?
We only perform the FFR for the non-corporate region PCI. In other respect of intravascular imaging, I know we have only one data regarding comparison between IVUS guided PCI versus angiographic guided PCI from Gamma registry. So the further future trial will be performed to confirm the benefit of intravascular imaging or physiology guided PCI.
So I congratulate the Korean group. For example, I recently saw the recent presentation by Professor B.K. Koo's group in the stable subset. IVUS versus a physiology-guided multi-vessel PCI. I think it's a flavor trial, and they show not much difference in terms of outcomes. Both seems to do quite well. It's just that you end up with more stents, longer stents in IVUS guided versus physiology guided PCI. So, like you said, I am also not 100% convinced that there is a disadvantage of using a FFR or physiology guided in a non-corporate vessel in a multi-vessel setting AMI. But I'm the one uncertainty I have is that in the AMI setting, when you're using FFR and some form of hyperemic agents, it may cause some adverse events in the AMI setting. So maybe a resting index like IFR may have some advantage. I'm not certain. The multi-vessel one, I feel even more space for investigation. The Detroit studies and all these other studies are firstly centers, like for example in Korea as well, where you have a very specific protocol. You have a shock team approach. You have a lot of devices at hand and a lot of multidisciplinary team discussion. I think that is the one that helps more than just a revascularization strategy, I think. Yeah. Thanks for your comment. Yeah, thank you. Any other comment from the other panelists before we sum up to move on to the case discussion? Yes, please.
Yeah, I want to add something that when we use the FFR, IFR, the points we assess the ischemia, right? But we know that, for example, from the sub-study of the complete trial, they show that in the non-carpet lesion, majority of them were vulnerable. And we know that sometimes the vulnerable plaque did not provide ischemia. So basically the IFR or IFFR may miss that kind of lesion in the future. Maybe like you said, maybe we need the information about plaque vulnerability to guide the treatment. And if we have the stent that quite safe and can modify that vulnerability, maybe we'll add the benefit. And yeah, so maybe we don't need to routinely stent the patient. And we know that some patients doing well in the selective strategy. Yeah, majority of them did not have MI. So, and we now have the medication that can deal with the inflammation to reduce the risk. I think in the future, we need maybe more information from imaging.
Thanks, a great comment. That's another point for discussion. I think FFR has reached its limit of ischemia guidance. So vulnerable plaque is another big area of plaque burden for speculated vulnerable plaque. That's where we may go in the future. So I briefly sum up the first session first before I go to the case base. I think what was great about PREMI and CULPRIT, although they're underpowered trials, is that they point to a direction that previously we were not looking at, which is complete revascularization. And with complete, actually we're quite certain that you need to fully revascularize rather than wait for a ischemia or symptom-guided strategy in a post-AMI space. Now the other trials are a bit more confusing. Flower and the rest followed to say whether physiology-guided in a complete revascularization, is it valid? In a Flower, they failed to prove the hypothesis in the low-risk subgroup. In Asia, it may be different because our disease subset is very diffuse. So if you got diffuse and you're differing more, maybe there's more benefit. If it's very clear-cut, angiography will tell you the answer. And there may be a component of vulnerability there. I want to quickly go into culprit shock study. In the shock space, unfortunately, it's a bit difficult. But the culprit shock study was good because the shock in that group was truly class stage CD shock. 80% intubated, very sick. I think that we still don't have a grapple on managing shock in a STEMI group because we're not sure whether revascularization strategy is the one that saves patient. I'm not certain that's the case. It's not dot balloon, it's not revascularization, but it's probably shock management. So in terms of shock management, we still don't have an ideal way of a shock protocol, what type of devices should be used. The devices have all not proven to improve survival, actually. And we do know that if you can have complete revascularization, maybe they benefit a bit better long-term based on earlier studies. But if you look at the culprit shock, I was surprised that at 1 year, the curve did not separate for those who achieve complete revascularization. So I'm still not too sure in the shock STEMI subgroup. So with that, I think there's more space for guidelines to change. Our intervention guideline is very bad compared to other suspect like heart failure, level 1 evidence. Our guidelines seem to flip every few years. So we'll still wait for more trials for the STEMI shock subgroup. So we'll move on to the case presentation. And I'd like to welcome, thanks Patrick, great presentation. I'd like to welcome Dr. Chu Chong Mao from Kota Kinabalu Gleneagles, Malaysia, to present his most memorable STEMI COVID case intervention.
Thank you. Very good morning. Thank you for the panelists for the kind introduction, and thank you, BIOTRONIK, for bringing me all the way from Sabah. So, no disclosure. This is I'm from Sabah, and Gleneagles Hospital is a private hospital, so we don't actually manage COVID patients. So you can see that it is sort of memorable for me. Okay. So this is not the patient, is some random picture I took from the internet. Okay, just to show Kadazan, Sabah, and okay, 35 years old young man who came to me with a complaint of chest pain. You can see the dates on the 4th of November 2020, about 2 years, 2 years. And the pain was started about 7:30 in the morning. It persisted until about 11. And he went to another center and they gave some GTN and resolved. So he came to my center about 3:30 in the afternoon. And a background history of dyslipidemia, nothing much significant. Ex-smoker, stopped about a year ago. And funny thing is, he was in contact. He was diagnosed of COVID, uncomplicated COVID, about a month ago. Okay, at that time, in Malaysia, everybody is quarantined for 14 days. So he was quarantined in the center, not in the hospital. So it's sort of uncomplicated. Yeah. Physical examination was unremarkable. Blood pressure 120, 70, blood pressure, pulse rate, and he's febrile. Okay. So this is the EKG. I want to show the ECG. You can see there's a Q wave in the lead 3 and FEF and a T inversion as well. Okay. The blood test, the full blood count was normal. Cholesterol not bad actually. It's not diabetic. Troponin is 430, clearly raised, and the cardiac enzyme, the CK is raised as well. Renal profile, electrolytes are all normal, and repeat COVID PCR test as per routine, which is negative as well. So the diagnosis was made as a non-STEMI at the point of time. Okay, so I mean, what we do, everybody do the same. We did an echo. You can see the airway function is preserved. Parasternal long axis, short axis, and epicardial four chamber views are all normal. There's no dilated chambers. There's no evidence of endocarditis in this echo. So of course we bring the cath lab. Okay, this is the angiogram. Radio, 6 French sheet and 5 French catheter. You can see the angiogram pretty normal. Only the distal part of the circle. You can see a moderate lesion, I would say 40 and 50%. And the right side seems to be normal. So would you treat this lesion? So I did not. So because it's not the territory involved, that doesn't correspond to the EKG, and the area involved is pretty small. So I give you a benefit of doubt medical therapy. Yeah? So he was started on dual antiplatelet, beta blocker, and he's on fondaparinux and lipitor-fusterol. So just in case some kind of microvascular dysfunction, yeah. So I thought that was the end, and then he will be happy and discharged home. So day 2, so this is on the 6th of November at 9 a.m. He presented with chest pain again. You can see this is the EKG, and the pain, I cut out the pain score, actually 2 to 3 pain score. You can see there's distinct ECG changes, ST elevation in 2, 3 AVF, and it's territorial. Yeah. So I just did a bedside echo, nothing much significant. Every function is still preserved. The blood pressure a little bit lowish, heart rate 60. He was never tachycardic. It's something that I noticed. It was never tachycardic. Saturation is 100%. So what do you do? Most of us will bring him back to the cath lab again to just have a look, right? I think so. Yeah. So bring the cath lab again. Again, radio, diagnostic angiogram. The right side was I did radio and I used the Ikari 3.5 as a diagnostic and PCI. You can see the left side was okay, and the circ remains as it is. Okay, but I think the catheter ran right into the right RCA, quite deep throating the RCA. So I changed the catheter to a JR. Okay, as a result, there is lesions in the proximal RCA. So is this a culprit, or is this just something because of the spasm because of the catheter? So what I did is, routine heparin, wire through, give some isocat or GTN, and the lesion sort of improve. So by this time, knowing the fact that he had some kind of COVID about a month ago, so knowing that there is an increased risk of venous and arterial thrombosis in this subset group of patients, so I actually try to aspirate and see whether some clot came out, maybe some kind of distal embolization or something, I'm not sure. I do not have IVUS. 2 years ago, I don't have IVUS. So I think probably IVUS will have a better picture to see whether there's any plaque rupture and things like that. But unfortunately, I don't have IVUS at the time. So again, the aspiration did not come out with any clots. So I will just leave it as it is. Yeah. Unfortunately, the granula dislodged, and we have to put in a triple lumen for inotropic support at the time. Yeah. So after the angiogram, the diagnosis have changed to some kind of myocarditis. Okay, so you can see that the EC changes remain similar. ST elevation and inferior leads. Patients still have chest pain. Blood pressure is still a bit low. So immediately we repeat the COVID PCR again. And I add in a respiratory panel. These respiratory panels include the other rest of the viral infection, for example, influenza, Coxsackie, respiratory syncytial virus, and I think enterovirus also. So all came back negative. So this is a summary of the blood test. You can see that troponin and CK definitely increased from day 1, day 2, and day 3. Unfortunately, the day 7 is down there. In 7th of November, it came down. So the inflammatory markers, this is something interesting. The procalcitonin, CRP, ESR are normal. So what do you get of this? So you get some kind of myocarditis without inflammation. So the D-dimer, I did some D-dimer, and I referred the case to my infectious disease specialist, and I call my respiratory guys as well. So all suggest to do some kind of imaging to rule out pulmonary embolism. So you can see the respiratory panel there, so all negative, and the repeat PCR for COVID is also negative. So this is CT pulmonary embolism. There's no PE seen, and the CT thorax only shows some kind of fibrosis, probably as a result of COVID infection about a month ago. So at the point in time, it's still a dilemma. Is it a myocarditis? Is it some kind of ACS with kind of plaque rupture or something? So 2 years ago, we don't have much of information, and we don't know much how we're going to treat this condition. So, of course, we have, fortunately, we have cardiac MRI. So we did a cardiac MRI. So what it shows is biventricular LV function, RV function is normal. Okay. The second point is that there is evidence of scarring, which points towards some kind of myocarditis about a month ago, because there's already scar. And in the STIR image, okay, again, there's evidence of myocardial ischemia as well. I don't have a pointer here, but you can see the STIR image. I'm not cardiac MRI trained, so that's what my colleague told me. There's some kind of edema at the basal segment when you look at the STIR image, and there's evidence of pericarditis as well. So the overall impression from this MRI is that he had some kind of acute or subacute onset of myocarditis. So the differential diagnosis will be sarcoidosis based on this, but the CT scan did not show that he had any sarcoidosis. Okay, so again, it still doesn't tell you. You can clearly see there's dynamic changes in the ECG, and there's no lesion seen in the angiogram. And knowing the fact that there are higher risks of thrombosis, venous or arterial thrombosis, how are we going to manage this? So the benefit of the doubt, looking at the guideline, they also suggest to treat, to give patients with COVID with low molecular weight heparin, and therefore the founder paradox is changed to heparin, low molecular weight, and started on hydrocort, just treat for the myocarditis. Of course, I involve my colleague, ID, infectious disease and respiratory physician. I actually called Tan Tok Sing also, my colleague in respiratory. So ask about whether they have come across this kind of condition where you have COVID, and then after that, some kind of myocarditis, stroke, some kind of arterial thrombosis, I don't know. So with the absence of CT pulmonary embolism, and sarcoidosis, so the ID suggests starting the patient on dexamethasone and anticoagulation. This is what they recommend to me now. So fortunately, his pain resolved after about a week, and cardiac enzyme is downtrend. There's no arrhythmia noted, and EF still preserved. So this is the ECG right before he is discharged. You can see again the Q wave, the inversions in the inferior leads, yeah. And fortunately, he come back after 4 months as well. I put him on apixaban with a lower dose, a triple therapy, a dual antiplatelet plus anticoagulation, weighing the risk that he's young, there's not much of bleeding risk. So put him on triple therapy for 4 months, yeah, as suggested by the ID side. Yeah. And then the conventional statin, all these things, because I still cannot rule out the possibility of SCS with plug ruptures. Yeah. So he was given dexamethasone 8 mg daily. So I can see the picture, he's still smiling. So 4 months later, this is the ECG. You can see that Q waves is no longer there. Again, physical examination unremarkable, blood pressure is okay. I stopped the apixaban, and the patient decided to transfer to a government service to follow up. Yeah. So I think probably stop there. Yeah.
Thanks, Dr. Very, very interesting case. Any comments from my panel from Hong Kong, China local? I must admit, in Singapore, we didn't see a lot of COVID patients. Yes, Iwa, your comment.
Thanks very much, Chu, for sharing this very nice case. I think the do you know the diagnosis for this patient?
So at the end, I think the MRI carditis, but clinically it's still like more like ACS, but we treat both.
Okay, because I just want to share, because I think one of my colleagues shared quite a similar case in our hospital CME. I think what your patient has is probably a multi-system inflammatory syndrome in adults. So it's MIS-A. So this is commonly seen in children, but what he shared with us was that this is a rare complication post-COVID-19 infection, and it can start 2 to 12 weeks post-infection. So the management is, the patient is very sick, but you did all that you need to do, angiogram, MRI, and I think the treatment of choice at the end will be steroids. So I think your patient's diagnosis is probably multi-system inflammatory syndrome in adults.
Okay.
Do you need to do a cardiac biopsy for this group of patients?
I think it depends on the clinical situation. I think I can share some of the info, but I think biopsy depends on the safety, and but nowadays with myocarditis you can diagnose using MRI.
Any comments? Yeah, Dr. Kang.
Yes. Is there any chance of a variant angina? So the patient is very young and ex-smoker, and I'm not so clinical situation at the time, but so second angiogram you showed show us RCA spasm by catheter. Yes.
Just after the
do you have any plan to provocation test to diagnosis of variant angina in the future?
Sorry, what's it?
Do you have any plan to provocation test to?
Oh, we don't. I think what I thought is the catheter went too deep. The catheter jammed into the right side of the RCA. That causes spasm.
The ECG showed only the ischemic change showed in the RCA region. Usually the myocarditis showed or ECG change showed or read. So I think there is some difference between the two.
Okay, all right.
That's a good point as well. Any other comments? Any comments?
Just a question, Dr. Hall. The patient, the case report, was the inflammatory markers elevated? Elevated, but mine completely normal. ESR, CLP, procalcitonin, all normal. So,
yes, comment.
I think this case is nicely demonstrated the benefit of the MRI in this kind of patient, right? I think the situation that you at the first of the patient is like a Minoka, because we don't know if the cause is vasospasm, myocarditis, or plaque rupture that had a spontaneously lipofused, something like that. And I am not my expert as well, but I think it's on the specificity of the subepicardial scar, right? That you have shown that if it's specific to the myocarditis, not the ischemia, I think, yeah. I mean, if patient had a high bleeding risk, maybe you can, at that time, you can just, yeah, withdraw the antiplatelet or anticoagulant, something like that.
No other comments. I briefly summarize my view of the case. I think I have very limited experience in STEMI mimics in COVID. I think it was quite well described in countries where they had a high prevalence of COVID-19 pre-vaccination. They have a lot of ST elevation cases with myocarditis. And we do know that COVID-19 can directly affect the myocardium. And some of these cases were very, very sick. And of course, the other one was thrombotic complication related to COVID-19, whether pulmonary embolism that you shouldn't miss in the COVID-19 STEMI mimic subset, either primary to the lungs or secondary in the coronary arteries. But those are when the COVID-19 is raging in the population. So thankfully, I didn't see a lot of it, but it was described in case reports and series coming out of Italy that I read that was quite terrifying. In autopsy series that I saw in Singapore, we did see that COVID-19, if you do have a fragrant infection, it can go in the myocardium, cause inflammation, and cause a myocarditis directly in both the endocardium as well as myocardium. So you get some form of endocarditis type of changes on the pathology slides. I think in this case, my diagnosis will be probably some form of myocarditis. I'm not 100% convinced that it's COVID-related. There is population prevalence of myocarditis annually anyway in the population. I'm not too sure I see data that the population levels of myocarditis was exceptionally high pre or post-COVID. So I'm not 100% convinced, but the diagnosis was probably myocarditis, less likely some form of vasospasm, I think. The MRI shows that the scarring was somewhat mid-segment and not true thickness. So it's more like a myocarditis pattern in both inferior as well as lateral apical walls. Yes, please comment. And what I'm afraid of is that a few years down, we're going to have a lot of cardiomyopathy cases that we due to COVID-19.
So one question to the panelists, can we consider colchicine therapy in such patients? Is that going to help as an anti-inflammatory drug? Because there have been several case reports with COVID myopericarditis that colchicine actually helped in such patients.
So I think maybe pericarditis has a bit more benefit. Myocarditis, I'm not too certain. In this case, it looks more like myocarditis rather than pericarditis, actually. So because the ECG didn't strike me as a pericarditis change, but the cardiac enzyme and the MRI changes strike me more as a myocarditis change. The good news only is that the patient didn't go into cardiogenic shock, refractory cardiogenic shock. And if no comments, maybe we move on to the next case. Thanks a lot, Dr. Chow. Thanks.
Thank you, Jack.
So, yes, Dr. Tham.
Yeah, I just want to say thank you for your training for the first part of this section. So,
yep.
So is Ellen okay?
Yes.
Okay, so sorry for that. So the next presenter is from Hong Kong colleagues, Dr. Alan Chen. Alan actually is my good friend, and also he's now the consultant cardiologist in Queen Elizabeth Hospital in Hong Kong. So he's going to share his most memorable STEMI COVID cases to us. Alan, please.
Thank you, Dr. Tam. Can you see my slide? Yes, I think that's quite a busy slide for me, so I need a little bit to rush. So thank you very much for inviting me again for this very important meeting. So actually, we have several of a memorable STEMI COVID case. We have quite a number of STEMI cases in our hospital, but probably this is one of the most representative. So my case actually is a middle-aged gentleman. Actually, he had history of hypertension and diabetes in private sectors. But however, we don't have no detailed exact history of more medication, etc. We only know that he was told to have a normal renal function. And initially, he was presented to a private hospital in March this year, while during the really fifth wave of the COVID pandemic in Hong Kong for vomiting and together with found to have markedly deranged renal functions. Sadly, he also found to have a COVID positive. I think at that time, whenever the patient was attended hospital, they easily to be found to be COVID positive. And then he was transferred to our hospital because we are the designated COVID hospital at that time. So this is the EKG together with X-ray. You can see his X-ray, the heart size a bit enlarged, and some infiltrate for the lung. EKG on admission was still okay, except for some some abnormal T wave or prolonged QT, but in fact, there's no ischemic change. So the patient was not in any chest symptoms. So a brief recall of the situation. I think it's very sad that you may come across the news at that time that we have most 1 million of population have been infected, and this is some of the snapshot on the newspapers. We have total lockdown the whole territories, and lots of COVID patients was not able to admit to the hospital. I mean, it cannot be transferred to the ward because of the severe congestions. So after that, the government actually announced that several of the COVID designated hospital established, and we are one of them, being the only tertiary hospital. We are transforming more than 100 in a hospital. 1,000 of 500 beds was totally transformed into a purely COVID hospital. So all clinical work has been cancelled. Our active cardiac surface, in particular primary PI surface, was severely affected. And most important of all, most cath lab in the territory in Hong Kong was not designed to treat patients with airborne infection with negative pressure system. So much so that actually this is a big dilemma. But this is subsequently everyone of the citizens in Hong Kong may receive this emergency alert one fine day. This is first test the system by the government to announce that our hospital in Trinity Hospital was transformed into a designated hospital. So we are also shocked as well. But we did prepare 1 year ago, which actually we have some preparation of our cath lab, because we are one of the tertiary centers in the doing the mega cluster primary PCI surface and receiving the transfer from this sister hospital. So in response to the potential demand, so actually we have modified our cath lab so much so that we can able to cater to patients with airborne infectious disease. We have HEPA filters, we have full PPEs, also air conditioning system just to cancel out recirculation of the air towards the control room. So back to our patient, actually, he was in fact very bad, the renal failures, creating more than 1700 hyperk metabolic acidosis. On admission, normal troponin, normal vital, except a mild desaturation of 1 liter of oxygen. And taken over to ICU for urgent hemodialysis, and he did well for 2 days. Downtrend of creatinine until suddenly the patient actually developed recurrent VTVF in the ICU. So the second moment, actually the patient get into recurrent VTVF. The ICU colleagues actually performed eCPR for these COVID positive patients, intubated him, putting a VA ECMO bedside because of recurrent arrhythmia. And at that time, the echo showed very bad EF, dilated LV, etc. Very suggestive of sign of acute coronary event. The EKG post arrest showed junctional rhythm because of the quite a number of times of the duration of the CPR, and quick lab test shows normal K, and we are consulted and we bring the patient to care for urgent coronary angiogram. So it's a matter of debate whether it's real STEMI, but I will show you the scene and probably you know how nasty it is. So you can see we take a ground shot from the microfunction set. You can see how bad is the left the heart functions. The cardiac output, the blood flow is barely contracting, and we have the VAMO already inside too. And this is the outside shot. You can see a lot of tactic and then tendon lesion, but it's not obstructive. But you can see from the aerial view, there's a lot of retrograde towards the left side, and this is our enemy. You can see the actually from the back one. You can see actually the distal left main it's a bifurcation, is ulcerative lesions, and together LAD was subtotally occluded. There's a big diagonal, it's also a big proximal OM, but the proper cert was occluded. And so in summary, actually this patient actually suffering from a distal left main bifurcation lesion with ulceration, probably is a culprit. The proper cert was occluded. There's a big proximal OM1. The LAD was totally occluded. The LAD and D1 was a bifurcation lesion as well, the non-obstructive RCA. So it's extremely complex coronary anatomy, extremely complex patient in post VTF rest on VA ECMO. So of course, badly EF patient is not a candidate, it's COVID. Our surgeon won't dare to go in for a care patient. So we need to proceed to hot PCR. I think it just correlates with what we mentioned about the STEMI with cardiac shock. Together, this is over COVID. So actually, whether we need to go ahead for a complete relaxation, I think anatomy would dictate the strategy. So we go ahead for wiring is not difficult, and LED we get good flow, and then pull out the vessels. So it's very diffuse disease. This patient is diabetic. We know that HbA1c subsequently come back for around 8 to 9. So after we blow up the LED, we take the IFS to see this very diffuse disease, and then we also a wide diagonal and check. This big diagonal as well is more than 2.5. And we plan originally to have a provisional strategy over the LED, the D1, to make it simple, because we need to tackle the left main bifurcation as well. So after the standing over diagonal, we also tackled the LED as well with long diffuse. I think at that juncture, we plan to reuse standing, but retrospectively, probably DEV is also an option. You can see the proximal D1 is bifurcation is kind of moderate disease. The IFS also show the moderate lesions. Probably we need to keep it simple, so we want to just push provisional approach. Circumflex, we a brief attempt of the proper shirt wiring is succeeded, but however, this extremely calcified using a 1015 balloon failed to fully open the lesion. We don't think it's worthwhile to further tackle it. Otherwise, we need a rotational fractomy, and this is overall is a very small proper shirt and small territories. So we change our focus to the big OM. So again, we need to complete the left main bifurcations. After the IFS imaging, we stand this OM, and then together with the proximal OM all the way to the left main in the DK crush fractions. And then we check the flow to the big OM. I think this is a good flow. Subsequently, work is not difficult. The DK crush to the left main bifurcation, the OM, kissing, and then do a rewiring. And this is what we get from the left main to the circ. But you can see some funny things going on in the LED. So the flow is not really good because of probably a lot of dissection over the proximal LED. We haven't stand the proximal LED yet. So we use the balloon to blow up the lesion again, but however, the flow still not that good. So we need to I think I can't play the video here. So believe me, the LED bifurcation now, the D1 is already have a lot of dissection as well. So because of the bifurcation lesion, and we need to switch our strategy to not provisional, but to two-stand LED D1 as well. So at that juncture, this is the image I want to show you. So I think that all of you agree need to auto salvage the D1 as well. So we need to strengthen strategy, do the bifurcation standing, two-stand techniques to the LED D1 as well. So again, this is a DK crush, and then we write lots of things. This is the angiogram after the D1 standing. I think they give the good flow to D1 as well. So we remain the final job is to stand the left main LED, the pop, and then the rewiring. We need to do the sequential rewiring to both the diagonal as well as third. So we need to do the second hit to both of these vessels. So it's just a little matter of time, but it's not really technical challenging. And we finally able to finish everything within probably around 2 hours. A final pop, and this is the final angiogram. So good flow, angiogram as well as IFS, and I can't really play here because I need to. Let's see. Okay, I can't play here, but believe me, the angiogram was okay. The progress, the patient was transferred back to the ICU, and we need supported transfusions, continue the hemodialysis. But however, he was still fully dependent on the ECMO circulations with minimal intrinsic heart contractility. So actually, I think the CPR time is around 30 minutes before set up the ECMO circuit. So actually, patient also have a recurrent VTAC, and despite lots of antiarrhythmic drugs. So and subsequently, he also developed in a DKA, DIC, and also systemic intervention response syndrome. So unluckily, the patient actually finally succumbed despite the successful revascularizations. I think lesson to learn, still acute coronary syndrome is the most common cause of VTVF in patients with strong CV risk, despite there's not frank ST elevation. So the COVID and acute metabolic disturbance pose a significant stress to the patient, to the heart, and provoke MI. Complex coronary disease requiring eCPR and complex coronary interventions actually also pose a significant challenge to the treating physicians, both the ICU together with interventional cardiologists. So in these very complicated double true bifurcation lesions, of course, the careful strategy planning is important, but we also keep an open mind and keep a dynamic decision making to tackle the unexpected. So thank you very much.
Thank you, Alan, for showing us these very challenging cases. So now the case is open for discussion.
Oh.
So I don't know, Jack, can you see the presentation clearly?
I got a good gist of it, Alan. Nice to see you again. I know you worked very hard for webinar last night as well. But this is really a tremendous case, I would say. Yes, Dr. Lee wants to make a comment from Taiwan. Liwa, wait for
Alan, it's good to see your case, and especially I'm very glad that you have a modified cath lab. You know, in the hospital, we have negative pressure hybrid room. We are required to do positive cases in the hybrid room. However, the machine is single plane with very low frame rate, like 7.5. So the images and the settings are not familiar to all of us. So it's a hard time for us to do the COVID cases in the hybrid room. My question is, doing the cases with the protection gear is really difficult, especially when you are wearing a visor and the fog will form inside the visor. So it is very difficult to see the images clearly. How to overcome that? And secondly, once you finish that case, how long you have to wait before you do the routine cases in that room? Thank you.
Yes, this is a good question. So infection control measure, we always need to satisfy with the hospital, right? So I think at that juncture, we learned from overseas experience. Most of the centers, for example, in US, in Europe, they didn't really bother. I don't know whether in the rest of the Southeast Asian countries, but I just heard from the Taiwan experience, they also need to do in the infection control setting. So in our hospital, actually, whenever we tackle the case, we will try to move out some of the essential elements, which is movable, right? We just leave the essential equipment inside the cath lab. So we have some of the trolley, some of the cabinet, we just take it out. And in order to minimize the need of disinfections after the case. So most of the time, we so-called after a COVID case, we need to have some kinds of terminal cleaning for around an hour. So before we can use this same lab for another case. So for a less emergent situation, usually we will put the COVID case at the end of the day, and then the staff can clean the lab afterwards. Otherwise, of course, for emergency case, for STEMI, we still do STEMI positive COVID case, but we pretend all patients with emergency to be potential COVID. We also test the rapid test in the ED, but we usually will wear full PPE and N95 masks, plus or minus face shield. It depends on the patients, the physicians. Some of of our colleagues already infected, so they have less of concern. But for the rest of the staff, usually they have get full PPE. They have face shield, they have head mask, and then they get N95, etc. And then they at the peak of the infection, in fact, even the physician, including us, will immediately go to shower in the toilet which is next to the cath lab. So actually, we have planned everything, but nowadays we have more leisure.
So can I ask Liwa or anyone from Korea, learning from this pandemic, is there a need to build a negative pressure cath lab for the next pandemic? Because what we found was that when I surveyed across the region, only UAE has one negative pressure cath lab in the environment. But do we need to have this resource, or is not really necessary? The rest of the hygiene factors, we always do it. I mean, if they are very sick, we just intubate them. We don't want them breathing in the cath lab. It's controlled ventilation. And we
so excuse me, I have some comments for this case. Hello?
Yes.
So I think this is really a very challenging case, and in the COVID-19 pandemic area, I think the negative pressure cath lab is very important. In my center, we have two clinics. So we have two negative pressure cath lab. So last year we performed more than 1,000 primary PCI cases, and the average D2 wear time is less than 1 hour. So I think it's very useful. And second comments is for the patients with very poor heart function. Sometimes the ECMO plus IBP is very useful. It has been demonstrated by some clinical trials. So ECMO plus IBP is superior to ECMO only. So especially I suggest for this kind of patients with severe cardiac dysfunction, use ECMO plus IBP, and we often use ECMO plus IBP for this kind of case. And we could do PCI where transradial approach, and as we know, at present we have the GSS sheet, so we could even use the distal transradial with 7 French guiding catheter. And for the patients with, I think in the COVID-19 pandemic area, we should make to do the good differential diagnosis, like the previous case. I think we should know that data from the Cleveland clinic, 7.75% of patients presenting with ACIs were diagnosed with stress-induced cardiomyopathy. That means maybe tachycardia. So like the previous case, I think the ventricular angiogram, the biopsy is very useful. If truly the patient is a tachycardia, if we still use catecholamine drugs, may increase the death rate. We should use like calcium sensitizer. And in the early 2020, I meet up patients was diagnosed with non-ST elevated myocardial infarction, and I do the angiogram for this case. I found the coronary artery is totally normal, so this is a tachycardia patients, and rapidly exchange the catecholamine drugs to level 7, and the heart function recover quickly. So I think this is very important. Is my comments.
Thank you, Tony, for the comment. So to give a short answer to Jack, I guess we need to be prepared because for during the peak COVID status, some of our primary cases actually shift back to thrombolytic to give fibrolytic for primary for STEMI instead of going for primary PCI. So the lab should be, venerated, or in the design of future hospital, the lab should be, have some sort of a negative pressure, and so have some isolation facilities. So to facilitate, as you mentioned, this kind of infection we can't predict. As you previously point out that from infectious disease physician, 7 years, there will be another one coming up. So I guess this is time, and this is the lesson we have to learn. So in the interest of time, I guess we should proceed to the next presentation by Dr. Frankie Tam. So Dr. Tam is a consultant cardiologist in Queen Royal Hospital in Hong Kong. So today he is going to talk about impact of active COVID infection on STEMI patient and mitigation measure. So Frankie.
Yes, so thanks to the Tam for your kind introduction. So I'm Dr. Frankie Tam from Hong Kong, and good to see so many friends here. Jack, Dr. Lee, Kiwa, yeah, good to see you all. So today I'm very glad to share with you this very important topic, the impact of active COVID-19 infection on STEMI and all the mitigation measures. Yep, I'm trying to move my slides. So where should I point this? Okay, So I think most of you agree with that. Probably this COVID-19 is one of the very important events in human history, at least in the more contemporary human history. So millions of lives are affected. Sorry, I'm going to go back a little bit. Yes, so our lives are transformed and many patients are affected both by COVID directly and also indirectly. And finally, probably now we are seeing hope and you guys are traveling around and hopefully in Hong Kong, we are traveling soon. We can watch our good football games, our favorite teams. We can attend the meetings together. But of course, as Jack and also Levi has mentioned, probably in 7 years' time, we'll be having another pandemic and we have to prepare and what we should do in the coming future. All right. So these are the stuff we published previously, and we know that the COVID-19 has tremendous effect on the cardiovascular system. Firstly, it will have direct myocardial injury. Also, it will exacerbate underlying cardiovascular conditions. Also, the treatment, the drugs will have lots of various interaction with other drugs, and also the vaccine, and also the indirect impact on the patient, healthcare provider, and the system. And specifically for COVID-19 and STEMI care, we know that there are a number of things that it can affect the whole system. Firstly, is the direct effect of the virus on STEMI, for example, the direct myocardial toxicity and various stress. I will talk about it later. And all of these, it will have various clinical and procedural aspects of STEMI care for the COVID-19 positive patients. Secondly, is a diagnostic and management dilemma of STEMI in COVID-19 patients. For example, as we have shown in a previous case, the presence of ST elevation may not be the classical type 1 STEMI in COVID patients. And also for the management, we have to know whether PPCI or fibrinolytics is the best option for our STEMI patients. And finally, is the disruption of the care system and logistic for the STEMI PPCI system. In Hong Kong, we have a lot of various effect on this because of the patient delay, system delay, manpower issue, and also healthcare facilities availability issues that is detrimental to both COVID and non-COVID care. So these are all the challenges of managing STEMI in the COVID-19 patients. And first of all, is a direct effect of the COVID-19 in STEMI. So we know that the virus can actually cause direct myocardial damage because they can enter our cells through the ACE2 receptor. And more importantly, the COVID-19 has lots of different immune-mediated damage, which causes a cytokine storm, either acute or subacute, as in the MISA, as described by Hiwa previously. Also, COVID-19 can cause a lot of different microvascular and also endothelial dysfunction. And very interesting is the microthrombi, because we know that in some of the autopsy specimen, in patients died of COVID-19, even in those with ischemic ECG changes, in autopsy, we can see lots of different platelet, fibrin, and complement activated products in the autopsy, which cause the microthrombi obstructing the microvasculature inside the myocardium, which may cause the MINOCA in the STEMI patients with COVID-19. So these are the data. It's a more clinical data of the COVID-19, active COVID-19 in STEMI patients. So first is the in-hospital outcome. On the left side, this is the early report from a group in Spain, which show that in patients with COVID-19 and STEMI, of course, they have worse clinical outcome. For example, they have more heart failure admission, they have higher mortality, they have more stent thrombosis and more cardiogenic shock. On the right side, this is the data from the American group. This is the big registry in North America. Again, it shows that patients with STEMI and active COVID-19, they have worse outcome. They have high risk of MACE, death, and stroke. So, of course, there's some good news, all right? So this the data published this year, which compare the outcome of patients with STEMI and COVID-19 in the year 2021 to the outcome in 2020. The good news is now they have less severe symptoms, they have less cardiogenic shock, and no mortality. I think the reason behind this, nowadays we have better treatment system, and also the SARS-CoV variant, maybe the Omicron, is less pathogenic, and also the use of vaccine. So in the data in 2021, only 11% of the patients have received vaccine at that time. So probably if we have data this year, nowadays we have many people receiving vaccine, hopefully the data now will show a much favorable outcome in patients with COVID-19 and STEMI. All right, considering the procedural aspects, we know that patients with STEMI with active COVID-19, they have more a prothrombotic state. So in these few studies, all of them point to a trend that patients with COVID-19 have more stem thrombosis and more thrombus grade, more use of mechanical thrombectomy, and more use of glycoprotein 2B3A. So we see the case from Ellen. Probably there may be a lot of thrombus in those cases with active COVID and STEMI. So in those cases, we have to make sure that we have a good flow for the vessels, and we may be using more potent anti-thrombotic or maybe high dose of heparin. So in cases we've tackled patients with COVID-19 and STEMI, we know that we have to use more potent anti-thrombotics. All right. Second is a diagnostic challenge of STEMI in COVID. So this is this data, it's an early report from Italy 2 years before. So they have gathered data from 28 patients with STEMI ECG, very clear. 23 of them even have echo abnormalities, they have regional motion abnormalities. And just only 11 of them have active culprit lesions. So this is a very important diagnostic challenge. In an active COVID patient, even the ECG, echo show a STEMI, they may not have the classical type 1 STEMI in those cases. So probably it may be some focal myocarditis, as shown as the case by Dr. Chu before. It may be microvascular dysfunction. It may be type 2 MI, or it may be microthrombi. So it will enter to the following management dilemma. Should we give thrombolytic or do PPCI in COVID patients with STEMI ECG, all right? So we have a lot of debate from different groups in USA, in Europe, in China. Of course, different options have different merits and demerits. For example, we don't want to, for those pro-thrombolytic, because they think the PPCI may have a risk to the staff, to the environment, it will incur sort of delay for the STEMI patients. And of course, on the other hand, for those who pro-PPCI, because we know that fibrolytics have multiple contraindications, and many of them have just Binoca, they don't have obstructive lesions, and STEMI patients may present late during COVID, in which the efficacy of fibrolytics may be limited. All right. And on the other hand, the STEMI care in COVID-19 is much disrupted because of the infectivity of this virus. We know that this COVID-19 is very infective, even in asymptomatic patients. For STEMI patients, COVID, they may infect the staff, other patients, and contaminate the environment. And this process go hand in hand, and then which leads to an uncontrolled outbreak, leading to death and healthcare system collapse, right? Intra-hospital outbreak also lead to shutdown of facilities and staff isolation. I think this is the real reason why, I mean, in Hong Kong or in China, we are still very strict in our quarantine because we don't want our hospital system to collapse. So what we can do, so previously, we regarded all STEMI patients will be considered COVID-19 positive. So we have to do different things. For example, we have to assess the COVID status by either rapid test, radiology, symptomatology, and then we have to decide which strategy to use, either thrombolysis or PPCI, depending on the availability of the facility and the manpower. And considering the reperfusion care, we have to depend on whether the CCU or bed or staff are available. So here are some practical recommendations in the cath lab for PPCI in the COVID-19 era. For example, for the patient, we recommend them to have universal surgical masking. We try to avoid aerosol generating procedure in the cath lab, for example, CPAP, intubation, and that's the reason why we have a lower threshold for intubation in some designated places, for example, in the A&E, in the negative pressure room. And for those CPR, we would try to use the automated CPR device. For the staff, we have to make sure that we have the full PPE and 95 or PAPR, and we try to limit the number of staff into the cath lab. For the environment, we just have a very hot discussion on whether we should have a negative pressure cath lab. If not, we have to modify the airflow system, just as Alan has performed in his hospital. And we have to have predetermined disinfection protocol of the infection control team in the hospital system. So this is the cath lab in our hospital. So in my opinion, I think we should have a negative pressure lab. For your information, the usual cath lab is usually positive pressure because we want to get all the dust and particle out of the cath lab. But in case of this infection control cath lab, we have to modify it to a negative pressure system. So not only is the OT room itself, because all the NT room or the Kang room, they also have to be modified. So this is the modification on the left side. In usual manner, it is a slightly positive pressure. All right. So the patient will enter to a normal pressure room inside to the positive pressure room. On the right side, all right, if you can modify it to a negative pressure, so patient will enter to a negative pressure room and inside to a positive pressure room, and all the air, contaminated air, will go inside the room that can be modified. And this is the recommendation of our infection control team. So I think in the future, every hospital, especially the newly designed hospital, would try to get one of these so-called modifiable pressure cath lab to cater for our patients with potential infectious disease. All right. So ladies and gentlemen, this is the final slide. So in summary, for COVID-19 and STEMI patients, first, they have worse clinical profile because they have more delay and more symptoms, more cardiogenic shock, and more multi-organ involvement. And secondly, they are more prothrombotic, so they have higher thrombus load and higher risk of stent thrombosis. And there will be diagnostic challenge. For example, there may be BINOCA or mild pericarditis. And for medications nowadays, we are using a lot of those COVID-19 drugs, for example, the Paxlovid. We know the Paxlovid have lots of drug interactions, especially the cardiovascular drugs. For example, clopidogrel, ticagrelor, and NOAC. And mind you that for patients taking Paxlovid, the use of ticagrelor, amiodarone, and eplerenone are contraindicated. And finally is the hospital system in the infection control. So we have to make sure that various strategies are employed, for example, universal masking, PPE, or possibly negative pressure facilities. So thank you very much.
Thank you. Yes, thank you. It's a very insightful talk, excellent presentation. So any comment from Singapore side or Hong Kong side?
Yeah, I've got a question for Frankie. Well, just now you mentioned that you noticed one of the possible mechanism for people, COVID patient presented with STEMI is the microvascular dysfunction and microthrombolysis. I don't know whether, do you have any data whether COVID patient, when they come in with STEMI ECG, what's the proportion of them having BINOCA and what's the proportion of them having STEMI? Is it more of them having BINOCA?
Yes. So I think the more big data is now planning to be published, but for the early data from the Italian group, probably only half of them have the classical type 1 STEMI. So in any patient with COVID-19 and STEMI, we have to be very careful because nearly half of them is not having the classical type 1 STEMI. For those patients, giving thrombolytic may be harmful for them.
What about the proportion of the different mechanism causing the BINOCA? Would it like more of them having microthrombolysis or any data for that?
Yeah, I think microthrombolysis is difficult because we can only discover them in the autopsy, right? So it's really difficult to have a study in that. But I think many of the patients with COVID-19 and STEMI will sort of have some microthrombi in the system. So, but however, it's very difficult to really delineate which one is not.
So any more comment? Chad, do you have some comment?
Can I ask then the experience in China or Taiwan? If you ask me initially, we also had the same triage to say we're overwhelmed. Primary PCI should go to thrombolysis. But looking at the data with actually a not insignificant proportion of STEMI mimics, shouldn't we push for all primary PCI even in the next pandemic actually, rather than a thrombolysis approach? What is your opinion in Hong Kong, Taiwan, or China? Sorry, maybe we have dropped off. Korea, maybe. Is there thrombolysis still going on?
Yes. So in early period of pandemic, so we recommended thrombolysis rather than primary PCI because of the infection, but there was some problem. So current guideline recommend primary thrombolysis should be within 30 minutes after patient arrival, but it was very impossible because we was not training. Before the pandemic period, we performed most in STEMI case, we performed the primary PCI. Second problem is there is no thrombolytic agent in ER and cath lab, so that's a big problem. So we have to prepare for next pandemic season.
It's not so easy because in Singapore, the last time I used thrombolysis was 2003. So I don't know how to use thrombolysis. So I think it's not so easy. For example, Dr. Lee in China, he does 1,000 STEMIs. So to convert to thrombolysis is also not easy.
Sorry, the voice is not very clear, but in my opinion, I think if primary PCI is not available, thrombolysis is certainly should be used. And as we know, according to the data from the Europe, pre-hospital thrombolysis is very useful method to recanalize the occluded artery as soon as possible. And data showed use the pre-hospital thrombolysis, the death rate is about 0. So I do think if we could rapidly use the thrombolysis method to treat the AMI patients, also a very good choice. And I have a question for Professor Tan. So as you reported, the STEMI patients with COVID-19 has a higher thrombus burden. So how to solve this problem, like use strong antiplatelet drugs or prolong the anticoagulation times? So what's your opinion for the high thrombus risk?
So I've always advocated that sorry, it's for Frankie. Frankie, go.
Yes. I think yes. So because frankly speaking, in Chinese patient, we do not see a lot of stem thrombosis. But I think in patients with COVID-19 and STEMI, I will make sure that I could have a good dose of anticoagulation, for example, heparin, and make sure that I have, for example, at least 80 to 100 units per kg of heparin to be used. We use potent antiplatelet agents and more judicious use of protein tuberous 3A. And because sometimes we have complex procedure like that in Allen, maybe we have to do it 2 hours, 3 hours. We may forget to give to be more vigilant on our ACT time. But in case of COVID and STEMI, we have to be more judicial in the use for the anticoagulation and also the antiplatelet agents.
Okay.
Dr. An, you want to have a comment? And Paul, you want to Dr. An first.
Hello. I just want to echo one thing that Frankie mentioned. I think in COVID time, we see an increasing number of patients presenting with non-obstructive coronary artery disease. So if your default strategy is lytics instead of primary, you might end up finding yourself thrombolizing quite a large number of patients with non-obstructive coronary artery disease. So that itself is also a risk factors that one have to take account into. So I would think that, Jack, I would tend to more agree with you. Maybe flipping back to the primary PCI as a default strategy may be a safer option for our patients.
Okay, Dr. An?
Yeah. I want to share our experience about the use of thrombolysis in the STEMI patient. As you know, in Ho Chi Minh City is the last year in Vietnam, the Ho Chi Minh City is the center of the COVID pandemic, with only the 75 people, 75,000 people dead. But in Ho Chi Minh City is about the 75 the patient the death for. So at the last year from June to October of last year, also had the peak of the pandemic. And also because of the strictly the social distancing, and also the Vietnamese people had no choice, they had no chance to approach with the first medical contact. And also at that time, then nearly all the Vietnamese people had the vaccination, and also in Ho Chi Minh City we don't have we have the negative the pressure cut left, so we choose the use of fibrolysis as the first choice. In our cut left, we have we have the 32 the STEMI patient. So all the patient we use unstable, and just 30 cases successful, just only 2 cases failed. And after we had the COVID results, we did elective the BCIs 1 day later. When we did with the 32 cases, we found that they had the 2 cases. The 2 cases, one is the core enzyme is normal, one is the spiral dissection, and third cases also we had the blood rupture. That is and also with the case of when we fail with the primary CI, we do rescue. Also, we follow up some days later, and the 32 cases, and we also continue to do the COVID test, and only 2 cases also had the COVID positive test. Also, so we had the incentive outcome left. That is our experience about when you use the fibrolysis on the COVID pandemic.
Okay.
Thanks, Dr.
Thanks. So if no more comment, in the interest of time, may I make some closing or key learning points for this section. So can you move the slide? No. Okay, I guess all of you will agree with me that COVID pandemic has a great impact on every aspect of life of people worldwide. So as mentioned by previous speakers, Frankie, Alan, and other doctors, so COVID can cause multi-organ damage. So regarding cardiovascular system, it cause direct myocardial damage or the post-thrombotic stage, we need to carry to tackle it in terms of anticoagulation in the setting of STEMI. So we did, we should learn a lesson. COVID without immunities can cause high morbidity and mortality. However, STEMI even have higher morbidity and mortality if it's not managed properly. So the hospital administrator or the physicians should coordinate, maybe to modify our cath lab with some isolation facilities, and maybe need to draft a better infection control protocol so we have to protect our staff and also our patients. So in order to preparing for the future unknown infectious disease. So for cardiologists, I guess we still need to have our job to explain to our patient or public that despite the epidemic or epidemics, so we need to seek medical advice if you have symptom of heart attack. So tell the patient that you are still protected from being infected with a hospital control measure. So you need to go to the hospital as soon as possible to save more harm muscle with timely perfusion therapy. So with that, I thank you all for your attention. And once again, I thank Jack to co-chair with me this section, and all the speakers for sharing their experience, and all the panelists for the discussion. So I guess we should conclude this section. And then we have a coffee break, right?
Liwa, maybe we overrun a bit, so we coffee break until 11, then we come back at 11 a.m. Is it okay? I think our timing is the same. Yeah. So 11 a.m., I think it just shows that we need to deal with the next pandemic. And perhaps maybe we should publish a consensus to our Asian Pacific colleagues to gather all this experience and give some recommendation for what we should do. For example, a faster data gathering, faster recommendation of what to do, and all the logistic that you talked about. Maybe it should be there, equipping all the hospitals and healthcare workers. And we should have some form of, I believe still that we should adhere to guideline-based practice regardless of pandemic. And that will lead rise to the best outcome if we can manage it based on resources. Thanks a lot. We take a break. We come back at 11. Thank you.
Good afternoon. Again, welcome to our second sessions of the big symposium. My name is Paul Ong. I'm based in Singapore. I'm really pleased to see a lot of you face to face, but today we also have the honor of having a lot of our good friends from overseas dialing in to support. So maybe let me just introduce our esteemed colleagues and panels on the table. Sitting right next to me is Dr. Aaron Wong from Singapore National Heart Center. On my left is Dr. Cho Song-Soo from Korea. Also here with me is Dr. Arun from India, and I also have Dr. Hong Minh Ngo from Vietnam as well. But we also have panelists dialing in from overseas. We have Dr. Raymond Fung from Hong Kong and also Dr. Yu Li from China. Together with me, who is co-chairing from Taiwan, is our good friend, Dr. Yin Wei Xian as well. Okay. Now, first of all, of course, we have to be very grateful for BIOTRONIK to support the big symposium and having this being physically present in a hybrid format today. Now, the focus on this session, we have two live cases to be presented by Dr. Ho Hee Hwa and also by Dr. Lam Ho, one from Singapore and one from Hong Kong. Now, live case for STEMI, of course, is difficult. We don't never get round to have it coordinated so well. So these are both recorded cases, and we will have cropped out some of the highlights to illustrate certain points. And I think in terms of managing primary PCI in STEMI, such as situation like multivessel disease, thrombosection, cardiogenic shock, I think the live case hopefully will highlight some of the nuances. You are really strongly encouraged to participate, and there are microphones dotted around. Please help interact. So without further ado, maybe can I invite Dr. Ho Hee Hwa to come on stage, and we can play the first sessions on acute PCI for STEMI, presented in a case presented in Tan Tock Seng Hospital. Dr. Ho Hee Hwa is the cath lab director for Tan Tock Seng Hospital. I think he is a household name in this region, so all of you probably know him very, very well. So maybe I'll pass it over to you, Hee Hwa, to take over.
Okay, thanks very much, Paul. And first of all, I'd like to thank BIOTRONIK for inviting me to share a case of acute PCI in STEMI. So the focus of today's session is to know about the contemporary approach. So we would like to share what is our approach from Singapore. So you can just play my video and pause it at the appropriate time. So just pause it. Okay, so the patient is basically a male, 57-year-old. He's a chronic smoker and previously was well. And he presented one Friday afternoon to our cath lab with anterior STEMI. And our cath lab was activated. So next. So this is the EKG on presentation. You can see that there is Q waves in the lead V2 to V3, and there's marked ST elevation with reciprocal change in the inferior leads. Okay, next. Sorry, you got to play the video. So this is myself doing the primary PCI with my fellow Ted. Ted is down here. So you can see that we are getting access. So by default, our approach is transradial. I'm sure it is in many parts of many centers and many parts of in the region. So Ted was very efficient that they got puncture at the access at the first puncture. So I think I'll just ask the panelists, anybody does think differently? Anybody trying the distal radial, maybe from the left side?
Dr. Cho, maybe I'll ask you to share with us your experience in Korea. I know in Korea we see quite a lot of femoral cases still being operated on, but I also have some really nice presentation on distal radial puncture as well. Maybe you can share with us your practice.
in our hospital, some faculty use the distal lattier, but we have 4 physicians for the perform the primary PCI, and 3 physicians usually use the lattier approach, and 1 faculty use the distal lattier approach. And yeah, and some in our Korea, 2 center very popular, very usually use the distal lattier approach without the image guided puncture.
Just pause the video, sorry.
So Aaron, I know you do both, but now increasingly transradial. But I believe, maybe you can share with us, what the clinical data would suggest, whether there's any, benefit of one procedure over the other.
Yeah, definitely transradial has been shown for multiple trials that it reduces, actually not even the bleeding complication, but somehow it shows there's mortality benefit. Yeah, so I suppose because femoral, especially in Western country when the patients are obese and they have lots of femoral complication, retroperitoneal bleed, it may not be so often in our sort of Asian smaller size. But I think for heart center, we use transradial approach as well, unless it's in cardiogenic shock, where we think that the femoral, we may have to put in IABP, other support that we actually approach from femoral. Yeah.
Back to you,
Okay, so I think from the video earlier, you can see that my fellow Ted has inserted the radial sheath, and we have given a cocktail as an anticoagulant. So in our cath lab, especially myself, I use Claxane as my anticoagulant of choice rather than the unfractionated heparin. So happy to hear what others use.
Can I ask, Dr. Arun, your practice? I mean, I think, using heparin versus low molecular heparin, what's your take on that for PCI?
Yeah. In our lab, it's almost more than 95% is heparin. Very rarely low molecular heparin, because we can titrate ACT with this, and the other indication is bivalirudin in heat patients or low platelet count patients. Yeah. Otherwise, we practically don't use any low molecular heparin.
Okay.
And most of our procedures are in all across India. It's a vast country doing multiple, thousands of PCIs and primary PCIs. Majority of operators are more than they are happy with radial.
Okay.
And particularly with this Teromos sheath, you can take a slender 7F, where in acute MI you are never sure whether you are encountering a bifurcation where you need 2 balloons, 2 wires, and other things.
So
yeah.
So that's really nice point that you brought up. So you are saying that your lab, the default will be radial, but you will use the slender 7/6, so that you have the option of going to 7 French. Is that right? Okay, that's nice point. I want to just quickly ask, anyone use low molecular heparin in your PCI?
Yeah, we have used it.
Okay.
But very rare.
Rare, okay. And anyone use bivalirudin in here in Asia? I heard India has it. Anyone else have bivalirudin in the lab?
We kept 1 or 2 in a pharmacy for cases with HIT that we really cannot use any heparin. We use it once for one of our patients who had HIT actually. So it's good to keep 1 or 2 vials in the lab for this sort of situation.
So I think the use of Claxane, I think, is backed up by clinical studies. I think the major trial is called the ATOL study. And because of these positive results showing non-inferiority to unfractionated heparin, Claxane is received a class 2A indication in the ESC guidelines. So okay, can play the video? So as we are getting ready, it shows you that we are preparing the manifold. So we work very fast as a team to get everything ready. And the next will be the guiding catheter. So in our, okay, can pause the video? So in our cath lab, especially for myself, my default guiding catheter for primary PCI is the Ikari Left 3.5. So I'm happy to hear what others are using for primary PCI.
How about, Dr. Hong from, what's your default guiding catheter in primary PCI? Or do you do all the diagnostic before you do the intervention, or do you take a multiple purpose guiding catheter to cut time? How do you do it?
Yes, thank you very much for for asking me about this. I definitely use the radio asset because back to the year 2011, I did that research to present it at TCT that compared the transradial with the femoral. So from that, we use the transradial, and with the diagnosis, so we use, for example, this case, we use the diagnosis for the right side and the guiding for the left side directly. And in the past, I have the guiding catheter that the Tiger Kim, so we use that one for both sides. But now we don't have that one available in the cath lab, so we use the diagnostic for the first for the right side for this case, and the guiding for the left side. Thank you.
Okay, maybe we feel a bit left out. I think we have people from overseas, from Hong Kong and Taiwan and China dialing in. Maybe can we see if Raymond is online? Dr. Raymond Fung from Hong Kong. Is it possible to bring Raymond in and see what his practice in terms of guide cath choice in primary PCI?
Sorry, I cannot hear very clear. So maybe you can continue discuss.
Okay.
Sorry, Paul.
Hello.
Hello,
Good to see you
hello.
again.
No time no see. Good to see everyone here.
See. Okay, but Raymond, can you hear us? No, Raymond, you are still muted. We can't hear you. No, we still can't hear you. Maybe Raymond will come back to you shortly. Maybe we asked Dr. Li Yu from China.
Thank
China
you.
obviously is doing a lot of primary PCI and transradial. So we're just keen to hear what your choice of guiding catheter in your practice.
First, I use Tiger to find the capitalist vessel. Then I decide to use GL or GL.
So JL and JR will be your default catheters. Is that correct? Okay. Raymond, are you back with
Yes.
us?
Can you hear me?
Yes,
So,
we can.
Yes. Well, you use carrier left in our lab at least because we think we can do the both side for diagnostic and intervention in case we need it. But I have another question. Would you use a 6 French or 7 French? Yeah. Because for me, sometimes I just engage these very complex cases, and 7 French would be quite inconvenient. But I think most of the time, if just for elective cases, that 6 French will be okay.
Okay, so we heard from our colleague Dr. Arun in India. He would default put in a 7-in-6 sheath. And I think if the practice in China is they tend to do a quick diagnostic to know what it is, then I think that addresses all the questions, isn't it? If you see a very complex lesion, then your choice of guiding catheter probably be 7 French.
Yes.
Yeah. Okay, so can I pass it back to you, Kara?
Yeah. Okay, sure. Can you play the video? So we use 6 French Ikari left as a default for some of us. So as we are advancing the guiding catheter to the ascending aorta, the question now is, should we perform angiography of the non-infarct related artery first, and then followed by the left coronary system? I think for myself, especially for anterior STEMI with a very high ST elevation, a tombstone looking like ECG, usually I would tend to go to the left side first. I think time is of essence. So my preference is always to go for the left side, take a look, and quickly open up the vessel. But of course, every individual practice is different. So happy to hear what others would do, especially you have an anterior STEMI with a tombstone ECG.
Maybe we just have a vote. If a patient comes with anterior STEMI, who would check the right first? before you do the angioplasty to the left? Who would check diagnostic right first? I think, hey, I think you're in the minority.
Yeah.
Sorry.
It's okay, no fine.
So I have one more point here. If you look at the ECG, this already evolved. My Q already appeared. By going by the ECG, it's already a 6 hours or 3-4 hours old MI. If you look at the ECG,
Yeah,
if the patient is stable, I would go with the right check first. If it is a hyperacute ST elevation and the patient is ongoing chest pain in 30 minutes duration of presentation, I'll go with left first.
Yeah, I think it depends. Sometimes you realize that for very young patients, the Q wave can appear very quickly. So it depends on the symptom onset to reperfusion. For this patient, I think his symptoms started in midday. So a lot of times Q wave doesn't mean that that is a delay presentation. So sometimes it can appear very quickly. So I think for myself, I think I tend to go for the left side, because the problem sometimes with the right is you could be facing an anomalous, and then you have a hard time to engage. And then after that, you may, patient may have radial artery spasm, so it makes things a lot difficult. So for me, if you have a tombstone ECG, I will go for the left first, because I think time is of essence. So okay, can play the video?
Another point is that if you see that the right side has a like CTO or very tight lesion, then this is very complex, so you have to be really careful when you do the left side. And sometimes you can see the collaterals from the right side. Once you see the collaterals, you can take your time, because it's being reperfused. I think Arun is right that sometimes we talk about door to balloon time, but symptoms of balloon time is actually quite important as well. For this ECG, I agree with Arun that it looks like it's already Q wave evolved, and the time, if the presentation is long, then the risk of no reflow in the LED is very high chance. So you won't do anything different, but at least you can sort of prepare for sort of more complication if it's a longer presentation.
Okay, can play the video? So we went for the left first, and we just show you the pictures.
And also when we look for the right, we just very briefly go to the right. If it cannot engage, we agree with you. We just go switch to the left side. Yeah, we don't try it very hard. Yeah.
Okay, so from the initial angiogram epicaudal, you realize that there is a proximal LAD occlusion. Unfortunately, there's some small bubbles going down the left circumflex. So we quickly swing to epicranial.
Now I notice the fellow tends to leave the guide wire inside there. So that's the reason why it's a bubble, because when you aspirate the thing, it doesn't clear off the bubble completely. That's why you have an embolism there at the moment. So I usually insist the fellow to remove the wire.
Okay. So once we confirm where is the occlusion, so we have to do the wiring now. So by default, our guide wire of choice is cyan blue.
I noticed the J wire the 035 wire is still inside while you're wiring this LED, isn't it?
Yes, I tend to keep it in, because sometimes you have the tendency of the guiding is not unstable, patient breathe, and you lose position. So I tend to keep it in, and I wire it, and I'll take it out. Yeah.
Sometimes the wire get deformed when you push in. If it's the J curve may knuckle, and then
that's why you have to be very gentle when you introduce the wire into the guiding catheter. So I think Ted tried to wire it, and he was successful. You can see in the subsequent shots. So we swing to epicranial. You could see that he could pass the wire easily past the lesion site. So once we wired, usually we do not do routine thrombus aspiration unless there is a high suspicion from the angiogram. And we, by default, we usually take a 2015 balloon, a small balloon, just to establish flow. So usually we will probe at low pressure, and then we will look at the angiogram and decide what is the next strategy. So we are mounting the 2015 balloon.
Taiwan, can I just interrupt you a little bit? You wired it. Did you take a picture or test shots to see whether a lot of time you have flow back at this stage?
We did a test shot.
Actually, for myself, if it's TIMI zero flow, I actually routinely do thromboaspiration. Actually, it makes life much easier because the moment we cross the thrombustor or whatever aspiration catheter, you see, TIMI 3 flow. You can, yeah. So I actually sort of routinely do it if it's TIMI zero flow. Yeah.
So we provide at low pressure. You can see that we got some flow, and we went up again. Patrick, how many more minutes do I have? Sorry, 15. Okay. So just repeated ballooning at low pressure.
So while watching this, I'm just curious, Aaron said he will, if there's no flow in TIMI 0, then he will aspirate. I want to know what's your practice in Dr. Hong, in your lab. Would you balloon? Would you just go in direct stance? Will you thrombus aspirate? What's your practice?
Yes, thank you very much for the question. That because according to this angiogram, so I actually so far I don't have the clear angiogram, so I don't have the comment on this. But in my current practice, so it's up to the thrombus inside the vessel. So for example, the very narrow, for example, in my mind, I think that the vessel is very narrow and then it's occluded. So there's not so much thrombus inside, so we don't need to aspirate that. But actually, it's a very vulnerable small lesion, but a lot of thrombus inside and big vessel, so we have to aspirate that. So at the moment, I still support for the aspiration, but we have to look at the vessel. Otherwise, we suck for 100%, like a guideline recommended. So we don't get any benefit from the suction. But if we indicate correct patient, correct lesion, so we get the benefit from that. And of course, the easy to stenting, easy to put the direct stenting in the side of the stent as well, and without any slow flow up the final angio. Thank you.
Okay, great. Maybe I can ask Dr. Yin, my co-chair from Taiwan.
Yes.
I think most of us agree that default aspiration no good. It depends on lesion and vessel characteristics. So Dr. Yin, maybe you can help summarize what type of patient would you do thrombus aspiration upfront?
Yeah, of no doubt, if there is a heavy thrombus burden, we will do that. But in case of sluggish flow, or the flow is TIMI 2, we will sometimes do aspiration. The aspiration should be performed before the lesion, start before the lesion, instead of pass through the catheter and then start to aspirate. So that can avoid the get stuck of the catheter by the thrombus inside the lesion. That's our practice. Thank you.
Okay, can we go back to you, Taiwan?
Okay, just play the video. So you saw that once we establish flow, the vessel is very small in caliber and diffusely diseased. So we took the balloon out, and as we all know, when patient in AMI, the vessel tends to vasoconstrict. So we proceeded to give a lot of GTN and hope to get a bigger caliber vessel, and then that will allow us to plan our next strategy. Let me know when I have 5 minutes, Patrick. So you can see my fellow Ted is giving the GTN.
Not always easy in STEMI because a lot of time the blood pressure is not there. It's luxury item. So
he was stable, so we gave lots of GTN. So I think just because of interest of time, what I can say is the artery size was what you're seeing right now is small in caliber. So so I think what's going to be your next approach? Maybe we can ask the panelists.
Yeah. We'll take an imaging catheter and see the vessel. Maybe IVUS in a thrombotic lesion, we'll take IVUS and see the vessel size. And many a time we underestimate the vessel size in acute MI when it's a thrombotic occlusion, particularly.
Dr. Cho, and I think in Korea you also do a lot of intravascular imaging. What's your practice?
Yes, in my practice, I usually use the IVUS in ST elevation MI setting, and then before the IVUS, if the patient vital sign is stable, I gave the nitrate and then check the IVUS.
You use IVUS, right? I think, can we ask Raymond Fong from Hong Kong? Raymond gives a lot of talk on OCT as well. So is it IVUS or OCT here?
Well, but I think in the STEMI section, I will use IVUS because I find it, I mean, time is really important. Of course, we already opened up the vessel, but still, sometimes because we want to finish the case as soon as possible. That's why I think for me, IVUS is good enough, unless it's in minimal situation. Sometimes in some STEMI cases, actually we only see thrombus and it's nothing else. Then probably we need to see whether it's really due to emboli or really there's a lesion inside. Then probably in that case, I might perform an OCT because it gives us more information about what actually happening inside the vessel. Otherwise, if it is like a simple, a typical STEMI case, and I will use IVUS.
Okay, thank you. But cost sometimes is an issue. If you don't have the resource, and I'm going to swing it around to Dr. Hong, not every case can be IVUS and OCT in real life. So in this particular case, when you see a small vessel like this, and your manager say no IVUS, no money, so what would you do?
Actually, we concerned about the diameter of the vessel. So in this situation, sometimes we have to think about the severe spasm of the patient. So we have to we wait for a while, and we give the nitrate again if the blood pressure is still okay. Because now it's the TIMI 3 flow already. We don't have to rush for time anymore. So we have time to do anything. For example, we wait for a couple of minutes. Or with the GDN, or even we have the IVUS in the cath lab. Sometimes we have to think about the IVUS. IVUS now is okay in my cath lab as well, but no, we don't have OCD. So in this situation, we have to wait for a while and see.
That's a very good tip. Okay, thank you.
You can just play the video. May have to fast forward a little bit because of interest of time. So I think what Dr. Hong says is correct. I think once you assess speech flow, I think there's no, don't rush. I think you can take a step back and think what is your next strategy. So patient was stable, so we waited about a good 12 minutes. So we gave multiple boluses of GTN. Can you fast forward to, so we gave multiple boluses, and the size still stay the same. You can see that perhaps is about 2.5 to maybe 2.2, but beyond that, I think the caliber is very small, much smaller than your 2 mm 6 French Ikari. So I thought of doing intravascular imaging, but I thought, the danger is if the intravascular imaging can be occlusive in this case. So looking at the entire LAD, it was diffusely diseased. There's disease in the proximal as well as the mid where the big diagonal comes off. So I decided that to open up the mid LAD with a 1-2. So again, we gave multiple boluses of GTN. The vessel never grew. And I decided that this is probably a patient may be undiagnosed diabetes with diffuse LAD disease. And I decided that perhaps I should try a drug-coated balloon approach. So I think for a 1.5 to 2 mm vessel, I think what is available in our lab is the sirolimus drug-coated balloon. So in the mid to distal LAD, we use two Magic Touch sirolimus drug-coated balloon. And in the prox LAD, after we did the lesion prep, I used a Pantera Lux 2020 to treat the lesion site. So whenever you use a drug-coated balloon, I think it is important to examine your results from different projections, making sure that you do not miss a severe dissection. Keep scrolling, keep scrolling. Oh, sorry. Okay, that's back. Okay. Okay. So this is the wire-free shot. You can see that the LAD is small and diffusely diseased. So I'm examining it from the different projections. I had one with completely wire-free. So rather than put in a small stance without IVUS, I thought that perhaps it is better to treat the patients with a drug-coated balloon. So I wasn't too happy that it was not engaged, so I went back to engage again and take a better picture. Just fast forward. So I again use the catheter to check the right. You can see that there's a moderate lesion in the proximal, and there is a lesion in the RPDA. So the question, of course, we had from the earlier session is what's the approach to non-culprit lesion? So in our lab, we use the QFR, which is angio-derived base FFR assessment. So the QFR, you can see it is abnormal in the RPDA, but it is normal in the prox RCA. So we decided to treat it medically. Just pause it. So the question is it feasible to, just go back one slide. Question is it feasible to use a drug-coated balloon? I think the answer is yes. We had some preliminary experience using drug-coated balloon in our center. We published our initial experience way back in 2015. We demonstrated that it is safe and feasible to use it in about 89 patients. But these patients has to be selected very carefully, and we had high rate of TIMI-3 flow with a low 30-day ischemic event. Next. Okay, just pause it. So I think when you use drug-coated balloon, I think it's important to do a proper lesion preparation. But in acute MI setting, you have a lot of clot. So when you have a significant amount of thrombus, I think it's important for you to do a thrombus aspiration because you want to clear the way for the drug-coated balloon. So so you have to aspirate when there's significant thrombus and must always pre-dilate because in a way you are testing whether the patient can tolerate minimum 30 seconds balloon inflation. So if patient has TIMI-3 flow with no significant dissection, with quite a satisfactory residual stenosis, then you can use drug-coated balloon as the final step. Next slide. So I think there is now a small randomized control trial which demonstrated the safety and efficacy of drug-coated balloon in primary PCI. It's called the Revelation trial, which was published in 2019. Next. And you look at the procedural characteristics, you can see that thrombosuction was performed in about close to 78% of cases. Pre-dilatation was 100%. And drug-coated balloon that was used in this study was Pantera Lux, and about 18% of patients need bailout stenting. Next. So when you look at the primary endpoint, which is the FFR at 9 months, as well as the clinical endpoints, basically it was non-inferior. So the conclusion of the trial was that DCB strategy was non-inferior to DES in terms of FFR, and it seems to be a safe and feasible strategy. Next. So I think the Revelation has recently published their 2-year clinical outcomes, again demonstrating the non-inferiority of the paclitaxel-coated balloon. Next. So I think the key points from my case is that I think the use of DCB is safe and feasible. We need to carefully select our patients. And again, important to do the necessary lesion preparation. You can use it in de novo lesions, for example, in small vessels, and also patients who present with late stent thrombosis. The beauty of drug-coated balloon is you treat underlying CAD and you leave nothing behind. Next. So I think what is the contemporary approach for primary PCI in 2022? I think radial access is definitely the default access of choice. We do not perform routine thrombus aspiration. Majority of patients will receive drug-eluting stents, but I think it is important to consider in some patients drug-coated balloon is also a feasible strategy. Thank you very much for your kind attention.
Thank you very much, Kaiwa. It's a fantastic case and a lot of important teaching points. But I think in the interest of time, I'll probably keep the Q&A till later on if we still have time. Thank you very much once again for preparing this case. Please come and join us on stage. For the remaining sections, can I pass over to Dr. Yin Wei-Hsian, our co-chair, to moderate the next sessions. Over to you, Dr. Yin.
Thank you, Paul, for your kind introduction and very excellent and fantastic session. I think the next presenter, Dr. Wen-Lieng, is my old friend. He come from Hong Kong and Tunmen Hospital. I think, as I know, it's one of the busiest hospital in Hong Kong, and they hold maybe largest volume of PCI there. So I think no wonder he can have so many interesting and challenging cases that can show us. Dr. Lam, would you please to show your case today?
Thank you, Dr. Yin, and good morning, Dr. Yin and Dr. Paul and Dr. Wong and all the panelists. Today is my great honor to share a recorded live primary PCI in this session, particularly together with Dr. Ho, one of my respectful senior during my fellowship training. And today my topic is talk about primary trip PCI. This was the history of the patient. The patient was 42 years old, history of hemophilia and HIV positive. Actually, it was a very sad story. At the age of 9, the patient got blood transfusion and was infected with HIV, and that affects his whole life. The patient this time was admitted for AMI and APO, and short ejection fraction was just 19. ECG showed AVL-ST elevation. We can see that from the angiogram. This is the right side angiogram, the outside. You can see for the outside there. Can you replay the video? Yeah. Outside we can see total multiple focal critical lesions. Some part, for example, the PL is total. So this was the right side, and this was the left side. The patients actually have AVL acceleration is because you can see the critical lesion at the also left main or mid left main, very critical left main. There are multiple critical lesions over the circumflex, and it's quite tortuous. And the most crazy part is the LAD. The patient have a big septal, and at the ostium of the big septum, there's a critical lesion. And this septal, after the critical left main lesion, this septal, this big septal in LAD actually is supplying the RCA. And this septal, critical septal, give septal retrograde supply to the distal AD. So actually is this critical septal supplying the RCA and also supplying the whole LAD. And the patient had critical left main lesion at the same time. And very complex medical history, hemophilia plus HIV positive. So how to handle those cases? What is the most important thing in those trips? Actually, this case, we also vary a lot. We have consulted surgeons turned down, and then we proceed. Although it's crazy, but I would like to share the most important things in handling those cases is love and courage. Actually, without love and courage, those cases will never be put on the table. And if you don't have courage, you just have love, you will not do this case. If you have courage, but you don't have love, there's no counteraction. Then many of the time you will do many crazy things out of your ability. Finally end up with ECMO for a few days and then die. So love and courage for handling those cases for me is the most important. That guide your heart. That will affect lots of things while you handle those cases. So how to approach this case actually is all the thinking, judgment, experience. Then it will affect and determine your approach and skill. So maybe could we ask all the chairman and panelists and the four, so how would you handle this case when you do the PCI?
Okay, we have distinguished panelists here. So would you please talk about your own considerations? Because the patient has hemophilia, are there any precautions we should be taken care of?
So how will you do this case? And a surgeon turned down, yes.
Well, as I know, hemophilia patient has a high risk of thrombotic and bleeding events. When they get ACS and needing PCI, should we give them some coagulation factor or something like that?
Yes, we had done, yeah, fully agree with Yin. So we use a team approach, we consult hematology. They think it's okay. Although probably this is first in men to use impeller in hemophilia, but it's okay. Just give Fanta egg, give full dose, and then from their experience, they said that even major surgery is okay to control the bleeding. So we give those Fanta eggs first, and then we proceed for the procedure. And how to approach this PCI?
Well, I think the most important thing is to determine the right side first or left side first. Yeah. I would like to ask Dr. Li from China.
Will you do right first or left first?
First, I will do a right coronary because of the collector is from the septal to right coronary, and the distal of the RAD, the collector is from one septal to the second septal. So I will do the right coronary.
Okay, and then after you fix the right coronary seems to be functionally total occlusion. But after that, will you do LAD or, of course, Lemon, but from Lemon to LAD or to circumference first?
Let's see what are the opinion from other panelists.
Yes, sure.
Yes.
Before that, I need to remind people, audience here, there's a QR code in the screen. Please scan it, and if you have questions, you don't have to come on stage if you're a bit shy, but do post the question online. We'll try and address it. Maybe Dr. Yin, maybe I'll pass the question to Arun, who is with me.
Yes.
What he would do in terms of, we noticed not just hemophilia, the EF is only 19% as well.
Yeah, there are two important questions and points in this case. It's a very low EF patient, very sick and multi-vessel disease, diffusely disease. So whether to take this patient on impeller first to do this cheap procedure is important. Whether he tolerates this ischemia during the procedure or there may be a hemodynamic compromise during the procedure, it will take a long time. Second question is whether you do it in a staged manner, fix up the RCA now and go to the left system maybe after a day or two, allow the patient to recover a bit. Say third is importantly, if might take on coronary anatomy, right will be the first because it's giving collateral as we discussed to the septal And if for left system particularly, it's left main critical disease, LAD is diffusely disease. I think circumflex ostium is not free from disease also. So though there is a tight disease in the proximal part of circumflex, but the ostium is not free from disease. We don't have a good landing zone at the circumflex proximal segment. So it goes to a dedicated bifurcation stenting of left main LAD plus circumflex, a two-stent strategy.
Okay.
Okay, I totally agree that hemodynamic support is really important in this patient. Besides impeller, because some region of this part of the world don't have impeller, so would you use ECMO support?
We don't use ECMO so frequently, but sort of that we give an intra-aortic balloon pump support, whatever acute result, acute hemodynamic support it gives in our lab.
Okay. Then
Dr. Liang, would you please?
Yeah, maybe I continue the presentation.
Sorry, can I just make a comment? My strategy will be slightly different, I think. From the ECG elevation AVR, I think the culprit lesion is probably the left main and the septal. So I think the patient is quite sick, EF of 19%. I won't go to manual with the right. If something happened, the patient will collapse unless you have the impeller, probably in this case, yeah. So in my lab, we have IBP, we have ECMO, but I'll probably prepare for ECMO, put an IBP in. I'll do the left main and the septal. Just that, and then maybe LAD CTO looks like a very difficult CTO. The RC also CTO as well, so maybe you can consider refer to surgeon and pass the problem to them. Yeah.
Yeah, but I personally would think that the septal branch is so important. So I would rather to do right first because after that I can more comfortable to do the left system. That's my personal perspective. Dr. Lam, would you please?
Yes. Okay.
Sorry for bothering you.
Can you go back to the slide? So thank you for all the valuable comments. And I would like to also share my thinkings on how to handle those trip cases. The most important thing is don't think too much. Actually, thinking too much is no use. Because you will encounter many unpredictable and unexpected situations. However, it doesn't mean that you don't need to plan. Just like our old saying, think twice is enough. Bi-directional thinking, forward and backward, forward for win and backward for lose. To handle those cases, the first thing you must think about the benefit of the procedure. That will the degree of benefit will set the degree of risk that you will take. For example, like this case, we think the benefit is life or death. So it's absolutely very beneficial, very important to the patient. So we allow a very high risk for this case because we do not do the patient must die. The second thinking is think about lose. There is winner's mindset. You must be able to do this procedure at the same time. You have losers planning. Think in which step of your procedure the patient will arrest. For this trip, actually high risk of arrest during the procedure. In this case, we think there are two situations the patient will arrest. One is you touch the left main, and then the other thing is the closure of the septal. So we have to prevent these things. For the closure of the septal, we have think about many things. Actually, I think in this forum, also in our WhatsApp group, we have discussed a lot. There's no way to prevent or the closure of the septal. So we have to think about another way. For example, we do the RC first, and then the RC supply the septal, so that we can reduce the risk. That is our thinking. Traditionally, Dr. Wong say is very good. Traditionally, the highest chance for you to success in this case is to the left main first, and then continue to do. However, if we use impeller support, can we change the thinking? Because the impeller actually very good in support the left side. It support the whole left side, and then it give some reserve or some chance for us to do the right side, and then we do the left side. So is this approach after the improvement in MCS, could we do that? So let's see the case. We believe how to achieve this good outcome is to divide into 3 parts. You have to go in extreme for 3 parts for your thinking, belief, and clinical judgment and planning. And then you have to good skill and good device. For example, without good MCS or good wire, good stand, we cannot finish this case. In this case, we will share our new thinking in handling those trips. We use a teamwork approach. So we will demonstrate a teamwork approach. For this case, you won't be able to finish it within 3 hours. It can be very long in case of complication happen. It can be 7 hours, 8 hours. So maybe team approach is another direction in handling those complex cases. So we go for this case, start with the impeller support. Play the video. Because of hemophilia HIV, we use single access to finish this. We will try to demonstrate to use the impeller shift to finish this whole complex case. You can see on the screen, could you stop the video? Okay, now you can see the screen. We can see the real time, although we had cut some time, but it's a real time. You can see all the things. We cut the unnecessary thing, but in important procedure, we had keep it. And you can see the hemodynamic in real life. From the setting, you see it's just one vasa axis, is the impeller axis. And then we do the PSI through the vasa axis. In this case, the first team finished, and then the second team used around 1 hour to finish the outside. Could you play the video? Could you play the video? So the outside is good now. After multiple stand, ladies, possible? I can't remember. Yes, and then so. BP pulse, everything okay. So we go to the main dish of today. We do the left side. Still same access. Oh, could you stop the procedure? Stop the video. Stop the video. So single access 7 French, because the osteo left main lesion, we can just use JL guiding. And please go to see the time. It's 39 minutes. Then we start to do the left main, start to do the procedure. So continue. Yes. Continue. Yes. Thank you. Yeah, it is a torturous. We try to wire. So every team maybe just maximum 2 hours, because if you do more than 2 hours, you will get fatigued. You will not be able to concentrate. And so this is the second team and help to do the left main. So at 1 minute, we wire the third. And then we dilate with small balloon to avoid no refold. The BP pulse still stable. Fold is okay. So we start to stand the circumflex. And then do the left main. Stop the procedure. Stop the video. So you can see just a few minutes, we start already the standing on the third, and then start and then touch the left main. Can you see the hemodynamic, the BP? The BP was flattened. Yeah, we touched the circumflex. That means the third was occluded. And then we put the balloon on the left main. The fold in the left main will be impaired. And the fold of the left main actually give blood supply to the septal, and probably the wire in the septal. And that's why the fold supplying the septal was reduced. So the patient, in fact, arrest, BP flattened. So maybe we ask the panelists how to handle this situation when the BP flattened. Can you see the BP? Yes. How will you handle in this sort of situation?
I think Lam Ho, I think is a beautiful illustration of use of impeller here. So in this case, I think the LV has more or less stopped ejecting. But yet when you look at the pressure tracing, your mean pressure is still roughly about 80 to 90 systolic, if I'm not wrong. So typically, without the LV mechanical support, a lot of these patients will go into PEA and you'll be massaging the heart. But I think with your foresight of planning in terms of having left ventricular support, I can see that the mean pressure, which is probably the most important here, is still supported.
Yeah, that is also a live demonstration that the case can arrest but can still keep very stable with the MCS support. I want to remind you that if with impeller, it doesn't mean that it can support all the case and support all the situation. Just say by my impression, I don't have study to support or data support. It can only support maximum 2 vessels. If 3 vessels have problem, even with impeller, it won't work. And with 1 vessel, absolutely is okay. If 2 vessels, if you use impeller support very long time, still not okay. You have to settle it in a very quick time. So can you go back to the video? So how to settle this situation? The patient was, you see the BP was flattened. So always think about the cause of the arrest, cause of the drop. So the major cause is the impairment of the blood supply for the whole LV because you bought a shirt and at the same time you stop the septal and the septal is supplying the distal AD. In this fragile patient, EF19, it will cause problem. So how to settle is absolutely you need to very quick restore the flow in left main and everything. Then things will be settled easily. So we can play the video again. We can see the time. We try to settle it within 10 minutes. In those chip case, you see, you open and then the left main, the blood pressure actually go up again. It's not flattened anymore. The pulse pressure have some pulsatile. The aortic valve start to open. So can you stop? You can see, can you stop? Yeah, after opening everything, the left main and everything. And then you can see that the blood pressure actually rise up again with pulsatile. And we are very lucky that we settle it within 8 minutes. So the pressure, hemodynamic, everything restore within 8 minutes. Okay. So in this case, don't think about kissing and anything. Most important, put a stent, open up with restore flow, then you can continue. Those kissing, everything is something later. Oh, okay. Can you replay the video? So the second team already do more than 1 hour procedure. Is actually very tight. Although it looks easy, but actually it's not. Already 2 hours, and so it may go to another team. And also this CTO, we know the septal is very important. We cannot keep the wire very long in the septal. So we cannot use the classic approach, a wire in the septal and then crusade and then puncture this CTO. This CTO, at least CTO score 2. And with some angulation, actually, after you see the video, you know that actually they're with some angulation. CTO score on 2. So the case we first try with Gaia next 2. We try filter, it don't work, and then we try the Gaia next 2, still don't work because the guiding support is not good to doing this CTO. Actually, it's a very old CTO. If it had septal collateral, that means it's very, very old and quite hard. Many of the time, we do CTO always with strong support guiding. That's very correct, and it's 95% case is correct. But you also have to learn to use soft guiding to do CTO. Because in some situation, you will, just like yesterday, we have a CTO webinar also, you have to learn how to do this with soft guiding. So, and then we try, but it's very difficult. So, and some dissection, but we do it very carefully. There's no perforation, everything. Yeah. So now, could you stop the video? So now the first team already do more than 2-hour procedure. We go to the third team to continue to do this CTO. In this case, my happy is to use the filter XTA to feel the hardness, the nature of the CTO, and then I will proceed to guide next fee, because when the guiding is very soft, then you must have a very strong wire to puncture. Could you play the video? So see the time is 24 minutes. We have to quickly finish this CTO. We fast forward, but we do not cut anything. So we use Sky Next 3, and then for those 3D wiring, I don't understand very well, but for me, it's to use a wheel with least force shortening and then change the wheel and least force shortening and move your wire. That's my concept on the 3D wiring. So we had used 4 minutes in wiring. We pace fast forward, but we do not cut. We don't want to cut anything, but show you the most important part. So we 6 minutes. For all this chip case, actually you have to handle it quickly. We found that many of the time the prognosis is related to the procedure time. If your procedure time is too long, many of the time the outcome is not good. So could you stop the video? Yeah, you can see there's a deep angle. In this case, in the old day, if we don't have Gynex 3, I can't finish this case because I need a very strong wire, for example, congress pole to puncture. However, if I can do the puncture, the wire will just go straight. It cannot dip down, but the new wire, it allows you to have very strong puncture power, but at the same time, it can dip down. That's very important to show in device. For example, like this case, Impeller, the Gynex 3, we found that we can't do it. Can you play the video? So, okay, now 2 lumen. So 10 minutes via the CTO, and then we go to exchange wire. And then I first confirm 2 lumen and landing, and then say, stop the video, stop the video. So at this moment, doing our PR review, we know that the septal is very critical. So do you have any measure to prevent the closure of this septal? Maybe we ask the panelists, for this septal, you can never stand, you cannot do two-cell bifurcation. What is your method to prevent the closure of this septal? Anyone has some experience to share?
Yes, thank you very much for the very excellent case so far. So actually, if it is this case, so I have to protect the septal. First, before I wiring the CDO, because we can poke the right away at the outcome of the septal. But in this situation, you already stay away from the outcome of the septal. So far, septal is okay. So now you already across the CDO, but the question is how to protect the septal. As it's inside in this situation, I will use the protection balloon in order to protect the septal. I don't use the gel balloon because gel balloon is the protection is not much as the protection balloon. We keep inflate the balloon, keep that for a while. For this lesion, maybe the 1.5 balloon is okay. 2.0 is too much because can cause the dissection again and triple after we take out the balloon. So 1.5, and then we going up before we standing the crossover that one, and then we deplete that and take it out, and we do the BOT at the final. Thank you.
Yes.
Okay.
Any other idea?
Please go ahead.
Okay, we go ahead. Yeah, can you replay the video? Yes. As mentioned by Dr. Hong, we use balloon inflate, use ATP technique or modified gel balloon technique, but still you see after stenting the septal close. But it's okay. Could you stop? Could you stop? Yeah. That demonstrates another way of thinking how to handle the septal. In prediction, we know that no matter what you do, the septal will close. Like this case, we use gel balloon, inflate 1.5, everything standard. That is already the best method that I know how to prevent the septal closure, but still it closes. However, you see the hemodynamic, nothing happened. Why? It's because already there is some logic of thinking. If we cannot settle this part, then we try to reduce the damage, cut loss. This septal cut, this septal supplying the DSOAD, supplying the outside. However, we already finished the outside, and then we open the CTO. The DSOAD was supplied by integrate, so the septal become less important, and maybe the DSOAD actually give retrograde supply for the big first septal area. So there's nothing changed in hemodynamic. There is also another way of thinking in doing procedure. Don't just face the difficulty in front of you. Sometimes you can turn around and then can help. So please proceed the video. So we just use rewire it and then do a kissing. So can you stop the video? Yes. So the time now is another 1 hour. I got very tired and actually very sweating for doing all this case, and then so we go for our fourth team and to finish, and then I can go to have lunch. And now also a very important thing is don't think this team is not important. Very important. And at the same time, Common also have a lot of knowledge on hemodynamic. At this time, we have to win off the impeller. For us, our thinking is that impeller is inevitable evil. Don't keep it very high P strong support. Beforehand, we use P8, so it can very support. At this time, at this juncture, we already try to reduce the support from impeller. It's P4 now. We reduce the impeller support. Could you play the video? So we handle to another team. So and then to all the optimization of the stand, and then the left wing we just stand, we have not do kissing, the shirt was not optimized. So in handling those case, optimization is something be high, but you must do, but don't do it while the patient is unstable. So kissing, pop, we finish the case. And everything was fine. The patient outcome was very good and still survived. And then hemodynamic, everything is okay. Then because we win the impeller in a very early stage, so now we can win, and then we settle the wound and finish the case. So that is my sharing. How to get good outcome in TRIP is not just do the case. You have to have good outcome. Then you need to have 3 direction to development. In the old day, I forget about device, but now I know that device is very important. We should develop the device at the same time and develop the skill, develop your different approach, and most important also your thinking, your clinical judgment. Many of the time in those cases you encounter complication. If you have complication, then your belief to keep you strong is very important. If you achieve this 3 direction in extreme, then your case, your PCI can go to extreme. That is my thinking during COVID. Maybe I think too much because I cannot travel in these 2 years. Thank you very much.
Thank you, Dr. Lam, for your excellent case. I think this is a really wonderful demonstration of how to deal with CHIP patient with hemodynamic support, logic thinking, well preparation, techniques, skills, and the tools. I think behind this, in addition to the love and the courage, you need patience. So we thank Dr. Lam for his excellent case. Final question. Is there any difference from the conventional PCI in terms of anticoagulation and the antiplatelet regimen during and after the procedure?
During the procedure, no difference. After procedure, you have to consult with the hemat team, work with them to give full dose of factor X. They have to give a higher dose of usual work.
Okay, thank you. Paul, should we end the session because it's 12 minutes beyond the schedule? I would like to thank everyone here, or especially you, to cover the session for me. I thank all the speakers, moderators, panelists during this session. We saw two excellent cases. One is with a large thrombus burden after aspiration, a DCB strategy for diffuse small caliber of the LAD. And the second is an excellent chip case. I think all of you, as me, learn a lot. Thank you very much for your attention. Thank you.
Thank you very much, everyone. And I also thank you all the panelists joining me.
Okay, good afternoon, everyone. Welcome to the next session of the big symposium, the New Technology Part A, Artificial Intelligence. Dr. Eric Wong from Hong Kong. So co-chair with me is Dr. Wen-Lieng from Taiwan. And we have a group of distinguished panelists, including Dr. Sam Min Kim from Korea, Dr. Jae Min Nu from Taiwan, Dr. Yu Shong Go from Singapore, and Dr. Hyun Shok Kim from Korea. So this session is talking about something we may not commonly encounter nowadays, but probably will be a trend in the future, is the artificial intelligence. So here are the session objectives: to know how artificial intelligence can be applied to interventional cardiology, and to know what limits most artificial intelligence implementation and future direction in healthcare. So we'd like to introduce our speaker, Dr. Robert from Canada, and he is an interventional cardiologist and artificial intelligence researcher of the Montreal Heart Institute, affiliated with the University of Montreal from Canada. So Dr. Afram, please.
Good morning, everyone. Thank you so much for the introductions, Dr. Wong. It's a pleasure for me to present in front of this distinguished audience. So I will speak today about artificial intelligence, which is a topic I'm heavily invested and passionate about. Those are my disclosures. Today, my session is divided in three steps. So I will briefly explain what is artificial intelligence. I will share some examples of artificial intelligence application in cardiology, most specifically targeted for interventional cardiology, and then we will talk about myths and limitations and future directions. So what is artificial intelligence? First of all, why should we care about artificial intelligence? Well, a famous tweet said that we should be excited about the future and striving to go beyond the horizon. And I believe with artificial intelligence, we will unlock new capabilities as physicians, improve our efficiency and diagnosis capability, and also spend more time with our patients. So this is the main reason why I'm invested in artificial intelligence, is to make this a reality. So what is artificial intelligence? Well, artificial intelligence is a tool to automatically learn by examples and to automatically determine the relationship between features and outcomes. If we play the video in the lower right corner, you will see in the lower left corner, pardon, you will see that there are multiple connections that exist between in a neural network, and those connections serve to extract features from data such as ECG and associated with outcomes. So if we take a very simple example, does this patient have a STEMI on a 12-lead ECG? Well, with AI, you would show the algorithm examples of STEMI and examples of non-STEMI or normal ECG, and then the algorithm will automatically determine that the ST segment is important based on those examples, and we'll also learn additional features to establish the predictive outcome, in this case, STEMI or not STEMI. As opposed to artificial intelligence or AI, conventional statistics are a tool to determine the relationship between covariates and an outcome using a pre-specified relationship. So in this same example, if you want to build a logistic regression model that would classify an ECG based on the ST segment into a STEMI or not a STEMI, you would predefine the ST segment as an important feature of the ECG, and then you would determine that the relationship, for example, follows the logistic equation, logarithmic equation, and then you would classify the ECG into STEMI and not STEMI. So in short, AI learns from examples. You do not determine the features. The algorithm automatically learns the features based on the examples. And in conventional statistics, you determine the features yourself, and you also determine the relationship. Now, the majority of machine learning or artificial intelligence that we'll present today are supervised learning algorithms. So supervised learning means that you tell the computer or the algorithm the examples, so you give it the answer, and it will try to figure out, based on new examples, what exactly should the answer be. And most of the tasks that we'll present today are classification tasks, meaning that we'll classify certain data into certain categories, as opposed to regression. So in order for artificial intelligence to have a meaningful impact in medicine, there has to be a couple steps to be able to integrate into clinical practice. The first step is data generation. So we had an explosion of digital data generation over the past decade or the past 2 decades, meaning that the majority of our clinical notes, exams, ECGs, lab results are all digital, meaning that they can be analyzed by a computer and they're not physical. Then once you extract the digital data, you have to perform a step called training, meaning that you feed the data into an algorithm, you also give it examples, and the algorithm will automatically learn the features to predict your outcome from that data. But training an algorithm in an institution is not enough. We all have biases in the way we read tests or the patients we treat. Therefore, external validation is important, and external validation is a crucial step for dissemination of AI in medicine. To perform external validation, you take an algorithm that was trained into one center, and then you validate it on data that it has not seen before from a different center. And the more often you perform this step, the more robust your algorithm is. It's not enough to have an internal and external valid algorithm. You also need an RCT to determine positive impact on outcomes. And I will present today to you certain RCTs that use AI in cardiology. And once you have an RCT determining that there is value for this algorithm, you need to deploy into clinical practice. This usually requires integration with current software or hardware, and also requires some engineering knowledge. And once the algorithm is deployed in clinical practice, you can update the algorithm with the new data or new diagnoses. So for example, if you have a ECG algorithm that will tell you the diagnosis on the ECG that was trained 3 years ago, well, COVID myocarditis would not have been one of the possible diagnoses because that diagnostic did not exist, for example, in 2019. So if you have new diagnoses along the way, you need to update the algorithm with those new labels. So that's part of continuous learning and monitoring. Now, there's different types of applications of AI in interventional cardiology. I will share different types today, but the lowest hanging fruit is automated medical test interpretation. For example, you could perform ECG interpretation or coronary angiogram analysis with AI. Also, democratization of care is a really important aspect of AI. So there's been a lot of work done in North America to develop automatic echocardiogram interpretation algorithms to disseminate access to an expert level interpretation in a primary care setting. So you could have a family doctor performing a transthoracic echocardiogram and collecting the data that will be analyzed by an AI algorithm. You could also enhance pre-existing data. For example, as physicians, we're not trained to do ejection fraction prediction using 12-lead ECGs, but actually AI is excellent at this task. You can also integrate different modalities, for example, clinical notes or different genetics, different tests to combine information from a patient across multiple modalities to perform interpretation with AI. And then we might hear in the news or in social media about general AI, meaning an algorithm that is able to create stuff and is good at multiple tasks, but this is part of science fiction. So all the algorithms that we will talk today are narrow AI applications, meaning that they're good at one task they were trained to do. So we will move on to current examples of AI in cardiology, and I'll start with a familiar exam, which is coronary angiographies. So you saw many fantastic cases, STEMI cases in the previous session, and we use coronary angiography as the gold standard for diagnosis and treatment of coronary artery disease. We tend to interpret those exams in the majority of cases, at least in North America, using visual assessment, meaning we are eyeballing the stenosis. And this measurement suffers from significant intra and inter-observer variability. We ask ourselves, can we develop an AI algorithm that will fully analyze an angiogram? To do so, we took 11,000 patients from the University of California in San Francisco, and we also validated the algorithm in red here in 464 patients that underwent coronary angiography in Ottawa. The algorithm had 4 steps. So the first algorithm determined the projection, so which view the angiogram was recorded at. Algorithm 2 determined if there was a left or right coronary present, because we can do angiograms of many different vessels and structures. Algorithm 3 determined the stenosis and also the anatomy. And algorithm 4, once the stenosis was determined, predicted the percentage of the stenosis. So we achieved excellent predictive ability for the projection and also the anatomic structure with greater than 90% sensitivity and specificity and positive predictive value and also negative predictive value. We're able to localize over 93% of the stenosis in the report using AI, and also 85% of stenosis in Ottawa in our external data set. And when we classify those stenosis into severe and not severe, we had an area under the curve of 0.86 with a sensitivity and specificity greater than 80% to discriminate between a severe greater or equal than 70% and non-severe stenosis. This was the first step that was required for more advanced applications of AI in interventional cardiology. And QCA is the gold standard to assess stenosis severity based on visual assessment or based on coronary angiography if you exclude physiological testing. So we also validated our algorithm in 447 patients and 5,000 stenoses using the Montreal Heart Institute Core Lab QCA data. And we're able to identify 100% of left and right coronaries and 80% of the stenosis that were present in the QCA report. This data was of higher quality than the previous data the algorithm was trained on because it was core lab data and it was interpreted by 2 experts. The most interesting finding is in this slide. So the AI algorithm was able to predict the stenosis with a mean difference from the estimated stenosis of 6.5% with a standard deviation of 5.5%. Whereas when you look at humans versus QCA, on average, that's a JAMA Internal Medicine article from 2018, there is a difference between 10 and 17% in a standardized data set. Therefore, AI achieved a lower variability than humans in predicting stenosis severity on QCA. Most of the work done on coronary angiograms involved the use of single images, but coronary angiographies are actually videos, and there is a lot more data comprised in a single video than a single image. So the problem with analyzing videos with coronary angiograms is that the coronary is moving in time and because of the systole of or the heartbeats, and also because of breathing, and also because of traveling of the C-arm. So we built our own algorithm that is able to focus on an area of the coronary, in this case, the proximal RCA, to create a stable video, kind of like a stent boost, but in motion of the area of interest. This is important because if you could feed this type of video to a AI algorithm, you could, in theory, develop new tools such as physiologic assessment based on videos of coronary angiograms, and you could also potentially determine different plaque assessments or also guide procedure. So we're currently working on different applications of this technology of using videos for AI interpretation, but I just want to share with you this case of an acute stent thrombosis. This is a patient that had a stent in the LED to the diagonal, which was larger than the actual LED, and she came back a week later with stent thrombosis. And we applied our AI algorithm here to see if there was actually stent under expansion based on only video of the angiogram. And in this case, you can see the algorithm localizing the stent, and then there's a box drawn in white on the area of interest. And you can see that the algorithm is actually able to track the stent despite the motion of the table. And then we enhance the stent video with a second AI algorithm, and then we build a classifier to use this image to predict stent under expansion. And then we confirm it to the OCT. In this case, the algorithm identified a high likelihood of stent under expansion, and OCT confirmed that as one of the causes of the thrombosis. There was also dissection and other causes, but in this case, we're working on an algorithm to detect or screen for stent under expansion based on coronary angiogram images alone. Next, we'll talk about ejection fraction. So ejection fraction is an important prognosis factor in patients with acute coronary syndrome. And often when we are called for a STEMI in the middle of the night, we do not know the ejection fraction, and we have to wait until the next day to get a TTE. Normally we perform ventriculogram, but there's risks associated with this procedure. There's also additional contrast use. We ask ourselves, can we use AI to analyze the coronary angiogram to predict the left ventricular ejection fraction? To do so, we took patients from UCSF, 4,000 studies of patients that underwent a coronary angiogram within 3 months, pre or post angiography. So within 3 months from the angiogram, the patient had a TTE, and we match the angiogram with the left ventricular ejection fraction value. We train and validate the algorithm within UCSF, and then we also perform external validation at the Ottawa Heart Institute on 776 patients. The algorithm would localize the left coronary artery and then would use a video of the left coronary artery to predict the ejection fraction. When we look at the performance of the algorithm, we achieved over 85 to 90% sensitivity and specificity in an area under the curve of 0.91 to classify a left coronary video into LVEF lower than 40% or greater than 40%. The mean absolute error in the left ventricular ejection fraction predicted by the AI algorithm compared to the TTE was 7%. And we had similar results in our external validation cohort. Most interestingly, when we analyzed the data stratified by presence or absence of acute coronary syndrome, we actually had a similar performance, and we had actually excellent specificity and acceptable sensitivity to detect low ejection fraction. The mean absolute error was 7.6%, and we had excellent Pearson correlation and intraclass correlation with the ejection fraction predicted by AI with the one obtained from TTE. So we can also use AI to teach us. So we can also use AI to teach us about different features that are important to determine the ejection fraction. In this case, we can see that the systole of the left coronary artery is what is actually being used by AI to predict ejection fraction for both normal and low EF. And we took this a step further. We actually integrated this algorithm in our cath lab workflow. So we built this software where all the data that we record in the cath lab goes into this software, and we can actually predict ejection fraction in almost real time as we're doing the procedure. And we're not conducting a prospective study to assess the validation of this AI algorithm to detect ejection fraction in patients with ACS. Next, I'll talk about acute coronary syndrome. So there's different etiologies of acute coronary syndrome and plaque rupture and STEMI or STEMI. The majority are caused by plaque rupture, but there's actually 25% of patients that have plaque erosion. So understanding of plaque morphology can lead to personalized management of ACS. In this case, we also know that in the erosion study, patients with ACS and plaque erosion and OCT could be managed without stenting. The problem is that some operators do not have expertise in OCT interpretation, and they cannot actually detect the plaque erosion diagnosis. So we asked, this is a recent study that was published about a month ago, looking at automatic analysis of OCT to identify plaque erosion. They built a model that was internally validated and also externally validated, and they achieved excellent sensitivity of 92% and specificity of 89% to determine the presence of plaque erosion. Next, the most interesting aspect of this study is that inexperienced readers, when assisted with AI, could actually increase their performance and reach an experienced reader level, showing that there is use in this type of technology for automatic OCT interpretation. I will just briefly, because I'm a bit short on my time, talk about ECGs, but there's been AI applied to different modalities. I just shared today the coronary angiographies. There's also a lot of work done on ECGs or CT scans with AI. And a study that should be of interest is the detection of ejection fraction or reduced ejection fraction with 12-lead ECGs. This is a paper in Nature Medicine that's shown that AI has excellent predictive capability to detect low EF, lower than 35%. And the authors actually performed a randomized controlled trial where they randomized primary care patients to AI-based screening for ejection fraction, for low ejection fraction or usual care, which is physical exam, and they were actually able to increase the yield by 30% when they used AI on ECGs to identify a low ejection fraction. And we can also use AI on wearables. This is an example of using a camera of a smartphone to detect type 2 diabetes. This is a study I led 2 years ago, and the app is currently available and can basically screen a patient using a camera on a smartphone for the presence or absence of type 2 diabetes. And we're currently conducting a prospective study to determine the validity of this tool. You can see here the areas of the signal that are predicting the type 2 diabetes, and the smartphone app is available here. I'll just briefly conclude with the myths and limitations of AI in cardiology. There are several myths that are present that I would like to dismiss today. The first one is that AI can replace the physician. So in medicine is ultimately a human enterprise, meaning that there is no AI algorithm that can replace the physician's empathy or communication. However, AI can assist the physician in making better decisions or faster decisions in test interpretation. The other myth is that AI is smart. Actually, AI is just be seen like an advanced statistical model that is good at the narrow task that it was trained to do, if the data does not differ too much from the data it was trained upon. So there's a lot of, there's actually no fundamental understanding of the concepts that it was trained to do. It just learns by example, by mimicking the features. The other myth is that AI will make diagnosis or take decisions. So I believe that, and there's proof now that there's current AI algorithms that are approved, for example, by the FDA to perform certain diagnoses, but the physician will always have the final word because there is responsibility that a computer cannot exert. And finally, the final myth is that AI is a black box. So I've shown you today that while it's impossible to achieve interpretability of AI algorithms, we can actually highlight areas of the image that are important in the prediction. So we can better understand how AI is working. This is a tweet by an ophthalmologist that published some papers on AI, but as doctors, we like to understand why or how we're basing our predictions. So we use, for example, the CHAT score in atrial fibrillation, and we understand how each variable is mapped to the outcome of stroke, for example. But with AI, we have to shift from explanatory to predictive power. AI in general is much better at predictive power than conventional models, but you sacrifice explainability from that. The most important thing is that AI is not smart and there's biases in the data. And if you use AI in your practice, you have to ask yourself, was the AI algorithm trained on data similar to the one in my center? Finally, I want to share with you this picture. So this is an AI that can generate images, and others asked to generate banana bread, and it generated, bread with bananas sticking out of it. It's just to show that it doesn't really understand concepts like banana bread, and it will just generate both words independently, and such errors can also happen in medicine. This is resources if you want to get started with AI. You can review those later. And as closing remarks, next slide. I believe AI will automate and enhance aspects of cardiology. I've shared with you today certain applications of AI in interventional cardiology, like automatic stenosis and QCA prediction, stent or expansion detection, and left ventricular ejection fraction prediction from coronary angiograms. I believe a cardiologist with AI tools will perform potentially better or equal to cardiologists without AI. And we must all work together to implement this technology into routine clinical care, and also study the impact on patients and workflow, and also getting regulatory approval. Thank you very much for listening and for inviting me. This is the team I'm working with at the Montreal Heart Institute, and I'm ready for the discussion.
Thank you very much, Dr. Afram, for giving us very insightful talk on the artificial intelligence. So your talk is now open for discussion and comments. So may I just kickstart with a question about the AI LVEF assessment. So, when doing the angiogram, different operators like to use different angles. So the angle of projection may not be standardized, first of all. And the second is, say, for example, if I have a STEMI case with an occluded LED, so the proximal part of occluded and beyond that part, we don't see the vessel yet. So if I take the cine image of that angiogram, will it still be possible to use the AI algorithm to estimate the ejection fraction, because part of the vessel is not visualized, or we need to visualize all the vessels before we can do that?
Yeah, so that's two great questions. For the first question, we described today, or I shared today, the performance on taking any view of the left coronary artery. What we found is if you take multiple views, especially, let's say, 1 or 2 cranial views and 1 caudal view, which all operators do in a routine diagnostic angiogram, the predictive power or the classification power actually increases significantly. So there is additional data available when you combine multiple views in the prediction in a single view, but it actually works very well on any of those views of the left coronary. And in the paper that's soon to be published, we actually stratified the performance according to the different projection, but the performance does not change drastically. Now, the second question that you asked regarding the occluded vessel for use of this algorithm, we are currently conducting a validation study looking to enroll 250 patients with STEMI or NSTEMI. So some of those patients have occluded vessels, and we're looking at the predictive power of the algorithm based on the routine coronary angiogram during the first images of the coronary angiogram where the vessel is occluded. Right now in the study, we have about 60 patients that were enrolled out of the 250 in our center, and the performance of the algorithm when you use the images where the vessel is occluded compared to the TT that the patient will have in the next day is actually lower than if you have the vessel open. However, there could be stunning or some wall motion abnormalities present when the vessel is occluded that recover as you open the vessel. So it is also possible that the ejection fraction that we detect is the real ejection fraction at that moment. This is hard to say because we don't have a simultaneous echo. What is clear is that the ejection fraction at the end of the, determined by the angiogram at the end of the procedure has about 5% error rate in this study compared to the TTE. And in patients, we note that there is an improvement in ejection fraction in some patients with STEMI. And those patients, at least in a very small number of patients that we enrolled in our study, have more favorable outcomes, meaning that there's less kidney injury, less mortality, less arrhythmias in hospitalization at 30 days. That's what we found at the moment. So it's possible that the delta of the ejection fraction based on AI from pre and post PCI in STEMI patients is actually a valuable prognostic indicator to be determined.
Okay. Thank you. So any comments or questions from Singapore or from Taiwan?
Okay, can I raise the question? Excellent presentation, amazing achievement. This is the very first time for me to hear that there is a researcher trying to do the coronary angiogram from the cine. As we all of us know, that when you're reading the coronary angiogram, you got to select the optimal angles and images for the machine to analyze. Because in your study, do you pre-select the very first frame for machine to analyze, or you let the machine to do the cine, to analyze cine? Because when you're doing the neural analysis, it will take huge amount of data. So my question is, do you pre-select images, or what kind of hardware do you use? Like the supercomputer or like some kind of GTP arrays? Thank you.
Great question. Thank you for the question. So for the two questions, the first question, in the first work, we present to the algorithm a single image of the stenosis, of the blockage, but we present all the frames where that stenosis was found from all the projections. So we get predictions from each image, then we average it out for an artery segment. And we use the final prediction that we display to the operator and that we correlate with the cath report. Now, we're also working on videos, and the video is a similar approach. So if the stenosis is seen in 2 or 3 projections, we will use those 3 projections to compute an average value rather than use a single projection. And like a human, we take the stenosis as in the projection where it's the most severe. So we actually present that in that circumstance. Now, the computer we use for training the algorithm could be seen like a supercomputer, but it's in the order of, it takes graphic cards, and it's the order of $40,000-$50,000 to have a computer to analyze those images. And yes, it does take a lot of data. We have over 200,000 videos of coronary angiograms that are used to train the model. But then when we want to deploy it into clinical practice, we actually need very few computer power. So just a computer with a basic graphic card is able to do AI predictions. To put it in perspective, you could use your smartphone to do AI predictions, but you need a big computer to train the algorithm to determine the weights and of the neurons initially. So you use a supercomputer to train, and then you use almost any computer with a graphic card is good for prediction or inference.
So thank you. Are there any questions from the panels? Okay, please.
Yeah. Hi, Robert. Thanks very much for your talk on AI. I just wanted to ask regards to angiogram, because for us, what is useful in the cath lab is to calculate the syntax score. And at the moment, it's very cumbersome because we have to manually calculate and score each lesion. So are you planning to come up with an AI algorithm for us to automatically calculate the syntax score?
Great question. So the work we've done at the moment can be seen like building blocks. So in order to get to the syntax score, you need to be able to tell, is it a left or right coronary, what's the anatomy, where are the blockages, and then you also need to provide additional data like bifurcations, calcification, diffuse disease, etc. So this is the first step to map the stenosis to artery segments. We're currently working with Boston Scientific, analyzing the syntax trial results to actually determine the other characteristics of the plaque that are required to calculate a syntax score. And our goal here would be to have an automatic syntax score calculator, and also potentially just classify patients into PCI, CABG, or both as a suggested therapy based on their anatomy beyond the syntax score. So we're definitely working on that, but it is a more challenging task because of so many variables that need to be integrated across multiple views and across heterogeneity of practice from the different operators.
I'm very, very sorry. I have to apologize to a speaker and the panels and our audience because the BIOTRONIK staff asked us to stop right here for the lunch. So I know this is a very interesting topic, and I think most of us, all of us, are eager to learn more about artificial intelligence. Especially, I come from a hospital. We have a new dean, and he's very interested in artificial intelligence. That's why our hospital also invested a lot amount of human resources and money in developing artificial intelligence. I would like to extend this discussion more. However, I can't. So at the final moment, I would like to say some take-home messages. As I think most of us, perhaps 95% of us spend our time in a cath lab or in a patient care. However, there were 4 fields that we need to pay more attention to. First is cutting edge intentions. The secondly is this artificial intelligence. I know some hospitals already put the artificial intelligence to their practice, like the screening, the the ECG at the emergency department, so that there were no more cases of the overlooking the acute STEMI ECG. Another one is regeneration therapy, the cell therapy. I know some hospitals are already begin this treatment. And thirdly is the precision medicine, like the genome-based treatment. I think these 4 fields deserve our attention. I can say no more. Thank you.
Okay. Good afternoon, ladies and gentlemen. Welcome to the scientific session on mechanical circulatory support. I'm Wen-Lieng from Samsung Medical Center, Seoul, Korea. I'll be chairman for this session. Serving with me as the co-chairman, Dr. Lee-Wa Tam, consultant from Kwang-Hwa Hospital, Hong Kong. In this session, we have 4 topics. Each presentation will be limited to 8 minutes. Please try keep your time limit. I'll chair 2 topics, and Dr. Tam will do the other 2. This session objective is optimal candidate for mechanical circulatory support. In particular, which patient is more suitable for each mechanical circulatory support. And we can run complication management during insertion of daily monitoring of impeller. And finally, we can learn the value of implementing our cardiogenic shock network shock team and role of interventional cardiologist. And I'd like call on Dr. Jonathan Yep from National Heart Center, Singapore. Our first speaker to present identification of patients who need MCS. What does the guideline tell us? Please, Dr. Yep.
Very good afternoon, and I'd like to thank the organizers for inviting me to give this talk. I'm Jonathan. I'm from National Heart Center, Singapore. And today I've been asked to talk about a very interesting topic, basically identification of patients who need mechanical circulatory support. What do the guidelines say? So if you guys know a little bit about this topic, this is actually an extremely difficult question to answer, and in clinical practice as well, we struggle to say, does this patient need MCS or does this patient not need? So it's a lot of a clinical judgment. Today, I'd like to go through a couple of important points. One, the definition of shock, because only when we understand the different stages of shock can we more align which patients will need MCS. Second, I'll go through a little bit of evidence and a page or 2 about the guideline recommendations. And lastly, a little bit about existing protocols. All right, this is a very important slide because we know that shock has a downward spiral, or what we call the death spiral. If you don't stop it in time, things are going to just go downhill from there. So if you have a patient with insult to the heart, there's a decrease in cardiac output. This will lead to various consequences, decrease in blood pressure, vasoconstriction, you don't correct it, it goes a spiral after spiral, it leads to decreased organ perfusion, and more ischemia, and the heart gets hit even more. So the idea is try to identify the patient, in need of support and try to get him before he downward spirals. So this is the updated SKY classification. I think all of you all know about this. I'll just briefly go through. There are 5 stages, A, B, C, D, E. A is, this acronym is very easy to understand. A is the patient at risk and not yet in shock. B is the patient at the beginning of cardiogenic shock. C is a patient in the classic cardiogenic shock. Stage D stands for deteriorating. The patient is deteriorating despite support. And E is a patient in extremis. All right, I'm just going to bring your attention to stage B and stage C because that's really the patients that, we struggle to identify and decide, what to do. In this table here, you can see in stage B, the patient in stage B may have hypotension, meaning blood pressure less than 90, 60 or tachycardic. But the most important point about the patient in stage B is the organ perfusion is still normal. So for example, an important variable to measure at this stage is the lactate. The lactate usually in these patients, even though they may have relative hypotension, is usually still all right. When you're in stage C, that's where organ perfusion is not good. So your lactate is high, and you eyeball a patient. For those of us who see patients regularly, he or she doesn't pass the eyeball test. You look at him, something just doesn't smell or feel right. So the patient generally looks pretty unwell. And of course, when we go to stage D, this patient is deteriorating, despite mechanical support or that you have instituted or despite inotropes. And E is the patient who is already about to collapse or in extremis. Okay, I want to talk a little bit about very briefly about the inclusion criteria of some of the clinical trials that included patients in cardiogenic shock. These are the 4 trials. And I want to bring your attention to the inclusion criteria as you see it. So most of them have the criteria of systolic blood pressure less than 90 for a period of about 30 minutes or requiring of inotropes to maintain such a pressure. And then most of these trials also include the important criteria of organ hypoperfusion. So it's important to understand what the inclusion criteria is because, to bring you back to our title, we are trying to identify the patient that will benefit from mechanical circulatory support. This is a quick summary of some of the trials of MCS. Basically, if you look at IABP Shock 1 and Shock 2 trial, no benefit. And if you look at some of the different trials on mechanical circulatory support, once again, this meta-analysis shows, once again, no difference between control and MCS. And so because of these trials, these are the guideline recommendations. In 2017 ESC STEMI guidelines, they recommend short-term mechanical circulatory support, caveat in patients with refractory shock, and it's only a 2B recommendation. And because of the 2 IABP shock trials, they recommend that routine use is not indicated. That's a class 3. And as this is routine use. And in the 2018 guidelines on myocardial revascularization, they basically said the same thing, short-term mechanically circulatory support, you consider it dependent on the patient's age, comorbidities and neurological function, as well as what you predict his quality of life will be. Once again, this is a 2B recommendation. Same likewise for IABP, routine use is a class 3, which is not recommended. So then, with the guidelines saying like that, how do we identify this patient? Let's say, you see a patient who's sick, and how do we decide, does he or she need mechanical circulatory support? And my talk today, is really not to tell you which device to use, IABP, impeller, depending on what you have in your institution, but really to say that, hey, this patient needs something more than inotropes. So there's this concept of the shock team, and one of my later speakers will go into that in depth. So this is just one slide to just crystallize this concept. So the concept of the shock team is very important. Usually in some centers who have formed this team, this may include a heart failure cardiologist, an interventional cardiologist, a cardiac intensivist, a cardiac surgeon, some perfusionists, cath lab staff, and as well as critical care nurses. And usually this team is activated almost like a PERT team or STEMI kind of activation, and then there's a quick multidisciplinary discussion on what to do. And these are the results of some of these shock team and shock protocols application. If you look at these 4 studies, the formation of a shock team and shock protocol has led to improvement in survival in patients presenting with cardiogenic shock. Quite significant, if I may say. So I'm just going to go through 2 protocols, and I want to highlight 2 very important points that may help to formulate, how we identify this patient who may benefit from cardiogenic shock. If you look here in this diagram, they say that if the patient is in refractory shock, okay, then you start considering MCS. And how do they define refractory shock? So 2 things. One is lactate. So if your lactate is high, despite of what you want to do, then this patient is open to strong consideration for starting some mechanical circulatory support. Number 2, there are some hemodynamic indices used. I think some of my speakers may go into that a bit more. I just want to highlight this CPO, which is the cardiac power output. And it's calculated quite easily by using your MAP times your cardiac output divided by 451. If it's low, some people use 0.6, some people use 0.9. If it's low, you should seriously consider instituting some extra support beyond what you're currently doing. This is a very big initiative that started in the US, the National Cardiogenic Shock Initiative. It's a very wordy slide. I'm not expecting you all to read it, but just suffice to say that they have come up with a very specific protocol that tells you when to start mechanical circulatory support and gives you numbers to say that, hey, you can take off this support in the cath lab, or do you need to go on to get extra support, or do you need to bring the patient on this current support to the ICU? What I want to highlight is two important points here, and this may help us also once again in our identification of the patient who may benefit from MCS. So the inclusion criteria for this is hypotension, less than 90/60, and or use of inotropes to maintain such a pressure. And number two, very importantly, evidence of end organ hypoperfusion. So clinically, or maybe using lab markers like lactate. And then in the cath lab, you quickly obtain your venous and femoral access, for your PCI. And then you do a quick either right heart cath to look at your cardiac index, or you can just put a picture into your LV to get your LV EDP. And just simply put, LV EDP more than 15, or your cardiac index less than 2.2, they say you put impeller. Of course, this may be a bit too extreme, in our Asian setting, but that's really a framework to consider in our mind. So in this review by Tilly is one of the lead investigators in many shock trials, as well as a big name in the field of cardiogenic shock. In this review in Euro intervention, he kind of put it very nicely. So when should you consider MCS? Basically, it's a multitude of factors. Number one, you have your multidisciplinary shock team that makes a discussion, because your shock team is different from a shock team in another hospital, because you know what your hospital has and what your hospital practices is like. So you all discuss. So that's important. Number two is you need to access your vascular access. These guys, femorals and all that are crappy, then that precludes quite a lot of device use. If you have some of these variables, that will help, like as I mentioned, your cardiac power output and your cardiac index from your right heart cath, and a quick measurement of your lactate value. There's this vasoactive inotropic score, but just to put it simply, you kind of look at how much inotropes is the patient on. Is it very high doses? Then that common sense, this patient is not doing well. Or is it just very low, like maybe dopamine just a 5 or NOAD 0.02, 0.03, you're not so worried. So basically the amount of inotropes being used to support the patient is a very important variable to consider as well, and that's very practically available. And of course, if the patient is at the extreme end, really collapsed, looks really bad, then these patients, no matter what you do, it may not help the patient. So that's why the shock team is very important to discuss when not to institute therapy. So just in quick summary, I would like to say that the current evidence for mechanical circulatory support is really mixed, and patient selection is really complex but extremely crucial. So this is really important to have a protocolized multidisciplinary approach, and depending on your institution's own expertise, experience, and whatever resources you have. So every hospital may be a little bit different from another hospital. Thank you.
Thank you for excellent presentation regarding optimal candidate for MCS and shock team approach for the treatment of cardiogenic shock. And we'll have discussion time at the end of the presentation. And next speaker is Dr. Sunny Chang from Queen Elizabeth Hospital, Hong Kong. His topic is which MCS for which patient? Do any studies support its use? Please, Dr. Chang.
Good afternoon, colleagues. I'm Sunny Sang from the Queen Elizabeth Hospital. It's my pleasure to be speaking in this symposium. And my topic today is which MCS for which patient.
Dr. Chang, please.
Can you hear me? Hello?
Yes, I can.
Yeah. Hello, I'm Sunny Sang from the Queen Elizabeth Hospital. Today's my topic will be on which MCS for which patient and the related evidence for the MCS. So I'm going to start off with a case that we commonly encounter in our unit. It's a 57-year-old man. He has a history of hypertension, hyperlipidemia. He was admitted to a hospital with a new onset chest pain and left bundle branch block. And on admission, he was already on inotrope support with the blood pressure around 109/84. And the echo already showed a poor ejection fraction of 20 to 25%. And with that presentation, we took the patient to the cath lab immediately for a primary PCI. As you can see from the angiogram, it's a severe left main disease plus triple vessel disease plus the RCA is a CTO. And we put in the IBP immediately to support the patient because the patient was in cardiogenic shock. We used the IBP because it was readily available at that time. And soon after the angiogram, the patient further deteriorated with lowering blood pressure, 80/42. And then he required further noradrenaline support. And the blood pressure was still very borderline. And we proceeded with the PCI anyway, because we wanted to revascularize as quickly as possible. And but during the procedure, the patient went into cardiac arrest. We had no choice but to escalate the support to the ECMO. And we completed the revascularization to the left main circumflex and the LAD, and we took the patient back to the CCU for close monitoring. And on arrival to our unit, as you can see, the patient had very narrow pulse pressure, and the wedge pressure was very high at 40 millimeters mercury, and the patient was still dependent on a high dose of noradrenaline. And you can see on the X-ray, the lungs are very congested, and the LV is barely contracting, and the aortic valve is not opening, and you can see some spontaneous echo contrast in the LV as well. So the patient is on ECMO, and he's going to need some venting strategy. So we also inserted the impeller CP for the LV venting. As you can see, after the insertion of the impeller, the wedge pressure dropped significantly from 40 to 12. And the patient was gradually stabilized, and his lactate level came down, and he subsequently was able to wean off from the inotropes as well as the ECMO support. Around a week later, he was more stabilized, and then he was able to be discharged with hip rehabilitation. And you can see from the echo that his ejection fraction was much improved when he was weaned off from the ECMO. So this kind of case now very commonly occur in many of our units right now. In the past, we have only the IBP available or the ECMO for the MCS, but now we have many different options to choose from, like the impeller, the tandem heart, which is not available in Asia commonly, and also the ECMO, and also combination of these devices. And the main objective of these temporary MCS is to improve the cardiac output by reducing intracardiac filling pressures, reduce LV volume, wall stress, as well as improving the coronary perfusion and the tissue perfusion. And as mentioned by the previous speaker, we now use the SKY staging system to stage the level of shock. And it's shown that the prognosis is directly related to the SKY shock stages, with the best prognosis in stage A and poorest prognosis approaching 70% in mortality for stage E. So therefore, timely patient stratification in the stages should be performed when we diagnose the patient with a cardiogenic shock. And at the moment, although we have many options of MCS to choose from, and many more are still emerging, but none of them have been proven to be better than the other, and or they has been shown in randomized studies to improve outcomes. So none of them are really not proven to improve the outcome yet. And these devices are also resource intense therapy. They require much resources, either financially as well as manpower. And different MCS has different characteristics, you can see, in terms of the support they can provide, the cannula size, the ventricle they may support, and they also have different complications and contraindications. And to decide on which MCS device to use, we need some hemodynamic measurement, accurate hemodynamic measurements. That's why that's why invasive hemodynamic monitoring is very important. The pulmonary artery catheter, the Swan-Ganz, will guide us on what type and what level of shock the patient is in and what kind of device the patient may need. Also, after the implantation of the MCS, it can help us to monitor the patient's progress and also subsequent complications. And several observational studies have shown that the PA catheter are associated with improved outcomes, particularly in conjunction with short-term MCS. And the ACC actually give the Swan-Ganz catheter a 2B recommendation. And for decades, we have been using the IBP. Since 2012, the IBP Shock 2 trial, which showed that the routine use of IBP in cardiogenic shock is not helpful, not improving mortality, and subsequently, the routine use of IBP is now given a Class 3 indication by both the European and the American guidelines. And the overall use of the IBP in the management of ischemic cardiogenic shock is decreasing over the years. So is there really no role for the IBP? There's still some situation in which the IBP may be useful, like in the situation of mechanical complication from AMI, such as acute MR or acute ventricular septal rupture. In these situations, the IBP may still has some help and is given a Class 2A indication in the ACC guideline. And also in decompensated heart failure with cardiogenic shock, IBP may still be useful in providing some temporary support for the heart to recover as well as for waiting for transplant. And the impeller was introduced around 10 years ago, and it was shown to provide more hemodynamic support than IBP. But in the ISO-shock trial, the impeller 2.5 did not actually improve the mortality comparing with the IBP. And even with the use of the impeller CP, which was supposed to provide more hemodynamic support than the 2.5. In the IMPRESS study, there was again no significant improvement in terms of the 30-day mortality and the 6-month mortality. In the longer 5 years follow-up, there's still no improvement in the outcomes. The VA ECMO can provide up to 7 to 8 liters of cardiac output, as well as gas exchange. And evidence for the benefit of VA ECMO in cardiogenic shock is based on some non-randomized studies reporting survival ranging from 33% to 60-something%. And this study from China shows early ECMO-assisted primary PCI in STEMI is showing some benefits. But we know that the ECMO, although providing good organ support, they at the same time increase the afterload to the LV. And we often see the problem of a closed aortic valve and a bloated LV, as well as a LV thrombus. And ECMO often require a venting strategy. So, and it is shown that in the LV, that LV unloading was associated with lower mortality in patients with cardiogenic shock treated with VA ECMO. So a venting strategy is often needed when we use the VA ECMO. So when we have the hemodynamic information that we need, we can decide on when to initiate the MCS. And there are studies showing that earlier initiation of the MCS, be it the ECMO or the impeller, is associated with better outcomes if you initiate early. So in summary, the IBP may still be beneficial in certain patient group, like those high-risk patients waiting for CBG or heart failure patient waiting for transplant. The impeller may be promising, it's showing some promises, but we're still missing some randomized and high-quality data to show that it's effective in cardiogenic shock. And for ECPR, ECMO may improve some survival. And taken together, the ECS, ESC, and the ACC guideline give the MCS a Class 2A recommendation for the cardiogenic shock for temporary support as a bridge to recovery, bridge to cessation, and a bridge to bridge strategy. So it is increasingly recognized that it is not actually the device that matters, but standardized protocol, as mentioned by the previous speaker. This kind of standardized protocol-based approach may improve the outcome of the cardiogenic shock. And just like the chain of survival in cardiac arrest, there's also a chain of survival in cardiogenic shock. And the early use of the MCS, in some cases, forms part of this chain. So we need to recognize the patient is in shock, recognize it early, support early, and then intervene early. But we need to bear in mind that unselected use of MCS is not supported, and the standard team-based approach may improve the outcomes. So this is my final slide. In conclusion, temporary MCS, they are rapidly evolving, and they have become an important part of the management of cardiogenic shock. And multiple platforms are commercially available, but they each have their own pros and cons. But there's evidence for benefit is still scarce at this time. So we need a high-level expertise to effectively address issues like device selection, timing of treatment initiation, device troubleshooting, and post-implantation care. And with that, thank you for your attention.
Thank you for your excellent presentation regarding optimal application and timing of mechanical circulatory support. We have 10 minutes for discussion of our first two presentations. And I'd like to introduce our distinguished panelist, Dr. Danon Keos from Thailand, Dr. Deborah Lee from Singapore, and Dr. Chien Van Do from Vietnam, and Dr. Ho Rem from Hong Kong. Who is first? It's very difficult situation to when and how application optimal timing to MCS for cardiogenic shock patient. In particular, as I mentioned earlier, the prior PCI for AMI cardiogenic shock patient, prior application for PCI is associated with a better clinical outcome. But non-AMI cardiogenic shock patient, it's very difficult to determine optimal timing of MCS. What is your thinking about that?
Yeah, I think that's a very valid point that we struggle with every patient. You know, if we start too early, did we subject the patient to unnecessary intervention? Or if we catch the patient too late, have we gone past that window where he could have benefited early? So I think if we look at the stages of classification, somewhere in stage C will be an ideal spot to consider the patient for mechanical circulatory support. We have been, at least some friends and I, we've been kind of thinking, stage C is actually a very broad group. Obviously, not all patients, if we see so many patients in stage C, and if we were to subject every one of them to mechanical circulatory support, it will be, your whole ICU will be full. So how do you pick up that patient within stage C who will truly benefit from MCS? So I think some ideas that could go through your mind is like, you can look at the different lactate levels, or if you have a right heart cath, pointing one way or another, that like your CPO that you can calculate is not so good, or your wedge is high. All these are really warning signs, and maybe not just like 15, 16, or a wedge that's a bit higher. And the last thing that I mentioned earlier is also like how much inotropic support, is the patient on to support him. If you're just on a low dose, you are fairly okay, but if you are using increasingly higher doses, that's another sign that you probably need to take note of. And once again, I want to emphasize the importance of having some protocol as well as a team-based kind of decision to make that collective decision whether mechanical circulatory support will help to benefit the patient. I think that has shown in many studies as well as in the literature that to be of good benefit.
Yeah, Can I ask a very basic question? In terms of the requirements for the definition of the cardiogenic shock, one criteria is the lactate. However, when we care the patient, we found that it's very frequently for the lactate to exceed the 2. So is it that surrogate marker too sensitive, or is setting too low?
Yeah, it's very critical comment to define cardiogenic shock. We usually define the cardiogenic shock as a low level of lactate less than 2.0. And in previous cardiogenic shock registry and trial showed most patient lactate level less than more than 2.0 milliliter per liter. And the other question and comment?
Just in addition to what Jonathan mentioned, in terms of timing for insertion of MCS in cardiogenic shock, I think there is a difference between acute on chronic heart failure cardiogenic shock and also acute AMI leading to cardiogenic shock. So I was involved in shock team when I was doing my fellowship in the US. So we have this shock team discussion where we discuss about what's the endpoint, what's the chance of recovery and all that. We have this discussion. And usually when we decide on the type of MCS to put in, if it's usually acute and chronic heart failure, because they already have biventricular, they have the ventricles has conditions, they're dilated. So they're more, they don't acutely like deteriorate in comparison to like cardiogenic shock due to AMI. So they usually try balloon pump, and then if the mixed venous saturation is still low, despite that, they will escalate accordingly. Whereas in cardiogenic shock due to AMI, the ventricles are not conditioned and usually involves primarily LV rather than biventricle. So there is more tendency to escalate immediately to MCS. I mean, that's from the experience of being in the shock team during the fellowship year.
Yeah,
could I make some short comment? Okay. I think this topic is huge. It's very difficult to talk in 10 minutes or something. May I just give 3 short comments? The first thing is we focus a lot on early MCS support, but actually some cardiogenic shock or many cardiogenic shock can be settled with early revascularization. I think we don't forget about this point. Because I think everyone had this experience in the old day, we don't have MCS. Early revascularization sometimes can stop the shock. The second comment is you must you must know that cardiogenic shock and cardiac arrest, they are 2 animals. How to manage cardiogenic shock and how to manage cardiac arrest is another story. Cardiac arrest already flattened, the patient is collapsed. That means this stage E or stage E beyond stage E. So in stage E, can you find any study evidence? No, that is something I want to remind. And the third thing is you have to pay attention to many truthful things in clinical so that you can manage those cardiogenic shock. Like Dr. Sunny Zhang's presented this case, patient poor LV with APO and severe MR. BP borderline. In this sort of case, we know that once you change to noradrenaline, the systemic vasa resistance will increase. The heart cannot pump the blood out, and then we will increase the congestion in pulmonary circulation. We focus a lot on white heart cath and before that and all this hemodynamic. Also, we have to bear in mind that the patient actually had 2 circulation. One is pulmonary, one is systemic. The white heart cath assess the wedge is assess the pulmonary circulation, may not be able to assess the systemic. And that are my 3 short comments on MCS and early revascularization or management of shock. And difficult to give a very detailed explanation or conclusions based on time because it's a very complex and huge topic.
Actually, I agree with Dr. Lam that the thing that very important and have the mortality benefit is the revascularization in the acute MI and cardiogenic shock. So, but we also need to, I think there is no way to just know in one time that the patient need a mechanical support or not. I think we need to follow the patient. If the therapy that we give the patient cannot maintain the hemodynamic, that may be the time that we need the mechanical support.
Yeah, can I have a comment?
Yes.
Yes. Yeah, so a few years ago, we used to use the IABB for most of the cases when we have a CS. But nowadays, after the COVID-19 pandemic, we use more ECMO-supported strategies. However, we don't have an impeller in our cath lab, so sometimes we are very struggling to deal with the NV loading. So we don't know how to do the venting. Sometimes we use a catheter like a pigtail. We put in the NV and to vent the NV, but the effect is not so good. So it depends on the way how you choose the method of support. we think that now we have a more experience with ECMO, so we are using more and more ECMO compared to the IAPP.
So Sunny, maybe.
Okay.
Yeah.
Okay, we have two important issue: optimal candidate and optimal timing. The optimal, I think, the optimal candidate stage B, C, D is more suitable for impella, and stage D, E is more suitable for. We don't have any ICT. Optimal timing of MCS, but we have ongoing two trial regarding optimal timing of ECMO, Euroshock, and ECRS shock. ECRS conducted by Dr. Tille, IV trial, corporate shock trial conducted by Dr. Tille. And next year, Dr. Tille will present the result of Euroshock trial regarding optimal timing of ECMO in AMI patient. So each time limitation, we move on to next two speaker. And can you introduce next two speaker, Dr. Tam, please?
Thank you, Dr. Yang. So introduce my colleagues, Dr. Chui Ga-long is current consultant just in Prince of Wales Hospital, Hong Kong. Today, his topic is troubleshooting in insertion and daily monitoring of impeller. Chui Ga-long, please.
So thank you, Chairman, panelists, ladies and gentlemen. So I'm going to Dr. Chui Ga-long from Prince of Wales Hospital, Hong Kong. So I'm going to share with you the topic today is troubleshooting in insertion and daily monitoring of impeller. So when I first started my impeller program in 2016, I encountered many problems. So the first few problems are access problem, anticoagulation issues. We have to keep the ACT exactly around 160 over 180. There's also positioning problem, suction problem, and also problem of hemolysis, especially in Chinese because of the LVs. Sometimes acute cardiogenic shock, the LV is not yet dilated. You may experience more than hemolysis than maybe other country. So first of all, I would like to talk about the S problem. So you don't want to see this in the cath lab in any interventional procedures. So especially if you're doing the impeller, which is a big sheath. So what I'm now doing is using a lot of ultrasound and micropuncture technique. So there's several ways to do so. One is short access approach. Mind you, even though you do the short access approach, there's tendency to stick high. The other is you have to align the needle parallel on top of the artery before you do this short access approach. And also the skin entry point should be at the same distance as the depth of the vessels. And then you align your needle attack angle to be 45, then needle entering artery at the point of the ultrasound. So now I'm doing more and more long access approach. You can visualize the whole path of the needles. And sometimes you can see the femoral head below. So this is to illustrate how I do it. So I usually screen up and down. So this is the bifurcation. I move up the pop. This is the common femoral. So I move up 1 centimeter above the bifurcation so that I got blade out procedures like cover stand, need some landing zone. So then I put an artery forceps underneath the ultrasound probe and do the fluoroscopy. So this is my entry point is the mid-femoral head, and this will be perfect. So I do it like a longitudinal way, align the needle. So I enter the artery 1 centimeter above the bifurcation. You can see the femoral head below, so I'm entering at the mid-femoral head. And then I put the guide wire in. So before I upsize, I usually do an angiogram, make sure I make a good stick. You need a single front raw stick. You're not sticking everywhere. And if you give heparin later on, there will be hematoma. And then after the procedure, if you decided to bring the impeller to the floor, so you need to remove the pure away sheath and reinsert the reassessor sheath. That is usually a tapering sheath. The tip is 9 French and the body is 14 French. So at the same time, sometimes you during the sheath exchange, the hole get bigger, you got peri-sheath bleeding. And what I did nowadays is to secure the impeller with two stitch that has a forward tension so that it won't come out. The other thing, I would do a figure of 8 stitch and put a 3-way and to tighten it to control some of the minor subcutaneous bleeding. So this is the way I did to control some of this minor bleeding, and also two stitch to keep the sheath forward to make sure it doesn't come out. So the other problem I encounter is the ACT problem. So the principle is to keep the ACT 160 to 180, so to minimize the risk of bleeding and keep the pump working. So the patient is on MO as well, I will keep the ACT slightly higher, and it should be a protocol-driven management. Otherwise, the CCU nurse will call you every hour for adjustment. So the purge fluid is usually heparin containing. If you are bringing the impeller to the floor, you can be heparin free during the PCI procedures because you also gave heparin. So this fluid is to prevent the blood entering the motor system. So if there's blood entering the motor system, the motor may stop working. So the purge fluid is a heparin containing dextrose solution. And the amount of fluid given is determined by the machine itself. So it has to keep the purge pressure above 300 millimeter mercury to prevent blood entering into the motor. So the purge fluids can be a dextro 5, dextro 10, or dextro 20 solution. And I said before, it can be heparin-free during the procedures, but it's usually recommended to give heparin in CCU or ICU. So initial company recommended 50 units, which is pretty high dose in Chinese population. So if you use a dextro 5 solution, so the amount of purge fluid given will be higher because of the decreased viscosity. Say, for example, if you use dextro 5 solution, on average, 10 to 15 cc of purge fluid is given to the patient. If you are given 50 units per cc, which equal to 500 to 750 units of heparin per hour, which is a lot for a Chinese patient. So the ACT is sky high. So I have some bleeding complication initially when I do this protocol. So I adjust the protocol to reduce the heparin dose to 10 units or to 25 units of heparin per cc. Thereafter, I experience less bleeding complication. And I think Chinese or some Asian patient is small and heparin sensitive, so I reduce the dose of heparin. And if additional heparin is used, I would give a separate line for heparin infusion. So the third problem is the impeller position. So impeller position is very important. So it has to be like 3.5 centimeters below the aortic annulus. So nowadays we have the smart assist. They may tell you the impeller position, whether it's right or wrong, LV or out, went deep into the LV or went out into the aorta. But you still need to know how to interpret the placement signal and also the motor current waveform. So I will talk about it later on. So usually the echo is the main choice, but you can do it in fluoroscopy on chest X-ray. So this is the typical normal waveform you will see. So you will see because the placement signal waveform is usually come from the pressure sensor in the outflow. So placement waveforms will be aortic, and the motor current is pulsatile. It means the inflow and outflow is in different chamber. So if you see this, the placement signal is ventricular and the motor current is flat, it means it is inside too deep into the ventricle. Right. Likewise, if you see an aortic waveform but a flat motor current, this means the impeller is inside the aorta, and both inflow and outflow is in the same chamber, means both inflow and outflow is in the aorta. So I've got a case, 54 years old AED doctors, type 2 DM, urgent coronary angiogram because of STEMI and cardiogenic shock, show distal left main 90, osteoarity 90, osteostress 95, went into severe cardiogenic shock. Before proceeding to PCI, we insert the impeller first because usually the PCI would introduce more ischemia to the LV, and the patient would make worse before he come back, improve later on. So if he or she is in cardiogenic shock decompensated state, and you initiate PCI, then the patient will do worse before he could do better. So he needs some support before you proceed to the PCI. So after successful PCI, patient was sent to the floor, and the ward call me. You see this placement signal is aortic and the motor current is flat. That means the impeller is too far out. You can see it's on the chest X-ray. So this is the chest X-ray. Usually I would add a line in. So this is the traditional teaching of how to differentiate mechanical aortic and mitral valve. So above the line is the aortic valve is too far out. So normal should be like this, 3.5 centimeters below the aortic annulus. So I'd like to skip some of the slide, but this is important. So how to do the repositioning in the bedside, you need to unscrew it. You say if you want to insert it back, and then you screw it back and do it under the echo guidance. You have to tighten up the chewy, otherwise the impeller will move. You have also likely to tighten the chewy at the back. Here, like this. So finally is the suction alarm. So why suction alarm is usually because of the inadequate pillow, RV failure, or the inflow position of the impeller is underneath the papillary muscle and mitral valve. So how to check the pillow? You check the CVP, you check the capillary wedge pressure, or non-invasively, you could do the echo for IVC collapsibility, but this is not applicable if the patient is on positive pressure ventilation. Alternatively, you can do the passive leg raising test. You do the echo at the LVL flow tract, and more than 15% increase in stroke volume predict fluid responsiveness. You can calculate the PEPI, which is a non-invasive as well, which is a Swan gang reading to assess the RVL flow, RV function. So the surrogate marker for the RV function, PEPI more than 0.9 means adequate RV function. So the other is the inflow is trapped under the papillary muscle, which you cannot do much about that. If the patient impeller is positioned too deep, you may need to put it back. So what I recommend is you cannot adjust the position after it's being inserted. So when you do the position the pigtail into the LV, I would recommend you to do it in the RL wheel and use the angle pigtail. If you use the straight pigtail, you go underneath the papillary muscle and you'll be trapped when you put the impeller in. And then thereafter, you cannot change the position. So I would recommend you to do it in the RAO wheel and make sure it's not trapping under the papillary muscles. Sorry, this is the last, but I think it's the most important. It's very commonly seen if the patient is on impeller, and probably because of the small LV in Chinese or Asian population. So this is a patient and STEMI, critical AS, poor EF, ejection fraction 15 to 20%. We didn't have time to do the CT for the TAFI screening, but the patient went into cardiogenic shock APO requiring BiPAP and also developed acute renal failure. So we proceed to BAV and then impeller, followed by PCI to the culprit RCA. So this is quite common if you see a patient who has hemolysis while in impeller. So every blood result is hemolyzed and you receive this urea. And the impeller is positioned too deep, so you need to put it back. So it can be due to inflow problem, cannulation, cannular obstruction, or outflow problem. But the management is to return down the P level by 2 in case of massive hemolysis, and check the pillow, check the RV function, and also adjust the impeller position. So sorry for the delay, and thank you for your kind attention.
Thank you, Gala. Actually, it's quite comprehensive and also a very insightful talk. So very informative in regarding the troubleshooting. So we leave the discussion at the end of the second talk. So the second talk will be presented by Dr. Wen-Lieng. So he is currently the consultant in National University Heart Center, Singapore. His topic is who is fastest, mobile team, emergency department, or CALEF? Value of implementing a cardiogenic shock network or shock team. So Dr. Lin, please.
Hi, good afternoon. Thanks everyone for being here on a Sunday afternoon. These are my disclosures, but I think the biggest disclosure I have for this talk would be that I'm a heart failure cardiologist. I am not an interventionist in the whole room of interventionists, and I don't do primary PCIs. So that's important to bear in mind. So today we are going to try to cover what we understand, how we understand cardiogenic shock in 2022, and I'll try to reinforce the importance of a cardiogenic shock team. What are the components of a cardiogenic shock team? And then maybe we can try to be better and faster. How do we do that? We'll have a discussion on that. So current paradigms in cardiogenic shock have largely been covered by the speakers before me. So we know that cardiogenic shock is a state of critical cardiac output, low cardiac output. If you don't address the cardiogenic shock, it will go into a death spiral, and eventually the patient will not be able to be revived. Of course, cardiogenic shock it is defined by low blood pressure or the need for vasopressors to support the blood pressure. increased filling pressure to the left ventricle, and signs of end organ hypoperfusion. All these three must be together to make the diagnosis of cardiogenic shock. And in this day and age, we often use the SCAI classification to determine the severity of cardiogenic shock and how to approach the patients at each stage, which was also covered by my previous speakers. Then came the idea of a cardiogenic shock center. We have seen many device trials failing to meet any efficacy outcome, failing to show one device being superior to another in the treatment of cardiogenic shock. Why is that the case? Are we not selecting the patients good enough? Are we not having good enough devices? Probably a mixture of everything, but I think the main thing is we need to have a systematic way of treating patients in selecting patients for cardiogenic shock, and that is why over the last 3 to 5 years, this concept of cardiogenic shock shock team really came to the forefront. And in the European Heart Journal, as well as in the American side of things, they all recommend for a comprehensive cardiogenic shock team, identifying cardiogenic shock centers and developing a network for the treatment of cardiogenic shock patients. So this is how we think we are able to improve the outcomes of cardiogenic shock in this day and age. And of course, we have also touched on a protocolized treatment strategy for cardiogenic shock. And the most famous strategy or protocol that we often hear about would be this National Cardiogenic Shock Initiative protocol. And the few things that we need to take away from this cardiogenic shock protocol would be, number one, they advocate for MCS prior to PCI, not PCI, see how things go, and then if the things don't go well, we insert a MCS device as a bailout. Probably too late. We want to have door to support time rather than door to balloon time. And of course, they advocate for right heart catheterization even before doing anything to the coronaries or instituting mechanical circulatory support. And if we do it right, we can see a potential benefit in this table. So for the past many years, 20, 30 years, the quoted mortality rate for cardiogenic shock has been around 50 to 60%. But in the NCSI protocol, although it's a single arm, non-randomized cohort, they see that if they do it right, they do the patient selection right, and they institute mechanical circulatory support early, we are going to see about a 70% survival from cardiogenic shock, which is remarkable for such a sick group of patients. So, summarizing all the current available data, I came out with this summary slide. So how do we manage cardiogenic shock? What is the most recognized and agreed upon state-of-the-art treatment strategy for cardiogenic shock management? Number one, use lactate for risk stratification. The eyeball test doesn't work in this day and age. Second, develop a network, a hub and spoke network of cardiogenic shock centers. If there's this center which cannot have cardiothoracic support, identify the next nearest cardiogenic shock center and immediately send the patient there if need be. Have a hemodynamic guided decision making. Liberally use the right heart catheter. So that is something that we need to think about in the middle of the night before we do any intervention or coronaries. Maybe we need to know the hemodynamics a little bit better. After we recognize the hemodynamics of the patient, of course, it is always very, very tempting for me to want to do the coronary revascularization, open the artery, save the patient. But maybe that is not the way. Maybe we should think about support before revascularization, and that really requires a big paradigm shift in the thinking of all my interventional colleagues everywhere around the world. Of course, then the thing about team-based decision-making, cardiogenic shock team activation is what I'm going to talk about today. So what is a cardiogenic shock response team and who should be activated? Why is there a need for such a complicated procedure for the treatment of one patient? Well, the cardiogenic shock response team is actually a whole system, not a group of people. And the cardiogenic shock team should actually be started before hospitalization. We need to work with our EMS. Like in Singapore, we have our emergency ambulance system recognizing STEMI before they even reach the hospital. Maybe you can move it a little bit more, push them to recognize cardiogenic shock on top of STEMI before they reach the hospital. And when that happens, they can choose to either direct the hospital, the ambulance to a cardiogenic shock center, or at least get the receiving hospital to be aware that how this patient is very, very sick. Then we tap on the current existing 24-hour services, such as the emergency department, the 24-hour cath lab service, as well as the coronary care unit to run this cardiogenic shock team service. The people who are involved usually would be the interventional cardiologist who is on call for the day, the intensive care physician who is running the CCU at that point in time, cardiothoracic surgeon, and a heart failure cardiologist. And if we do it right again, we have this paper telling us that a shock team approach, rather than just the device that we use, potentially can improve the outcome of patients with cardiogenic shock. So that brings us the question of why then patients are still dying of cardiogenic shock? Is it because we are not fast enough, we are still slow in revascularizing the patient, or are we doing something wrong? So now we look at the traditional route of a patient being sent to the A&E in cardiogenic shock. The ambulance service will recognize a STEMI, they will send to the emergency department, the emergency department then triages the patient, calls the cath lab, the patient goes to the cath lab, undergoes emergency angioplasty, then the patient will go to the CCU. If the patient needs further mechanical support or further hemodynamic monitoring, that would be in the area of the CCU. They will decide there and then. Is this the best way to do it? I think the consensus now is no. So this change in utilizing our current resources must take place for the patients to benefit from a cardiogenic shock team approach. So we do not have new infrastructure being set up. We are still dealing with the emergency department. We are still dealing with the cath lab. We are still dealing with the CCU. It's just a change in mindset and implementation of a shock team protocol that is going to make the difference. For example, when the patient reaches the emergency department, a lactate can be done to re-stratify, or maybe I can even suggest a point of care lactate can be performed in the ambulance itself. So that would move the diagnosis of cardiogenic shock upstream earlier. Then in the A&E, if they think that the patient is not doing well, they have the liberty to activate the shock team or divert the patient to a cardiogenic shock center. In the cath lab, before doing anything, I would urge patients who are in cardiogenic shock to receive a right heart cath up front. After getting the right heart cath, if the patient is really an impeller, for example, or mechanical support candidate, the support should go in before the revascularization. And throughout this process, it's not one person making the decision, but 4 or 5 heads coming together to see what is the best strategy for the patient. Once the patient finishes the revascularization, everyone should be in the loop of the patient's condition, the current level of mechanical support, the current inotrope support level. Then the patient is moved to the intensive care unit where the intensivist carries on the treatment. So this is a tight, well-oiled machine that will improve the patient survival when they present with cardiogenic shock, not just the mere device that we are using. So in summary, we are witnessing a paradigm shift in the cardiogenic shock management, and I hope that I brought this across to you over the short 8 minutes just now. And I feel that a protocolized management of cardiogenic shock should be implemented in every healthcare system. Since most hospitals already have 24-hour services like A&E, CCU, and cath lab, we just need to restructure, re-protocolize the whole cardiogenic shock treatment strategy to fit a cardiogenic shock team. So in conclusion, I think instead of being faster, which I think we are all very fast already, we need to be better by improving our protocols, improving our workflows, and improving communication amongst the different subspecialists. And the key is not one person making the decision on the treatment strategy, but a whole group of very experienced subspecialists coming together to iron out what are the best ways to approach this patient. Okay, with that, I thank you.
Thank you, Dr. Lin. It's an excellent presentation. So it's not just fast, but very concise and touched upon. Yeah, thank you. So now the 2 talks is open for discussion. Any question or comment from the floor? So maybe I ask Galong, so can you elaborate a little bit more on how to adjust the impeller bedside? I guess it's very difficult to insert the impeller back to LE if this is jump out to the aorta.
So usually I would do it under echo guidance, and I adjust like 2 centimeters, and then I recheck the echo, and then adjust further by 2 centimeters, just like empirically and under the echo guidance.
Yeah, but without the guide wire, I guess it's very difficult.
Yes.
Do you need to twist or any?
There's sometimes tortuosity in the iliac system, so the torque is not being transmitted to the tip, so you may need to push in a lot before the tip even started to move. So it's just if you have a strict aorta iliac system, this is not a problem. So this is not easy, I must say.
Thank you.
So I have a question for all of you. So whether you support first before you do the PCI or you do the PCI, because sometimes, as Lam Ho said, sometimes you may settle with inotropes, you may settle with some intracorneal adrenaline, and you finish the procedures. But sometimes if you proceed to PCI, the patient usually did worse before they get better. So if they cannot, survive that adverse events, so the patient may went into cardiac arrest and CPR. So what I have impression is if the PCI is simple, then I perhaps would support with adrenaline or noradrenaline and then proceed to the PCI. But if the PCI is very anticipated is very complex, I restore the flow and then I do the support before I proceed to further PCI. So what do you think?
Yeah, Gala, it's a very difficult question. I guess it's most of the time depend on the clinical setting, the patient, and sometimes it's the anatomy. So let's say if the patient is really shock and very unstable, probably in that type of patient will be simple. Usually I must actually to support the patient first and then go back to the anatomy. But in case it's rather borderline, let's say the blood pressure is still okay, but the shape look is not that good. Probably in the case, you still have time, we have support with some inotropes, and then we look at the anatomy. If it's a not very complex lesion, probably we can tie over with a really, quick approach to tackle the lesion. But instead, if this is a complex anatomy that we expect that the procedure will be prolonged, then we may again go to support the patient first and then before proceeding to the PCI. So I think it's very difficult, but I guess more or less nowadays is shifting the paradigm to supporting patient first if really be in cardiogenic shock and then going for the PCI. Any comment from other colleagues?
Maybe I answer. I cannot say it's an answer. I just share my view and experience. For early presenter and simple procedure, go for PCI first. For late presenter complex procedure, go for MCS first. This is for cardiogenic shock. For cardiac arrest is another animal, another story. For cardiac arrest in front of you, adrenaline, and then quickly revascularize, and then ask your team to bring the Lucas, because you are not just focused on the heart, you focus on the brain, save the brain and save the heart. And Lucas, and then before the MCS available, you should finish the PCI, then the patient can survive. So separate in two conditions to consider. Cardiogenic shock and arrest are different story.
Okay.
I also have a question to the panel. How frequent do you see acute ischemic limb in a patient that you have to keep the impeller on, especially in CCU with the repositioning sheath? And how frequent do we have to put in the distal perfusion cannula?
Kalong, can you answer this question?
Usually for impeller, we don't need reperfusion. So for MO, you need it most of the time. So probably because of the tapering sheath. So actually the incident of limb ischemia is not that common, although I've seen 1 or 2 cases that I need to put in the reposition sheath. And before the off table, you need to, or during the procedure, you need to check also the limb. But of course, if you have, before you off the table, you may Doppler assess the distal pulse before you come off and assess whether you need to put in a sheath before you take the patient off the table.
Because I'm not sure, sometimes when you take the femoral angiogram using the micropuncture dilator or smaller sheath, the distal flow is good, but when the 14 French goes in, I'm not sure whether there's any value in taking the angiogram once again just to see the distal flow, because there have been cases of some ischemic limb happening as well, although the caliber, although we did all the workups like CTA, autoiliacs and all that to be good, but sometimes I'm not sure if in Asian population, the caliber tends to be smaller.
Yes, of course. Patient can also have peripheral vascular disease, and also Asian patients tend to be smaller. So this is quick questions. Limb ischemia is an issue, but it's not that common for ECMO, I would say.
Yes, thank you. So maybe I ask Dr. Lin a question. So in Singapore, in your practice, you mentioned about designated shock centers. So I just want to ask, any issue in patient in a regional hospital without a designated shock team? So patient in a very bad shape, you be concerned to transfer this type of patient from regional hospital to designated centers. And in Hong Kong, sometimes we had also had a designated ECMO center. So our practice is to put in an ECMO in the regional hospital and then transfer the patient to a designated ECMO center. So how's the practice in Singapore?
I think Singapore is largely the same as how you described. We have the advantage of being very, very small. So going from one end of the island to the other end is like 30 minutes. So generally, the ECMO centers in Singapore, we have this ECMO retrieval service. So they service roughly about half of Singapore. Each center services about half of Singapore. And upon referral from our regional hospitals, we take the phone call, we assess whether we need to activate the ECMO team, and we will send our ECMO surgeon down to the site to assess the patient. And if he or she thinks that the patient requires ECMO support, then the mobile ECMO team will go to the regional hospital, implant the ECMO, initiate the flow, and then bring the patient back to the cardiogenic shock or ECMO center. So that is what is being performed in Singapore. We are even thinking of, instead of calling it an ECMO retrieval, we might want to shift our paradigm to a cardiogenic shock retrieval. Maybe the patient is in a regional hospital but doesn't really need ECMO. Maybe can get away with impeller. Maybe you just put the impeller pump and the impeller console in the ECMO ambulance and initiate impeller in the regional hospital and transfer the patient back. So that is something that we might be thinking of in the near future.
Good.
Dr. Tam, it's time to close.
Okay.
Please introduce key learning and conclusion.
Yes, thank you, Nguyen. So I guess this type of mechanical surgery support did rationalize the practice of interventional cardiology. So now we are more, comfortable in certain sense that we can tackle more complex lesion, and also in patient encouragers, so we can support the patient first and then go for the procedure. The patient will have better outcome. But mind you, this type of device still have this drawback, especially they are large bore catheters. So starting from the beginning, starting from the vascular access, you need to be careful. Maybe the practice of using ultrasonic guided puncture is very important so that you can prevent the complications from the start of the procedure. And afterward, so the monitoring is still very important because the patient can be deteriorated, or sometimes the patient actually get improving trend. So you need to timely remove the mechanical surgery support. Otherwise, the complication will be developed. So again, I really appreciate the suggestion that a designated shock team and also a well-written protocol for the both doctors, nursing, and multidisciplinary team is very important in order to improve the survival and the outcome of the patient with cardiogenic shock. So with that, I really thanks all the speakers. They highlighted the main point of using this device in this scenario. So again, I thank the co-chair, Dr. Nguyen, with me for co-chairing this excellent session. Thank the speakers, thank the panelists to share their experience. So with that, I thank you for your attention for this meeting, this section. So now I conclude this section, and then we go for coffee break, and then we have another section regarding the new technologies. So stay tuned. Thank you. Okay, welcome back to the last but not the least important section of this big symposium. So this is the new technology part B, resorbable magnesium scaffold. I'm Liver Thames from Hong Kong. Co-chair with me is Dr. Wen-Lieng from Taiwan. So he's now in Singapore. So the section objectives of this session is to review the available data of resorbable magnesium scaffold and current applications, and also to learn more about the next generation resorbable magnesium scaffold. So this section again will be, I've been very honored to have two speakers. And then I will introduce the first speaker of this section is Dr. Ying-Xin Chen from Taiwan. So he is going to discuss with us, will the resorbable magnesium scaffold prove the concept? So Dr. Chen, please.
Thank you, Dr. Tam. And today I would like to provide a talk. The title is, will the resorbable magnesium scaffold prove the concept? As Dr. Tam mentioned that the main objective of the talk is going to provide you the most updated data of McMurray's. And we are going to talk about how the clinical data goes now. And we are now focusing on the concept. What kind of concept? Well, the believer of the resorbable scaffold is that after the resorption, there will be no more chronic mechanical stress over the vessel wall. And there will no more chronic inflammation over the stress over the vessel wall. And also preserve the vessel motion when the scaffold was completely resorbed. And when the scaffold was now completely be reabsorbed, and they were going to become a kind of a genuine de novo vessel. And the believer would think that the risk of the late events will become lower, including the device thrombosis and potentially to reduce the new atherosclerosis in the future. And with the complete resorption of the scaffold, they provide further future treatment potential, including the potentially KBG in the future, or sometimes we are expecting a new growing of the vessel. Well, McMurray is coming to the market in 2016. It's a magnesium containing the scaffold, and the scaffold resorption begins in 3 months. And after 1 year, 95% of magnesium was resorbed. And right now it comes with 6 different sizes. And during the BIOTRONIK 4 trial, it's 4 sizes during the study period. And the marker is tantalum on both ends of the scaffold. The scaffold straw is 150 by 150, and the crossing profile is 1.5 millimeters. It's a sirolimus eluting scaffold, and right now with over 2,000 cases of clinical trial data and also post-marketing survey. Well, in the past, we had a lot of data understanding the performance of the McMurray's from BIOTRONIK 2 and 3, and now we have BIOTRONIK 4, and most of the literature has been reported was coming from the first cohort. And today we would like to focus on the full cohort data. In addition to the BIOTRONIK 4, there is a lot of clinical trial that is now been kicked off, and including with the focus on imaging study and also with acute chronic syndrome indication. So we're going to focus on the BIOTRONIK 4 now. And as all of you know that the BIOTRONIK 4 have been reported the first cohort data, and the study design is probably try to enroll most of the eligible clinical cases and to have the complete follow-up. The primary endpoint is the target lesion failure, and including some of the second endpoint, such as cardiac death and scaffold thrombosis, etc. And by far, the most updated data is coming from the full cohort, 2 years data now. The BIOSOL-4 involved more than 200 sites, and in Asia Pacific, there is about more than 6 countries have been involved, and in Taiwan, there's 4 institutes that are devoted to BIOSOL enrollment. In the BIOSOL-4 study period, all the cases have been followed their 4P policies, including the patient selection and to select the proper scaffold size to fit the lesion. And most important of all is the pre-dilatation, Magnesium implant, and post-dilatation. The follow-up is pretty good. From this figure, we can see that more than 95% of cases has complete 2 years of follow-up. And this is the baseline characteristics in the full cohort. The mean age around 62 with 74% of male gender. And the lesion distribution was now shown on the right upper panel with more than 50% located in LAD lesion. And most of the cases was presented include with the history of diabetics is 21%, and history of myocardial infarction is also 21%. And the study also enrolled acute coronary syndromes. So in the full cohort, it is estimated that 18% of the cases was non-ST elevation myocardial infarction. And as for the lesion complexity, the B2C contains 15% of the cases. And although the study excludes bifurcation lesions, there's still 5% of bifurcation in BIOSOL-4 studies. And this is going to be the full cohort report data. For the target lesion failure rate, after follow-up up to 2 years, is 6.8%. And the initial 1 year follow-up is about 5% for the TLF rate. For the number, it can be compared with the contemporary drug-eluting stents from BioLink's, BioResort, and BioFlow 5 studies. The data was numerically pretty similar, comparing contemporary drug-eluting stent. And when you compare with the previous absorbed BRAs, the 2 years TLF rate was about 7.1%. For other safety issue, considering the scaffold thrombosis, after 2 years of follow-up from the full cohort, it's now 0.8%. And the data by the first year of the follow-up from the full cohort is also 0.8%. It means that after the 1 year, there is no further additional scaffold thrombosis. And if you exclude those who had the early depth interruption, then the scaffold thrombosis rate was only 0.4%. And following by other safety profile, the cardiac death after 2 years is 0.5, and the clinical driven TLR is 6%, and the target vessel MI is 1.6% by the end of 2 years follow-up. So this is what I just mentioned, comparing the first year and the second year of the BIOSOL-4 data from the full cohort. And the TLF and the scaffold thrombosis was really satisfactory. And if you compare further with the data from the other clinical trial, such as BIOSOL-2 and 3, I think the early trials, which had less number of cases enrolled, had even a better TLF and scaffold thrombosis from the data. So by reviewing the full cohort of BIOSOL-4 data after 2 years of follow-up, it demonstrates the excellent safety and efficacy. And for the target lesion failure rate at the end of 2 years is 6.8%, and the scaffold thrombosis is 0.8%, and which is demonstrate a very good, excellent performance. And we have mentioned that if you exclude those early depth interruption, the scaffold thrombosis is only 0.4%. So this is now with all the clinical trials targeting the DREAMS 2G as so-called Magnesium scaffold. And we had 2 years of the BIOSOL-4 full cohort. And we also have the 3 years of the first cohort data. And now we have 5 years of BIOSOL-2 data. By the time goes, the TLF rate increased a little bit. And maybe it's one of the issues that make us concerned using the Magnesium right now. But the performance comparing with the contemporary drug using stent is pretty much similar. So before ending my talk, I would like to share some of our clinical experience from our institute. And most of the cases come from the BIOSOL-4 studies. In our institute, we enrolled only 14 cases with a mean age of 65, and we did not enroll any cases with acute myocardial infarction. And all these cases was now enrolled following the regulation of the BIOSOL-4 study criteria. And we have now the case developed scaffold thrombosis even now, and the B2 cases only 21%. And this is one of the case, 64-year-old man with multiple cardiovascular risk factor present with a CCS class 2 angina. The lab showing pretty good condition. We preserve LVEF, myocardial perfusion scan showing large area of the ischemia over anterior wall and also some other part of the heart. The case was done in 2018. And we begin with case selection, coming with the coronary angiography for the lesion selection. From this projection, we can identify a lesion at the proximal LAD, and the lesion was around 70% of stenosis from the angiography. And the lesion length is probably acceptable and fit the BIOSOL-4 study. And the right coronary angiography here, showing the patent RCA now. So after the selection of the lesion from the angiography, and we decided to perform the OCT and to identify the scaffold size. And from the right panel, we can identify the lesion length around 15 millimeter. And in proximal and distally over the lesion, at the distal part, the diameter is around 3 millimeter. And more proximally, the diameter is around 3.3. So after the selection, we decided to perform the pre-dilatation with non-compliant balloon using Pentaradiol 3x12. And after angiography, there is a minimal residual stenosis. So we implant Magnesium 3x20 as we have been planned from our OCT information. And we post-dilate the lesion with 3.25 non-compliance balloon. And this was the post-procedure OCT showing the good apposition of the scaffold. And this is the final angiogram. And the residual stenosis was minimal. And after 1 year, the patient present angina. So we decided to perform the angiography follow-up. And from this projection, we believe that there is no identified restenosis from the angiogram. And for this case, we do not perform OCT after the angiography follow-up. So by now, it's around 3 to 4 years after the scaffold implant. And the thallium scan this year showing the pretty good result. So I'm going to end my talk now. And from the BIOTRONIK 4 cohort study, the data shows really satisfactory. And from my clinical experience, the case is also doing well after 3 to 4 years. Thank you.
Thank you. Thank you, Dr. Chen, for the excellent presentation. Now the talk is open for discussion, and we are honored to have a list of panelists to interact for this section. So they are Dr. Ellen Chen from Hong Kong, Dr. Jianjin Chen from Taiwan, Dr. Junyao Hao from Taiwan, Dr. Gala from China, and Dr. Mohammed from Malaysia. So any question or comment? So maybe I take the lead to ask Dr. Chen. So from your presentation and also from the BIOTRONIK 4 studies, now with the 4P, concept, the scaffold now is proven to be safe. And so do you think it's a time for more complex lesion? Let's say, for example, today we are talking about more STEMI cases and for long diffuse disease cases, bifurcation lesions. Do you think it's time for us to use this scaffold for more complex lesion?
Well, there's two kind of concept discussing the complex case. As for the bifurcation issue, from our clinical experience, and maybe if you didn't notice my case, in my presented case, there's a small diagonal branch were located over the lesion is around 1.5 millimeter and was spanning by my scaffold. And after 1 year, the vessel was still there. So if the procedure, the scaffold is going to cover a vessel with a side branch, I think it's a safe method because the scaffold will going to be absorbed in the future and the side branch will not be gelled. But if you try to open it with additional side branch technique, I think I'm not quite sure it will be works in this case, in this condition, because we do not have adequate data. We do not have enough trial to prove the concept. And for additional complexity regarding the vessel with severe calcification, I think it's still a very, very difficult task to overcome with any scaffold, because you may see most of the scaffold will absorb in the future. Otherwise, you will develop the scaffold thrombosis years later. So the scaffold will gonna be reabsorbed within 1 year or even quicker. I think to maintaining the vessel structure is very important. But if the vessel was really calcified, I think the recoil issue, even 3 years or 1 year, 3 months or 1 year later can be happened. So for complexity lesion with heavy calcification is still the main niche for the future application of the scaffold. Thank you.
Yes.
Thank you.
Dr.
May
Tan,
I
may I ask a question?
Sure.
Sure.
Please.
Thanks. Thanks, Dr. Chen, for your excellent presentations and the informative experience. And I think, as you mentioned about that, from the BIOTRONIK 4, there's still some complex case like the calcifications and the bifurcations. And I'm very curious about the results. of such kind of patients while performing, because this is a real world issue we will encounter, of course. So just I want to ask you just answered that, the tiny diagonal branch, how you deal with that. What if there are some gel, you need bifurcations techniques? Okay, and the other is that so do you think that how much calcium can you tolerate in your experience to put this kind of stents? Because we have some measurement for the very calcified lesions, but as for the very tiny lesions, what's your experience? Thanks.
Okay, I will try to answer these two difficult questions. I think Professor Lee was also on site. Maybe he can also give us more comments. And regarding the clinical outcomes from such as B2 or HA type C lesion, well, because we do not have the subgroup analysis data right now. And in our institute, we have 14 cases in our BioSorb data. And we also experienced some cases with target lesion failure. And the component for the complexity is vessel calcification. And so that's why I keep talking about the difficulty to dealing with heavy calcified lesion by far using the McMurray's. And so in our experience, we did experience some target lesion failure in a more complex case, especially with the vessel having heavy calcification. And as for the tolerances that we can accept to use McMurray's of the calcified lesion, I think I do not have answer now. And from BioSorb 4, if the lesion needs rotablation, I think it's not the suitable case right now for McMurray's. For those patients with end-stage renal kidney disease, is not in the case right now because a lot of issue. I think the chronic calcification is also one of the points that we should consider right now. Thank you.
Thank you. So Gala, how are you?
Hi.
Hi. So what do you think about the future about this Marriott in China or over the world? What do you think?
With regarding the absorbable staining, I think two things we should keep in mind. One is how to reduce the scaffold, the strata thickness. You know, some late events, from my point of view, I think maybe related to the very thin, the scaffold strata. Another thing is how to maintain the radial support. I think, you know, in China, we have 2 or 3 domestic absorb the scaffold, but based on our limited experience, the completely absorbs time per duration, maybe more than 2 years. So compared to magnesium scaffold, the only 1 year completely absorb, I think it's too long. So for the future, the scaffold, I think 2 things. One is reduce the scaffold strata thickness. Another one is control the absorb time period. Thank you.
Thank you, Gala. So anyone comment?
Yes, Alan from Hong Kong.
Yes.
So I just want to ask the panelists on the moderators any opinions, because we are also the site of investigation for the BioSorb 4. So we have also experience of implanting the Marriott, but it just also fully agree that we have all the beautiful case, and most of the patient, I think the key is still the patient selection. To select the right patient, I think they would get the most benefit. But however, we always has the enthusiasm about using the scaffold. But however, bear in mind nowadays the DSC guideline didn't remove the recommendation, the class recommendation of speaking against the routine use of the scaffold. So just want to know, rest of the panelists, apart from the studies registries, how often are you actively using the scaffold? Because I think when the guidelines were updated, then we start decreasing the use, unfortunately, because nowadays, whenever we encounter similar patients, we think that they really deserve the scaffold, but very unfortunate, we don't know where we are now. So how can we further proceed? I mean, at least there's a very strong against from at least from one of the national recommendations. I just want to know the opinion from the expert panelists. What's their opinion?
Who dare to answer this question?
Yes, may I have some comment on this?
Yes.
Yes. Actually, we also joined the BIOSOP 4, and we enroll some of cases that not complied with the enrollment criteria. So I think the patient usually come back with a target lesion failure. So my experience is I will stick to the criteria suggested on label. Use those for simple non-bifurcation lesion without any calcification. So, and I also have one patient. Although although the patient is fulfilled with the criteria of BIOSOP 4, but still come back with a target lesion failure. But that was 3 or 4 years later after BIOSOP implementation. So I don't think that's due to the scaffold per se. Maybe because of the patient's factor. So my opinion will be, if we follow the criteria, let's suggest by the BIOSOP 4 inclusion criteria, I think the results should be good, especially like the case presented by Dr. Chen. It is a single lesion in relatively young men. I think if we put the McMurray's, maybe 1 year later, it come back with very good angiography result, and we actually leave nothing behind. That's what we want.
I'm sorry. For the time's sake, perhaps I have to cut short the discussion and move on to the next presentation. It's okay. Sure. Next, I'm going to invite speaker Michael Howday to present his top presentation, the next generation resorbable magnesium 4 scaffold. Dr. Howday now is the director of medical clinic, Lucas Kang House Noise Hospital. Dr. Michael, please.
Yeah, good afternoon, and it's a real pleasure to be with you, and many thanks for the kind invitation to share with you the latest data that we have available on the most recent version of the resorbable coronary magnesium scaffold, now called DREAMS 3G. Now, if we go back to the background, and a lot of that has been said, bioresorbable scaffolds have been developed to address 3 major items. First of all, it should provide mechanical support, similar to what we are used to have with our permanent drug-eluting stents. Second, to control neointimal proliferation over the vascular healing period. And third, to prevent long-term stent-related adverse events, which are the real downside of our current drug-eluting stents. Now, the resorbable magnesium scaffolds emerged as promising technology. You heard from the 2nd generation of the drug-eluting resorbable magnesium scaffold, the DREAMS 2G with its commercial name Magmaris, that showed a low target lesion failure and scaffold thrombosis rate in multiple trials. And you heard about that in detail during the previous presentation. But, and that is what we have to recognize, the angiographic in-scaffold late lumen loss was not comparable to those late lumen loss values that we observe with historical PLLA-based scaffolds or contemporary drug-eluting stents. And this was the major driver to improve our device. Now, when we look at the next generation of the resorbable magnesium scaffold, what were the expectations that we as physicians have with a further improvement of that device in order to make it competitive to contemporary drug-eluting stents? First of all, there was a request to increase the durability of radial support while maintaining the resorption time of only 12 months. And this was obtained by the development of a new so-called BioMag backbone, which is consisting of a proprietary magnesium alloy, being different from the alloys that have been used for the previous versions. This improved device has shown significantly better mechanical properties in the benchmark preclinical tests. Further on, it still continues with the use of the BioLute coating that elutes a limous derivative for the anti-proliferation coming from a PLLA layer on top of the backbone. The second request was to reduce the strut thickness, and this could be obtained with this new BioMag backbone alloy, now bringing the strut thickness down to 99 micrometer for the 2.5 millimeter version, down to 117 micrometer for the 3.5 and 3.0 versions, while keeping it at 147 micrometer for the large one for the 4.0 device. So for the 4.0 device, I think it is not so essential to downsize the strut thickness as it is for the smaller sizes when they are implanted in smaller vessels. The third aspect that needed to be improved was the radiopacity. Although it is still a metallic backbone device, it is not radiopac. And therefore, the radiopacity of the markers had to be improved significantly, still being made out of tantalum, but they are now much, much better visible. I'm not so sure whether you can see it on the slide, but clinically, when I present the case at the end of the presentation, you will nicely see that it is now much easier to identify the ends of the scaffold for post-dilatation rather than with previous versions. And then fourth, there was a clear request for an increased size portfolio nearing to the portfolio sizes which we have for our modern drug-eluting stents. And as you can see from the table here, we are now covering devices in diameter from 2.5 to 4.0 and in lengths from 13 to 40 millimeters. So a quite nice portfolio, which now much better accommodates the need to address a single lesion with a single device. Now, when we look at the available data that we have for this latest version, which have been coming from the BioMag 1 trial, a first-in-human trial, which has been presented during an innovation late-breaking session at TCT a few weeks ago, you can see that the primary endpoint of that trial was in scaffold late lumen loss at 6 months post-procedure. So in order to show that we have improved our unmet need with the late lumen loss. Secondary endpoints were clinically driven and had to be reported at 1 month, 6 months, 12 months, and then continuously at 2 years, 3 years, 4 years, and 5 years. Again, what I can show to you today are the data that we have presented at TCT for the 6 months time point. The patients received a large bench of intercoronary imaging, which will be presented at later meetings. So now, if we look at the sites, study was conducted at 14 centers in 8 different European countries, and I personally have to thank all of the contributing centers for doing a great job. Now, try to continue. Yeah, when we look at the inclusion criteria and exclusion criteria, they are very similar to what has been used in previous first-in-human trials with the precursor devices of the resorbable magnesium scaffolds, apart from the fact that now for the first time, we in a first-in-human trial allowed to include patients with hemodynamically stable non-ST elevation myocardial infarction without angiographic evidence of thrombus at the target lesion. On this exclusion criteria list, you still find the more complex lesions like left main, CTOs, bifurcations, where from the very beginning on, you attempt a 2-device strategy. A 1-device strategy was allowed, but not a 2-device strategy. So the patient flow shows us that to the BIOMAG-1 trial, 116 patients were included with 117 lesions being treated. A large portion of that patients received additional intracoronary imaging, as I mentioned, IVUS and OCT, to get additional information on the healing process. Data will be presented at other occasions. We have a complete data set at 1 month clinically, and then at 6 months, clinical follow-up rate is 99.1%, and angiographic follow-up rate 95.7%. And with having said that, I want to share you some particular aspects on the baseline characteristics of these patients in the first-in-human trial. Please appreciate that 1 out of 5 patients presented with a non-STEMI at the time of implantation, and that we had a fairly large proportion of more complex lesions according to the AHA-ACC lesion classification class B, 2, and C, namely almost 77%. So these were not the easiest lesions to be treated. Now, coming to the primary endpoint result, which was in scaffold late lumen loss at 6 months. For the new device, the mean value was 0.21. When we compare this to the value for the precursor version, the Magmaris, it was 0.44 in the BioSolve 2 trial. So doing a post-hoc superiority analysis, this reduction of 52% in scaffold late lumen loss at 6 months was highly statistically significant in favor of the new device. Now, if we're doing the same exercise for the in segment late lumen loss at 6 months, you see the value for the new device was 0.05 on an average compared to 0.27 for Magmaris in BioSolve 2. Again, this reduction by 81% in the post-hoc superiority analysis was highly statistically significant in favor of the new device. All other angiographic parameters that we looked at were in the same direction as the primary endpoint that I showed to you. Now, looking at the clinical outcome of these patients at 6 months with the new device, target lesion failure was 0.9%, 1 single patient, because this patient developed a clinically driven TLR rate. The patient was asymptomatic, fully asymptomatic at the angiographic control at 6 months, and the device was implanted in a too small vessel, which is still a contraindication to be done. So if you look at the other criteria of target lesion failure, namely cardiac death and target vessel myocardial infarction, there was not a single case observed. And again, please appreciate that there was no single case of a definite or probable scaffold thrombosis. Now, I want to share with you one case which nicely shows what the device can do, and which is a bit in line of the case the previous speaker presented to you. This is a patient who received a proximal DES and a mid-DES in the LAD. And exactly in between, the patient now developed a stenosis at the origin of that diagonal branch. The diagonal branch was not big enough to be an exclusion criteria for putting the patient in the trial, but it's a nice challenge what is going to happen to that diagonal branch over time. And you can now see this is the pre-dilatation, lesion preparation with a non-compliant balloon to artery ratio 1:1. And the result of that pre-dilatation you can see here. This is a result good enough to fulfill the criteria to now continue with implantation of the resorbable scaffold. which now you can see here. It's a 30 millimeter long version, a longer version. And if you try to look at the markers of the balloon, you can also see the additional markers now being easily to identify the length of the scaffold, proximally as well as distally. Now then we need to do the post-dilatation. And as I mentioned, post-dilatation now is much easier to be performed correctly within the scaffold, as you now can nicely identify the markers of the scaffold and position your balloon markers within the scaffolded segment. So this is a clear improvement. You do not need imaging enhancement technologies any longer in order to identify the scaffold markers. And this is also seen over time. So this is the final results post-procedure. And please appreciate that there is no obstruction to the diagonal branch originating now from the scaffolded vessel segment. And you can also nicely see that the imaging, the intercoronary imaging, both IVUS on the left side and OCT on the right side, shows a very nice round open lumen and a very good embedding of the scaffold struts into the vessel wall. Now, if we may conclude, we can say that the DREAMS 3G demonstrates significantly lower in-scaffold late lumen loss with a mean value of 0.21 millimeter and a median of 0.13 millimeter compared to its precursor device, DREAMS 2G or Magmaris as it's called commercially, at 6 months follow-up time point, which is now on the level of contemporary drug-eluting stents. And second, it shows a very good safety and efficacy profile up to 6 months follow-up with a low target lesion failure rate and clinically driven target lesion revascularization rate, both of 0.9%. And again, please appreciate no definite or probable scaffold thrombosis. Now, having said this, which is and will be the next step now, the next step will be and has to be the creation of BIOMAG-2, a large randomized controlled trial which will compete the new device, the DREAMS 3G, against a contemporary drug-eluting stent. More than 1,700 patients are going to be planned to be included, and the primary endpoint will be target lesion failure at 12 months. And we sincerely hope that we can start this trial within the very near future. It will be a global trial, and you might anticipate that doing a global trial at the moment with all the restrictions that we are seeing is not so easy to be conducted as it was years ago. So with having said that, I would like to thank you very much for your kind invitation, and I'm more than happy to address any kind of questions. Thank you so much.
Thank you so much, Dr. Howday. Now the presentation is open for discussion. How about the comment or any question, Dr. Zazia?
So, I mean, to me, this is a good concept of performing angioplasty with leaving nothing behind. So for those who have done lots of drug-coated balloon treatment, to absorb this concept of resorbable scaffold is much easier. It's kind of trying to bargain between a drug-coated balloon and a permanent DES. So what I can say, I just need to comment that in terms of this new technology, I think the most important component in using this new treatment is the vessel preparation. As long as you stick to the 4Ps that is recommended by the manufacturers, you should get a very good result. This is also a very good lesson we actually learned from the previous PLLA bioresorbable scaffold, the Absorb. All right, the moment you prepare the lesion well, in terms of long-term outcome will definitely be better. Yes, we have a very high hope for this therapy, especially for more complex lesion. As demonstrated in the first case, it was actually a bifurcation lesion, and the second case was also a bifurcation lesion. To know that in the next 1 year there won't be any more strut crossing the side branch is very reassuring. And not only that, it also a very good place for a future bypass grafting in the mid LED segment. So I think only time will tell whether this technology will stand up and continue to progress. Particularly talking about very calcified lesion, because you know that you can actually clear the calcium intraluminally, but most of our patients, especially in this region, very high rate of diabetes and CKD, we tend to have more of medial calcification, which is a problem even for DES. Yeah, that's my comment.
Thank you. Other questions or comments from our panels?
Yes.
Dr. Holiday, okay, Cheng-I, please.
Thank you. And Holiday, great to hear so many news, and especially the good news, I think, from you. And you mentioned about the newer generation is about to reinforce the mechanical power, and but without reducing the strut thickness. And I'm because I think it's very from a standard view of the operator. I think in my previous experience is that I always appreciate that the scaffold got shrinked, but not by the experience from McMarris, but from the others. But so the radial force is one of the important thing I want very concerned. So do you think that can we say that the late lumen loss improvement in the newer generation may all contributed to the increasing radial force or new intima formation, and how much radial force it increased? I mean, when compared to the current metal stance, it is the equal the radial force or a little bit less? Thanks.
No, as I mentioned, and I was not able due to the time constraints to show you all the preclinical benchmark tests that we had done, but what we can say is that the radial force was increased by about 40%. So that is a significant increase. Nevertheless, it will not reach the level of a modern drug-eluting cobalt chromium stent. That is a different level. Let me say a little word on the calcium, which always came up several times here. If we have a significantly heavily calcified vessel, I still believe that this resorbable technology will not be a target for that kind of lesion. You will never get back vasomotion for these kind of lesions. We have drug-eluting stents which contemporarily ultra-thin strut devices can address these lesions pretty nicely. So I don't think at the moment, and also not for the randomized trial, heavily calcified lesions will be a target for resorbable technologies. But coming back to your original question, radial strength, which was the #1 expectation from our colleagues to be improved for the device, really was improved by about 40% in the benchmark trials. Transferring that to the results in the first-in-human trial, I have to tell you, I cannot differentiate it from the other contributors that are responsible for that very beneficial result, which is the antiproliferative drug, which is the selection of the patient, the selection of the lesion, a well-done implantation result. The only thing I can say is that the one and only failure case we had was a case where the device was implanted in a by far too small vessel, so significantly beyond the 2.5 level that we say, which is the lowest range to go for.
So Professor Howdy, I have a questions. So nowadays we know that using the scaffolds, we need to be very meticulous in all those 4 Ps, right? So from your point of view, do you think intravascular imaging is really mandatory when treating patients with scaffolds? I mean, the resorbable, the technology, as compared to those routine DES implantation.
Yeah, honestly speaking, I'm still a very big believer that this kind of technology will only be broadly survive or be reintroduced into our interventional technology scene if we can do it without mandatory intracoronary imaging. Nevertheless, if you get into contact with that kind of technology. During the learning phase, intercoronary imaging is very, very important in order to, first of all, re-emphasize sizing, to re-emphasize the contribution of the plaque you are treating with, to get more information, how much calcium is there, if at all, and what is the distribution of the calcium, in order to decide to use a resorbable technology in this particular lesion, yes or no. But at the end, we should find an algorithm which will allow us our regular use, at least throughout the world, where we can use it without a mandatory intercoronary imaging technology. I know that in Asia, intercoronary imaging is much more popular. It is much more performed, rather in comparison to Europe and also to the US. A lot has to be done with reimbursement aspects, etc. But I think when we really want to go globally, we have to provide a device that you can use without intercoronary imaging.
Hey, Dr. Howday. I don't recall right. I saw your case in your presentation to treat the LED mid-distal bifurcation lesion. In that case, you still use a guide extension or something to put in a stent. But you said that this new generation magnesium scaffold is thinner and has better deliverability. Could you comment on that?
Yeah, the device thickness is coming down to 1.4 millimeter, which is improved. You saw the guide extension in there. The guide extension basically was not in there for performing the procedure, rather than for performing the OCT procedure in order to get an excellent clearance of the vessel to see what we want to see. That is what I personally do very frequently if I do OCT, to use a guide extension to have a super selective contrast injection, limiting the amount and flow in order still to get very good images. So that's the way for. The procedure itself was done without. Nevertheless, I mean, it's not supported very much by the company that you should use guide extensions when needed in order to implant the resorbable magnesium device. Nevertheless, you can do that. The part what we recommend is, if you need to do that, is that you load the McMorris device to the guide extension outside of the body of the patient, and then introduce both the scaffold within the guide extension into the guiding catheter and advance it there. So that works pretty well. So you have a protected advancement there, and that is how it should be done.
Thank you. Do you feel it is comfortable to put the magnesium scaffold in the left man? Say
No.
if the lesion
No.
fits.
No, a very, very clear answer, no, because we don't want to do the same mistakes that were done with Cypher 3.5 millimeter in left mains at the early days of left main PCIs. The major reason is that the device that we have today, it is by far too small to address left mains. You see, even if we have a 4.0 device, which we can upgrade to 4.5, this is for the vast majority of left mains too small. And what we don't want to have is, with still 147 micrometer strut thickness for the larger 4.0 device, having non-embedded, non-opposed struts hanging into the left main. So that is my clear answer for that. No, not at the moment with the device portfolio that we have.
Thank you.
Michael, so Michael, it's Liwa from Hong Kong. So I enjoy your presentation very much. So I can see your presentation slide that the in-segment late loss is more promising when compared with in-stent late loss. So how do you explain this? Is it difference in the design or difference in the, you mentioned about the markers, so the post-dilatation is more easier there, so that the in-segment late loss is more pronounced. Can you comment on that?
Yeah, it's always the same aspect when you look at all available data in the QCA field. The in-segment late loss data are always better than the in-scaffold late lumen loss. That has something with the definition on how to calculate and how to measure that. So the main aspect is that when you look at into in segment, you look at the 5 millimeters proximal and distal to the device on top of that. So any kind of edge aspect that comes and contributes to a restenotic process is encountering that. On the other side, you are enlarging your vessel segment because proximally the vessel size is always getting bigger. Now, these values, when you look at the precursor data coming from the BioSolve 2, 3, and also in particular where other trials have done QCA, the in-segment values were always very good. The problem was the in-segment. In-segment, according to our feeling, according to the fact that the radial strength was not good enough for the precursor devices, was not on the level that we do see for contemporary drug-eluting stents. So that was the reason that drove us in the direction to improve that radial strength for the new device to make it more compatible to modern drug-eluting stents.
Michael, in your presentation, no scaffold thrombosis developed. So how long do antiplatelet therapy will you give the patient?
Now, the study protocol said that we should give DAPT for at least 6 months. We all are aware of the recommendation of the position paper of the ESC that states that with resorbable technologies, DAPT should be given as long as the resorption time is. So for this device, it would mean 1 year. So in reality, it was that about half of the patients received DAPT for 6 months and the other half for 1 year. Beyond 1 year, obviously, there is no necessity any longer because the device is resorbed. There's nothing left there. So nothing that could create a kind of device thrombosis.
Okay, can I have one short question?
Sure, please.
Yeah. Oh, yes. Dr. Holder, thanks very much for your excellent talk. So, so in BioSolve, we use O0 if a second stent is necessary for the rescue. So in biomed study, is it allowed to use two new generation Magnesium? And also in the first generation of Magnesium, the proximal and distal radial opaque marker sometimes is not so clear. So I'm wondering, in this new generation, is more clear to see it?
So let me answer your question. It was allowed to implant a second biomag device in the case that you have proximal or distal dissections that you need to tackle, or that your initial length anticipation or measurement was not correct, means you did not cover the whole lesion with your implanted device. Then, of course, you need to do something. And as long as it is proximal and distal, it is allowed to use a second biomag device. Now, doing it again, you have to do it as we say during the previous Magmaris version as well. You need to bring device to device. So no overlap, but just adjacent to each other. Now, with the new marker concept where you nicely can identify the scaffold ends by these new tantalum markers, it is very easy to bring that exactly to the right spot, leaving no gap between, and in particular, not having an overlap of the device. So this is a clear step forward. It was allowed to do in that way in the trial, and it was done in the trial. We have examples for that we can show you where that nicely works out.
Thank you very much.
Okay, Michael, perhaps before we close this session, perhaps I can ask you one question, which is perhaps a little bit difficult to answer. I think to me, I think for most of the interventional cardiologists, actually, the indication for your Mary's stent is overlapping with the indication for drug-eluting balloons, and the BIOTRONIK make these two. So could you comment, which do you think is the best indication for Mary's stent rather than drug-eluting balloons?
Difficult question, and it's also depending on how much time you give me to answer, but I try to make it short. There is of course overlap of indications, but what is the big difference for me? I see the indication of DCB for the smaller vessels, in particular for those where I would absolutely not attempt a resorbable device. Now, the resorbable device should go to the larger vessels. Now, if we really, for the future, want to see benefits of that technology, only the larger vessels will show us something that contributes significantly to the clinical outcome of our patients. So therefore, I think this is the major difference. I don't see, honestly, personally, an indication for a DCB in left main disease. Honestly speaking, I don't want to go back 35 to 40 years in the history of interventional cardiology, where I only had balloons which disrupted my plaque, and then I cross my fingers overnight and hope that the lesion is not going to collapse and going to occlude. So this is something you see where the benefit of a temporary scaffolding device still is, and where I would like to say the vast majority of our colleagues will not move away from. It's that aspect of early safety that a scaffolding device brings to our procedure.
Thanks a lot. Because sometimes I have to wrap this session by giving the key learning points. However, I think to me, to most of you, I think the take-home message is really simple. When you are dealing with the patients with adequate, suitable lesions, never forget there was one such stent called Magnesium Scaffold. So especially when it comes to simple lesions, comes to young people, don't deny the patient the right to put in the stent that will resolve later on, and that the vessel resume its normal function. I think that is very simple, and please bear it in mind. Next, I'm going to invite the host here, Jack Tan, and also invite Li Hua on the line for the closing remark. Jeff, please, it's your time.
I think this is everyone's favorite moment. First, it's been a long journey and a long day, but I had a fantastic interaction today with the faculty. I made some new friends, and I really want to thank all the co-directors, Dr. Lee from Taiwan, Li Hua from Hong Kong. It has been such a pleasure working with them. Very easygoing chaps, and I hope that the two countries, people can travel and we can have live meetup really very soon. I also like to thank and acknowledge the contribution from BIOTRONIK for bringing all of us together. Patrick, Ming-Fu, Lilian, all the BIOTRONIK folks who were very involved and made this organization very easy for the course co-directors. I'm sure you guys also have a very good experience here today. I will hand over the time now to Dr. Lee first.
Thank you so much. Though I'm one of the course co-director, however, I would extend my sincere appreciation to Jack Tan for having me here, and also for BIOTRONIK for bringing me here to see so many friends. Especially, I see some of you who are my friends I haven't seen for a long time. And also, I would say thanks to Jack for organizing this meeting and setting up the programs. I think a lot of presentations are very meaningful and bring up clinical issues and raise interactions between the experts and all the audience. I personally enjoyed a lot and learned a lot. I think most of us will have new learnings from this meeting. And with these updated knowledges, we can provide better service to our patients. And perhaps we can extend these knowledges to our colleagues for more sharing. Next, I'm going to invite Li Hua. You are the last one.
Thank you. So I guess all of us did enjoy the meeting very much. So it's very informative, very fruitful, cover lots of topics, including STEMI and also we most hated COVID problems. So, and also new technology, AI, mechanical surgery support, and also last but not the least, the scaffold. So we have more, new, technology coming up. So this is also the aim of this meeting, that we can come together to share our experience all over this Southeast Asia, different parts of the Asia countries. So we did enjoy the meeting very much. The only thing is still we can't have a full, physical meeting. So we can't really face-to-face and have some drink, wine, food together in the night time of the dinner. But anyway, I guess we also had the hope that we can have the physical meeting and physical contact face-to-face very soon. So I hope once again, thanks BIOTRONIK for supporting this meeting. And I hope they will support the meeting again and maybe a true physical one. So we are really looking forward to it. So last but not the least, I have to thank Dr. Lee from Taiwan. So he's very, experienced. He during our preparation works, he did mention very, minor points. He did remind us most of the points that we forget. And also Jack, he is instrumental to organize and also to have decide the topics, and also gives us the main theme and guide us through. I really enjoyed to work with them. So I'm looking forward to futures to have a further collaboration with them. So thank you very much. Jack, maybe you go for the last work.
I'm grateful for those who turned out in Singapore. So today we kept the program free. So I welcome you to see my country, which you haven't visited for a while, and enjoy yourself. Singapore is wide open. So please go anywhere you want. If you feel comfortable, you can mask off. Actually, there's no restrictions. I hope the next meeting, Liwa, can be either in Hong Kong or Taipei. So I would love to visit your country as well. And we hope to meet in live again really very soon. Thank you very much, everyone, and good evening.